So well guys, yes, anatomy is coming. Well, anatomy is coming not to terrify you. Anatomy is coming to make your life easy. Anatomy is coming to tell you it's doable, it's palatable, it's revisable, and it definitely is going to be one of your best ally in your exam. So take me seriously, but don't be scared of me. I definitely will be your best friend. Hello everyone, and good evening to all of you. Well, it's wonderful to see approximately more than 600 people live already. Well guys, people who don't know me, I am Dr. Ashwini Kumar, and I am here to, to cater you for the next few hours the subject of anatomy, and we'll try to make the subject revisable and palatable for you. Well, you must have attended the class, many of you must have attended my class, and many of you probably attended the class at different platforms. So it's just a revision session, and I'm getting a lot of requests in last few days that ye wala topic karte hain, sir, wo wala topic karte hain. So I think you should leave it to me, and let me decide that what topics are to be done. There is a animated PowerPoint which I prepared for you, as many people are still asking that whether and when we will get this PDF or this. Don't worry, the moment this class gets over, you will get the presentation, you will get the PowerPoint. I'll tell you the link also. Everything ye sari baatein hum karenge after the session. So you will get the presentation, you will get the entire PDF, annotated PDF. Kuch likhne ki zarurat nahi, you don't have to write anything. Just sit down. As I said, just take your food and water with you, and I hope you already use the washroom, and just sit down here, because we are not getting up from this chair, as I said, till the time we are finished with all the major subject revision and major revision of this anatomy part. And I have a couple of more things to tell you after the session gets over. I'll tell you about that. I have a few plans in my kitty for your exam, so that the anatomy is, as I said, is your best subject when you move and for the exam here, right? So guys, thank you so much for all the messages and all the love. I could see all my respected faculty members are also there, many of them. So good evening to everyone, and thank you for being here. So guys, without a further ado, let's get started. There's a sequence in which I have prepared this entire presentation here, so I want all of you to please pay attention to it. We have to go with a certain speed. It's a revision session, so please forgive me if you find little, if I'm going little, rapid in certain part here. Okay, and one more thing, guys, I will not be able to look too much into the chat box in between, because if I look into the chat, the many people who will get distracted here. So don't worry, your every question will be answered. That is my promise. Everything will be answered, but maybe not now in between, because that may not be the doubt for the other person here. So without further ado, let's get started. So guys, I'm gonna start the revision with the embryology part. So let's start with the embryology first. Well guys, look at this picture here. Look at this picture here. Can you just make it this full size? Full size. Okay. So guys, what picture you're looking at right now, it's an image in which it's an electron microscopic image in which you can see all the three germ layers are there. Just keep looking at the presentation. Don't look at me. Just keep listening to me and keep looking at the presentation there. So you're looking at the ectoderm, mesoderm, and the endoderm. You know the endoderm is the first germ layer to develop, and you're looking at all the three germ layers at this point of time. Now, what else you're looking at in this picture is you're looking at the green marked structure over there is the notochord. And notochord, which is developed from the axial mesoderm. This notochord, which develops from axial mesoderm, stimulates the surface ectoderm and convert it into the neuroectoderm. And that neuroectoderm will give rise to the neural tube. So that's the neural tube which you'll see above the notochord here. The neural crest cells is also derived from the ectoderm itself. Now those we call them neural crest cells because they are present at the crest. And once the neural tube is formed, they are found squeezed between the neural tube and the ectoderm. So this is probably the side where you'll see the neural crest cells here. In fact, one of the very recent question in which the neural crest cell derivatives were asked, and they put the arrow somewhere there itself here. So it was like above the neural tube and just below the ectoderm. So the junction over there is where the neural crest cells are present. Later on, they will migrate. They will come to the side and they will go migrate to the certain other areas also. But that is the place where the neural crest cells are seen initially once the neural tube is formed. Well guys, in this picture you can also see the colored part over there, where you can see the three type of mesoderm to be seen there. You can see that's a para-axial mesoderm. Neural tube is like an axis, so we have a para-axial mesoderm. Then we have an intermediate mesoderm, the one which is in between, that is intermediate mesoderm. And obviously the mesoderm which is present right on the side here, the one which is laterally placed is called as a lateral plate mesoderm. So I'm sure you are oriented to this image now. You're looking at ectoderm, endoderm, mesoderm. You're looking at a neural tube. You're looking at a notochord which stimulated the ectoderm to form the neural tube and the neural crest cells. And you're looking at the 3 part of the mesoderm. Now, let me take your attention to one specific thing in this, guys. Now, look at that. That is an intermediate mesoderm. We already said that. Now, intermediate mesoderm, इसको पहले लेते हैं, इसको अलग करते हैं. Intermediate mesoderm is something which will give rise to the urogenital system. It will basically contribute to the development of urogenital system. Not making it entirely, पूरा नहीं बना रहा, but it is contributing to the formation of urogenital system. And the major contribution of this intermediate mesoderm is giving rise to the 2 ducts, that is mesonephric duct and paramesonephric duct, which I will talk with you in the later half of this session. So that was the intermediate mesoderm. Now guys, let's remove this intermediate mesoderm and focus on the 2 other mesoderm that you're looking at, the paraaxial and the lateral plate mesoderm, because the paraaxial and the lateral plate mesoderm are very much comparable to each other. If you know the paraaxial mesoderm, you automatically know the lateral plate mesoderm. So let's see what paraaxial mesoderm and lateral plate mesoderm will give rise to. Now first the paraaxial, guys. The paraaxial, why do we call it paraaxial? Because it is along with the neural tube. Now this paraaxial mesoderm will form the ball-like condensation along the entire length, and that is called as a somites. I'm sure you all heard of the somites here. So paraaxial mesoderm is the one which will give rise to the somites, and that's how the somites will look like. Now that's a view from the dorsal aspect, from where the ectoderm is removed. Now imagine the ectoderm is removed from here. आपको बीच में दिख रहा है, that is a neural tube. That's a neural tube there. And looking at the paraaxial mesoderm on both the side, and look at those ball-like condensation. Those are called as the somites. Those are called as somites. What somites will give rise to? So paraaxial mesoderm forms the somite, that is between 20th day and 30th day. And what somites will give rise to? Somites will give rise to the axial skeleton. One is the axial skeleton. They will give rise to the dermis of back, and they will give rise to the skeletal muscle, except those skeletal muscle which are derived from the pharyngeal arches. So look at this, guys. Dermis of the back, axial skeleton, ribs, vertebrae, right? And the skeletal muscle, well, except those muscle which are derived from the pharyngeal arches, which is something we'll discuss separately. Now, if you know what are the derivatives of somite, that means you know the derivatives of paraaxial mesoderm. You already know what are the derivative of lateral plate mesoderm. जो यहाँ नहीं बना, वो यहाँ बनेगा. Whatever is not formed from the somite or paraaxial mesoderm will be formed from the lateral plate mesoderm. But look at one thing, guys. Can you see the lateral plate mesoderm is dividing in 2 parts? There is a coelom in between. Now there is a formation of a coelom called as an intraembryonic coelom, and that intraembryonic coelom divides the lateral plate mesoderm in 2 parts. One is called as a somatopleuric layer. The one which is above is somatic. जो ectoderm के साथ होगा, that is somatic. So we have a somatopleuric lateral plate mesoderm, and the one below is planchnopleuric lateral plate mesoderm. The word somatic is for the body wall. So the one which is with the ectoderm is called as somatic lateral plate mesoderm, or you can say somatopleuric lateral plate mesoderm. And then we have a planchnopleuric lateral plate mesoderm, which is with the endoderm, the one which is below. So you can see coelom in between here. Well, somatopleuric and planchnopleuric lateral plate mesoderm. Now you already know what should be derived from lateral plate mesoderm. Now if you look at that list over there, so that means what should be derived from lateral plate mesoderm? It should be the dermis of the front, it should be the dermis of the limbs, it should be the appendicular skeleton, smooth and cardiac muscle. Now we already know the list, whatever is not derived from here, but we still have to divide this, that what is from somatopleuric and what is from planchnopleuric, guys. So obviously the word somato is for the body wall. So somatopleuric lateral plate mesoderm will give rise to the dermis of the front and limbs, ventral body wall and limbs ka dermis, and it will also give rise to the appendicular skeleton. Upper limb bones and lower limb bones will be derived from the somatopleuric lateral plate mesoderm. And obviously the word splanchnic, when you hear the word splanchnic, the viscera comes to your mind. The splanchnic is viscera. So which muscle are related to viscera? It's about the smooth muscle and the cardiac muscle. Though we have some exceptions in smooth muscle, but let's go with the general thing first. Majority of the smooth muscles will be coming from the planchnopleuric lateral plate mesoderm and the cardiac muscles also. But yes, cardiac muscles are derived from the planchnopleuric lateral plate mesoderm at the cranial end of the embryo. अब हर जगह तो cardiac muscle बन नहीं जाएंगी, so there is a specific area that is at the cranial end of the embryo where the cardiac muscles are formed from the planchnopleuric lateral plate mesoderm. So this is what you're looking at, guys. Right now we already saw the intermediate mesoderm, and now you're looking at the paraaxial and the lateral plate mesoderm. And as I said, this list is very easily comparable, Okay, now moving on, let's come back to the neural tube and the neural crest cells. Now we saw the derivatives of the mesoderm here. Now if I focus on to the neural tube and the neural crest cells, guys, and notochord also. See, notochord itself is made up of axial mesoderm. But the function of notochord is to stimulate the ectoderm and form the neuroectoderm. So neural tube बनाई notochord की वजह से. But what will be the fate of notochord? Notochord basically will vanish. So notochord will vanish, and notochord will only have some remnants, and those remnants of notochord in us, we have like nucleus pulposus, the one which is like the commonly asked question, nucleus pulposus. There is a ligament called as the apical ligament of Dens. Odontoid process का ligament होता है, apical ligament of Dens, and membrana tectoria, or simply tectorial membrane, which is basically present between the atlas and the occipital bone. So nucleus pulposus, apical ligament of Dens, and there is a membrane which is a continuation of posterior longitudinal ligament called as a membrana tectoria or tectorial membrane. These are the remnants of the notochord. What about neural tube and neural crest cells? Well, neural tube, the moment you think of neural tube, think of central nervous system. So neural tube is going to give rise to the central nervous system. Neural tube, and when you think of central nervous system, think of all the components of CNS, guys, like brain and spinal cord. Well, the cells which will do the myelination for CNS, the lining of the ventricle, the retina. So all these are basically derived from the neural tube. Just have a look at that list, guys. The brain and spinal cord, well, obviously that's about CNS here. The oligodendrocytes doing myelination for CNS. Astrocytes forming blood-brain barrier, ependymal cells, that is a ventricular lining epithelium, obviously CNS के अंदर ही होगा. Retinal and even retinal pigment also. Retinal pigment also. Like, so retina we say na, optic nerve and retina is extension of the brain only. It's an extension of diencephalon only. So that is all about central nervous system. So the moment they ask you the question on the neural tube components, think of central nervous system. Bas. If it is related to CNS, it is all about neural tube. Neural crest cells. Now, the neural crest cell is also called as a fourth germ layer. It is giving rise to so many structures that nowadays we even call as a fourth germ layer as well. Now, guys, the neural crest cells are actually have two types of derivative. Now, certain derivatives are neural derivatives. By origin to neuroectoderm se hai na. So some derivatives are neural derivatives and some derivatives are mesenchymal derivative. Now, when you say neural derivatives, you have to think about only the peripheral nervous system. Look at that list. Now look at the first three things over there, guys. All ganglion, enteric plexus, Schwann cells. Now does it give you an indication of all just the peripheral nervous system? Ganglion. अब ganglion होते ही peripheral nervous system के अंदर है. Whatever ganglion you think of, trigeminal ganglion, geniculate ganglion, dorsal root ganglia, sympathetic chain, any parasympathetic ganglion. If the word ganglion comes to your mind, it is obviously the part of peripheral nervous system and it is derived from neural crest cells. Enteric plexus, myenteric plexus, Meissner's plexus, Orbex. You all people read about the plexuses. All these plexuses are made up of nerves, and obviously they are made up of peripheral nerves coming from neural crest cells. Even the nerves of pharyngeal arches, one of the neat question only, guys. Nerves of pharyngeal arches are derived from where? No, nothing special. They are also derived from the neural crest cell. Any nerve is derived from neural crest cell only. Schwann cells doing myelination for peripheral nerves coming from neural crest cells. Adrenal medulla, guys. Adrenal cortex is derived from the intermediate mesoderm. In the adrenal gland, the adrenal cortex is derived from the intermediate mesoderm, but the adrenal medulla is derived from the neural crest cells. Parafollicular C cells. Now this is sometime you must have read somewhere it is written ultimo branchial body gives rise to the parafollicular C cells, which is not true. It's the neural crest cells which will giving rise to the parafollicular C cells in the thyroid gland. Melanoblast and melanocyte, pigment epithelium. The moment you think of pigment epithelium, except the retinal pigment, all pigment epithelium are coming from the neural crest cells. All pigment epithelium are from the neural crest cells only. And then, if you look at the structure which I marked in the white color there, guys, majority of the structures, the mesenchymal structures in head and neck, जो कि बाकी बॉडी के अंदर mesoderm से derived है, in head and neck, most of them, I'm not saying all of them, there are definitely exceptions in that, but most of them are derived from neural crest cells. Just think about it, like if you think of a bone, skull bone, then you will obviously compare with the bone of the rest of the body. Abhi bone in the rest of the body is coming from mesoderm, but majority of the skull bone, except the occipital and sphenoid bone, they are coming from where? Neural crest cell. Dermis of the rest of the body, we just discussed, dermis is derived from the mesoderm, but here the dermis of the head and neck is derived from the neural crest cells. Cartilage, just like bone, cartilage, dentine. So all these structures in head and neck, whenever you look at these structures and your brain says ki yaar, this should be derived from the mesoderm, so most of the time answer actually neural crest cell hota hai, because mesenchyme of the head and neck is derived from the neural crest cell itself here. And there is one important septum which I wrote there, that is a conotruncal septum, which is a septum which is dividing the actually cranial part of the heart tube. It is dividing something called as a conus and truncus arteriosus, so we call it a conotruncal septum. Okay. So guys, this is about the neural crest cells derivative and about the derivatives of neural tube. So at least you can eliminate some options when you keep that in mind, that CNS is about the neural tube and peripheral nervous system is all about the neural crest cells. Chali guys, moving on. Now this is something about the discussion on the general part. Now let me take you to some important topics in the systemic part as well. Now let me start with the development of the diaphragm first. Now this is one of the picture image based question asked in the exam about the development of diaphragm. Now even if you know the components of the diaphragm here, you have to identify them on the picture. Now in this developing diaphragm picture, look at this A, B, C and D, where A actually is a body wall mesoderm. Either you say cervical myotome or body wall mesoderm, and this is something which will give rise to the muscular part of the diaphragm here. The body wall mesoderm will give rise to the muscular part. Now important thing is image mein identify karna guys, that is present more toward the posterior lateral side. That's body wall mesoderm invading from that side here. The muscles will be formed from that area here. Then look at B, dorsal mesentery of esophagus. Now generally we don't talk about the mesentery of esophagus, we talk about mesentery of the stomach. Lesser omentum, greater omentum, mesentery of the small intestine, mesocolon, mesoappendix. But हम generally esophagus की mesentery की बात नहीं करते. There was a time when there was a mesentery of esophagus also, but that dorsal mesentery of esophagus is used or utilized or absorbed to form the crus of the diaphragm or crura of the diaphragm. Look at C, the one which is placed most anteriorly here, that is called as a septum transversum. Now just to tell you little guys, what is septum transversum? It is an undivided or undifferentiated lateral plate mesoderm towards the cranial end of the embryo. The lateral plate mesoderm that we saw, uske andar coelom tha. There was a somatopluriclair, splanchnopluriclair, there was a coelom in between. Now if you take the same lateral plate mesoderm toward the cranial end of the embryo, so there is an area where at the cranial end of the embryo where there is no coelom in that lateral plate mesoderm. That is called a septum transversum. So that's a very important structure. Septum transversum gives rise to the central tendon of the diaphragm. It gives rise to fibrous pericardium, liver, stroma and all. So central tendon is derived from septum transversum. In the developing, don't be surprised that central tendon to beech mein hona chahiye. Well, it is in front because septum transversum came from above guys. In the craniocaudal folding, septum transversum came here and then it got absorbed inside and then later on the central tendon will go to the center. तो सबसे आगे जो आपको दिखेगा, the one that you will see most anteriorly here is the septum transversum, giving rise to the central tendon. And then look at the dark pink thing over there which is marked as D. Well, that's a membrane which is formed. Initially there is a canal called as a pleuroperitoneal canal and then that canal is bridged by the membrane called as a pleuroperitoneal membrane. Now, this pleuroperitoneal membrane will be invaded by the muscles only. The muscles which are derived from the body wall mesoderm, वही muscle आके इसके अंदर invade कर जाएंगी. So it is actually invaded by the muscle or incorporated by the muscle. If it is not incorporated by the muscle, then there's a different condition. Now, first of all, let's take a condition, guys. Let's say the pleuroperitoneal membrane is not formed. Bana hi nahi. If the pleuroperitoneal membrane is not formed, then there is a canal called as a pleuroperitoneal canal. Obviously, in this area here, you will see a canal there, and that canal will be called as a pleuroperitoneal canal, forming a direct communication between the abdominal and the the abdominal cavity and the pleural cavity, this thoracic cavity here, and that will allow the intestine to herniate above, and that lead to the congenital diaphragmatic hernia. So congenital diaphragmatic hernia is when the pleuroperitoneal membrane is not formed. The opening hai, pleuroperitoneal canal persists. Persistence of the pleuroperitoneal canal here. It's more common toward the left side, and obviously if the intestine will herniate toward the left side, they can cause the lung hypoplasia, also the left lung hypoplasia as well. Then we got another condition. Pleuroperitoneal membrane is formed. Bana to hai. Pleuroperitoneal membrane is there, but that membrane is not invaded by the muscle. We said muscles will incorporate inside. If the muscles will not incorporate inside, if this pleuroperitoneal membrane is not incorporated by the muscle, or if it is not not converted into the muscle here, then what will happen? Then obviously again there is a very thin membrane will be there which will be separating the abdominal cavity. And that membrane is not good enough to stop the content of abdominal cavity to herniate above. Though it is not a true hernia, now that is called as an eventration of the diaphragm. That is called as an eventration of the diaphragm, which is similar to the CDH, congenital diaphragmatic hernia, but it is not a true hernia. It's not a true hernia. Look at this picture, guys. If you look at the abdominal content over there, look at the intestine, the colon in there, and look at the thoracic cavity, and they are herniating above. They are pushing the lung above. They can also cause lung hypoplasia, but you can see a very thin membrane is present in between them. So it's not a true hernia. There is something in between, but that membrane is not good enough to stop these structures here, and that is called as an eventration of the diaphragm. That is an eventration of the diaphragm. Okay, chalo guys, moving on. From here, let's move on to this one very next very important thing, guys. And well, in the entire embryology, looking at the current scenario in the past few years, if I have to mark one most important topic, it goes without saying the pharyngeal arches. Now they probably asking pharyngeal arches question in every exam, whether it's NEET exam or INI-CET, the pharyngeal arches are probably their favorite here. Now look at this section, guys, and if you look at that embryo over there, so if you take a section through the pharyngeal arches over there, if you take an axial section at that level here, now that's how the pharyngeal arches will look like. It's just a close-in view of the same thing only. It's a cross section dikh raha hai aapko. Now obviously pharyngeal arches in the core, in the center, we do have a mesoderm. Now we do have an ectoderm on the outside and endoderm on inside. That's the definition of pharyngeal arch. These are the cylindrical thickening of the mesoderm, having endoderm on the inner side, and we have an ectoderm on the outside. Now on the outside, the spaces between the pharyngeal arches are called as clefts. So clefts are ectodermal. I don't have to say that clefts are ectodermal hai, and the spaces inside the endodermal side, they are called as pouches. So all the pouches are endodermal. So that is just to tell you that how the pharyngeal arch look like. So we have all the three things. We have endoderm, ectoderm, mesoderm is there, and the space in the ectoderm is called as cleft, and the spaces in the endoderm are called as the pouches. Okay. Now, what are the fate of these clefts and pouches? So let's use some schematic picture to understand this. Now have a look at this image, guys. Now what you see over there, if you look at all these are cleft, look at this green color thing, all these are the clefts, and all this in the red over there, they're all pouches here. Now what you see, the second pharyngeal arch, now there is a growth of the second pharyngeal arch which will push this ectoderm also, will go down and join with the caudal pharyngeal complex, and because of this growth of the second pharyngeal arch, jitne bhi cleft hain, all these clefts now obliterated. The second cleft, third cleft, fourth cleft, all these clefts are now obliterated. Ek hi cleft bacha, first cleft. As you can see over there, all the clefts are obliterated. Now this ectodermal lined embryological space is called as cervical sinus. It's called a cervical sinus as it is mentioned there. Now this cervical sinus usually disappears, but if the cervical sinus persists, if there is a persistence of the cervical sinus, that can give rise to the branchial cyst. You all read about the branchial cyst. Usually these are the painless, harmless swelling which are seen along the sternocleidomastoid, and most of the time the patient get rid of these branchial cysts for the cosmetic reason. They are not problematic unless they are causing any kind of fistula inside or outside. So that's the branchial cyst. If the question is asked, branchial cyst is nothing but the persistent cervical sinus. So ये तो मिला हमें second, third and fourth cleft से. That's obliterated cleft. If some remnant is there, that can give rise to the branchial cyst. So the only cleft remains here is the first cleft. And what first cleft will give rise to, guys? The first cleft, which is the only cleft left, will give rise. Now look at the entire head and neck. यार एक ही opening है side में. External auditory canal, so that will give rise to the external auditory canal and the outer layer of tympanic membrane. It contributes to the external auditory canal and the outer layer of tympanic membrane. Well, that's about the cleft. Cleft mein zyada kuch hai nahi, guys. The first cleft, and that's the first cleft that will give rise to, and rest all the clefts will get obliterated. Okay. Now moving on to the pouches. Now let me just take another schematic picture here. Now this time I want you people to focus on the pouches, guys. Please look at the pouches there. First pouch, second, third, fourth pouch mentioned inside. The first pouch, what first pouch will give rise to? Now you can take a hint from the cleft. If the first cleft gave rise to the external auditory canal and outer layer of tympanic membrane, so first pouch will give rise to the inner layer of tympanic membrane, middle ear cavity, the eustachian tube, and the mastoid antrum also. The lining epithelium of all of these, tympanic cavity ka ho, tympanic membrane ka inner lining epithelium, auditory tube, mastoid antrum, they are all made up of the endoderm, and they are all made up of the first pouch. Pouch is endodermal. I don't have to say that again. Pouch means endodermal. Second pouch, guys. What second pouch will give rise to? Palatine tonsil, and strictly speaking, it will only give rise to the lining epithelium of the palatine tonsil. Palatine tonsil, that to the lining epithelium of the palatine tonsil. Third pouch, on the other hand, will give rise to the, that's very, very important, and twice it is asked as an image-based question. It gives rise to the thymus and inferior parathyroid gland. Inferior parathyroid gland thymus के साथ develop होगा. Later on it will migrate below and come below. So though it is inferior, but it develops above the superior. That's third pouch giving rise to the thymus and inferior parathyroid. And then we have the fourth pouch. You get that fourth pouch over there, which will give rise to the superior parathyroid gland. Now guys, we don't have fifth pouch, but we do have a remnant of fifth pouch which are residing with fourth only. But एक time था ना जब fifth arch भी था, when fifth arch was there, so there is an additional pouch also there, and that fifth pouch is not there. We just have the remnant of fifth pouch, which is called as the ultimobranchial body. Look at the name, ultimobranchial body, such a nice fancy name. Ultimobranchial body because it's the ultimate structure of branchial arches. It's the last thing to develop from branchial arch, so we call it the ultimobranchial body. This fourth pouch and fifth pouch together इनको caudal pharyngeal complex ही बोलते हैं. There's term given to them. They call them caudal pharyngeal complex. Now, A patient with absent thymus, like the question I'm coming to, the one which was asked, the patient with absent thymus and hypoparathyroidism is because of which pouch? Well, it's mainly a third pouch anomaly. Though it's a third and fourth pouch both, but if you have to choose between one, you have to obviously go with the third pouch anomaly here. And that's one of the most common microdeletion syndrome, guys, the DiGeorge syndrome. I'm sure you all read about that here. So in DiGeorge syndrome, the patient is having absent thymus, there is no thymus, and hypoparathyroidism along with other features here. And the question asked was, they gave the picture of the pharyngeal arches and the different pouches were given over there, and the question was absent thymus and hypoparathyroidism is because of the anomaly of which arch or pouch. Then the best answer here would be the third pouch. You got to go with the third pouch in that case. Okay, moving on. The next, guys, pharyngeal arch arteries. अब pharyngeal arches की बात कर ही रहे हैं, तो let's shift to the pharyngeal arch arteries here. Now first let me just give you a little orientation about this picture here. उसके बाद फिर हम शुरू करते हैं. Now I want all of you to look at this screen here with me, guys. See, in this picture what you're looking at right now, all these are the pharyngeal arch arteries here. Now first look at this dorsal aorta here. This one is one dorsal aorta looking at here. That's another dorsal aorta. Let me use this picture actually here. This is the dorsal aorta here. That's a left dorsal aorta, and that one is a right dorsal aorta. So initially we have two dorsal aortas there. And these dorsal aorta are connected with the aortic sac. Aortic sac is in front, like developing heart is there, and we have an aortic sac which will give rise to ascending aorta and pulmonary trunk. And that aortic sac over there, look at this aortic sac is going to divide in two parts. One part obviously will be ascending aorta and other part will be the pulmonary trunk. Now this aortic sac will be connected to the dorsal aorta of the left side as well as right side by how many? 6 pharyngeal arch arteries. But for the discussion sake, हम सिर्फ 3 ले रहे हैं यहाँ पर. The third arch artery, the fourth arch artery, and the sixth arch artery. Fifth को तो भूल ही जाओ, fifth will disappear anyways. So we are looking at the third arch artery, fourth arch artery, and the sixth arch artery here. Now please look at the first picture, guys. All of you want to do just focus on the first image there. If you look at the first picture, it tells you that arch of aorta is derived from what? Arch of aorta is derived from, first of all, aortic sac तो हो गई. One is aortic sac. Then obviously arch of aorta has to go toward which side? Left side. So it's a left horn of aortic sac. Then left fourth arch artery, left side का fourth arch artery, and then left dorsal aorta. Left dorsal aorta का ज़्यादा contribution नहीं है. So if you just stick to these three here, we have the aortic sac, number one, left horn of aortic sac, and that is a left fourth arch artery. Left fourth arch artery. These are the components of the arch of aorta. Am I clear or not, guys? Aortic sac, left horn of aortic sac, left fourth arch artery is giving rise to the arch of aorta. Arch बन गया. Coming to descending aorta now. उसके आगे continue करते हैं. Now see, descending aorta, if this still here, if it is arch of aorta, now descending aorta is by what, guys? Descending aorta is by what? That is a left dorsal aorta. Now not only left dorsal aorta, the fused portion of both the dorsal aorta as well. When both these dorsal aorta, they fuse in the lower part, that also is required. So descending aorta is by the left dorsal aorta as well as a fused dorsal aorta in the caudal part. Now look at the branches of arch of aorta. The first branch of arch of aorta you can see over there is this one, the one which is shown with that. Well, obviously which artery needs to go toward the right side? The brachiocephalic artery. Once the brachiocephalic artery will go toward the right side, then only it can divide into common carotid and subclavian. So that is simply the horn. Which horn? Obviously किधर जाना है आपको? Right side. Right horn of aortic sac. Just the right horn of aortic sac is required for the formation of the brachiocephalic trunk or brachiocephalic artery. That's the right horn of aortic sac. We got the arch of aorta, we got the descending aorta, we got the brachiocephalic artery. Moving on. Now, look at this, guys. Look at the artery, which is one of the very frequently asked questions from the pharyngeal arteries here, guys. Now, you're looking at the two subclavian artery, guys. Now, you know that one subclavian, the left subclavian artery is a direct branch of the aorta. Look at that. That's a subclavian artery directly aorta se aa raha hai. And that subclavian artery over there, this one here, the right subclavian artery, obviously will be coming from the brachiocephalic trunk. That will be coming from brachiocephalic trunk. So, if you talk about the left subclavian artery, बहुत simple है. It is by the left 7th cervical intersegmental artery. Now there is a intersegmental arteries are there, and I'm talking about specifically one of them called as the left 7th cervical intersegmental artery, which will give rise to the left subclavian artery. Just one thing is required, done. But you cannot have the same thing on the side because 7th cervical intersegmental artery के साथ साथ what else is needed? You need the connection with the brachiocephalic trunk, and that is coming from which arch artery? The fourth arch artery. On the left side, the fourth arch artery was forming the arch of aorta. On the right side, the fourth arch artery will contribute to the subclavian artery, and that's why the right subclavian artery is derived from right fourth arch artery and then 7th cervical intersegmental artery also. That's very, very important to understand the normal development first before you understand this abnormality. Now, that's a normal subclavian artery, guys. All of you, I want all of you to pay attention to this part. It's a very potential question which is asked earlier also. Now that's a normal right subclavian artery. Now let's consider a situation when the fourth arch artery of this side is obliterated. लीजिए, the fourth arch artery of this side is obliterated. अब ये तो बचा नहीं, fourth arch artery is not there, so you cannot have the subclavian artery coming from the brachiocephalic trunk. That is not the option now because the fourth arch artery is obliterated. In that case, there will be persistence of this part. Can you see that over there? That is what? That is a caudal part, or you can say the lower part of right dorsal aorta. So the blood will come from here, and then it will join with the seventh cervical intersegmental artery, and that's how the abnormal subclavian artery will form. Now I want to look at the screen. That's how it is going to happen here. That is the persistence of, look at that artery, guys. That artery will persist here, and that will give rise to the subclavian artery, the right subclavian artery. Well, this absolutely, you're right, guys. Why we call it a abnormal? First thing is, obliteration is very important to say. If there is no obliteration of the fourth arch artery and there is a persistence of this, दो arch of aorta आ जाएंगे. Then there's a double arch of aorta. If there is an obliteration of the fourth arch artery of the right side and there is a persistence of this dorsal aorta, the caudal part of right dorsal aorta, then it will give rise to the abnormal right subclavian artery. And yes, you rightly said, guys, the reason we call it abnormal right subclavian artery because it is coming from the aorta. Aorta is on the left side. We are talking about right subclavian artery. It will compress the esophagus and will cause dysphagia lusoria. Look at that. Look at that picture over there. That's the subclavian artery of the right side. Esophagus के पीछे से होके जा रहा है. It is compressing the esophagus, causing dysphagia. In extreme cases, can cause dyspnea also. That's the abnormal right subclavian artery. Okay. Now, coming to, we already justified the arch of aorta, the branch brachiocephalic artery, subclavian artery. Okay, now come to common carotid, guys. Now look at this first part, the first image there. What you see, that common carotid artery is derived from the proximal part of third arch artery. Just the proximal part of third arch artery is required to form the common carotid artery. And then, if you look at this, the distal part of third arch artery and the cervical part, or you can say the cranial part of dorsal aorta, दोनों मिलके बनाएंगे internal carotid. Common carotid will continue as internal carotid only. So the distal part of the third arch artery, that look at that color over there, distal part of third arch artery and the cervical part of dorsal aorta, or you can say cranial part of dorsal aorta, will give rise to internal carotid, will give rise to the internal carotid. External carotid, don't bother. External carotid will just come out as a bud on the third arch artery. External carotid artery will emerge as a bud on the third arch artery. Okay. Now, coming to the sixth arch artery, guys. Fifth arch, fifth arch will disappear. Now, sixth arch artery, look at the first picture, guys. If you look at the first picture, first of all, aortic sac. Let me take you back to the aortic sac. We said aortic sac will give rise to two things. Aortic sac gave rise to ascending aorta, done. Now, a part of the aortic sac is also giving rise to the pulmonary trunk. So, pulmonary trunk to ban gaya aortic sac se. But what about the two pulmonary arteries? The pulmonary arteries are derived from the proximal part of the sixth arch artery. Mind it, proximal distal बहुत important है यहाँ पर. Proximal part of the sixth arch artery will give rise to the pulmonary artery. Distal part of the right sixth arch artery will disappear. कुछ नहीं बचेगा इसका. But the distal part of the left sixth arch artery, as you can see in this picture, will persist. And you all know that is nothing but the ductus arteriosus. That is ductus arteriosus found by the distal part of the left sixth arch artery. Distal part of left sixth arch artery. Now see, this also tells me about the recurrent laryngeal nerve, guys. That also was one of the questions asked about the recurrent laryngeal nerve. Right side का छोटा होता है, left side का लंबा है. The reason is, see, if you look at the recurrent laryngeal nerve on this side, initially it was going below the distal part of the sixth arch artery, and the left recurrent laryngeal nerve is also going below the distal part of sixth arch artery. अभी distal part of the right sixth arch artery तो disappear हो गया, तो recurrent laryngeal nerve will come above and will hook below the fourth arch artery, and you know fourth arch artery will give rise to subclavian, and that's why the right recurrent laryngeal nerve is present or is basically winding below the right subclavian artery. But that's not the case on this side. On this side we have a ductus arteriosus, which in later life will persist as ligamentum arteriosum. So that nerve never got a chance to go above, and that still hooks below the whatever the remnant or derivative we have of the distal part of sixth arch artery, and that's why you see the left recurrent laryngeal nerve longer. It is below the arch of aorta. It is passing under the ligamentum arteriosum. So just quickly go through that line here. It says left recurrent laryngeal nerve has a longer course than the right recurrent laryngeal nerve. This is because it hooks under the left sixth arch artery, which persists in extrauterine life also. Okay. But please don't spam the group, my dear. Whatever your issue is, it will not be resolved by posting the same message multiple times. So I know that there are many people. The time is precious. I know that the people who are watching this video, they are exam going. उनके लिए बहुत important session. I really do not want to waste time even just by talking anything in between. That's why don't spam the group. That's my request to you. Chalo guys, let's carry on. Now that was just you'll find this in your PDF also. This is just overall what we discussed here. So all the arteries and adult derivatives are given, and we already discussed about the development of these arch arteries. Now the question which was asked in the recent exam was, it was kind of match the following kind of question where you have to compare the pharyngeal arch with the respective artery. Now we did not talk about the first and second arch. Fifth arch sort of disappear hi ho gaya. But first and second arch will give rise to something. Well guys, first arch, the remnant of the first arch is the maxillary artery. The first arch remnant is the maxillary artery, though it is the largest branch of external carotid, but it's just a remnant of the first arch artery only. And second arch artery will give rise to the stapedial and hyoid artery. Now look at this chart. I hope this makes sense, guys. The first arch, maxillary artery, transient, remnant only. Second arch artery, hyoid and stapedial. Third arch artery was giving rise to common carotid, and the distal part was forming internal carotid. Fourth arch, on the left side forming the arch of aorta, but on the right side it is forming the subclavian artery. Fifth arch degenerates, forget about it. And sixth arch, we already said, sixth arch will give rise to the pulmonary artery, but on the left side it is also giving rise to the ductus arteriosus, as well. Thank you, Vishwit sir. I'm sorry, I'm sure there must be other faculties also, but I'm not able to scroll through the message, so I'll just keep going. Chalo guys, so that was about the pharyngeal arches. No matter what, chhodna nahi is topic of pharyngeal arches, the derivative of pharyngeal arches, everything about pharyngeal arch is important. So just make sure you from the anatomy part and the embryology, you got to go through this part very well. Chalo guys, quickly moving on. That's another question which was a last year neat question actually. The question was about the derivative of the where the falciform ligament is derived from. It was an image based question. Now first I wanted to understand and just let's keep it from the exam perspective, guys. Now imagine I'm standing like in front of you like this. Now if I am a gastrum here, mere aage wala sab kya hai? Ventral mesogastrium, and sab kuch piche jo, that is dorsal mesogastrium. So that's a ventral and that's a dorsal mesogastrium here. So if this is a stomach here, it's all ventral. Ventral is in front. Gastrium, stomach ke aage, ventral mesogastrium. This is all ventral mesogastrium, and everything behind the stomach is dorsal mesogastrium. In the ventral mesogastrium, the liver will develop. In the dorsal mesogastrium, spleen will develop. Let's take it nice and easy, guys. Ventral mesogastrium, liver will develop. Dorsal mesogastrium, piche ki taraf, the spleen will develop here. Now, if this is a liver, what is connecting the liver to anterior abdominal wall? What is connecting the liver to anterior abdominal wall? Falciform ligament. So that means this part of the ventral mesogastrium will give rise to falciform ligament. What is connecting the liver to the stomach? What is connecting the liver to stomach? What connects liver to the stomach? Lesser omentum. That means this part of the ventral mesogastrium will give rise to the lesser omentum. And then obviously it is surrounding the liver also. So whatever ligament we have of the liver, coronary ligaments, triangular ligaments, they're all also derivatives of ventral mesogastrium. So you have to think about ki stomach ke aage liver is developing in front of the stomach in the ventral mesogastrium. So all the ligament connecting the abdominal wall to the liver and connecting the liver to the stomach, they are all derivatives of the ventral mesogastrium. Look at that, triangular ligaments, coronary ligaments, falciform ligament, lesser omentum, all derivatives of the ventral mesogastrium. Simple, nothing. Dorsal mesogastrium, guys. Look at the greater curvature. If this is a greater curvature here, if I go beyond the greater curvature toward the posterior wall. Now first of all, greater curvature पे कौन सा omentum होगा? Greater omentum. Then fundus of the stomach will be connected above to the diaphragm, that is called as the gastrophrenic ligament. To the diaphragm, gastrophrenic ligament. Then stomach is connected to spleen, that is gastrosplenic ligament. And spleen is connected to the kidney on the posterior abdominal wall, that is a lenorenal, or you can say splenorenal ligament. Lenorenal or splenorenal ligament, and they are all derivatives of dorsal mesogastrium. Just say the derivatives of all the dorsal mesogastrium in your head. The derivatives of dorsal mesogastrium will be greater omentum, gastrophrenic ligament, gastrosplenic ligament, and lenorenal, or you can say the splenorenal ligament. All these are the derivatives of the dorsal mesogastrium. So last year it was a question on the falciform ligament. Well, you never know. Next time they might ask you falciform ligament or maybe the lesser omentum or greater omentum. Just think about ventral and dorsal mesogastrium, liver in the ventral and spleen in the dorsal mesogastrium, and then you can easily think of कि कौन-कौन से ligament उनके अंदर develop होंगे. Okay. चलो guys, moving on. One more thing in the embryology before we switch on to the next topic, otherwise embryo करते रह जाएंगे. Well guys, one thing which we kind of left in the beginning only, that was the intermediate mesoderm. Now intermediate mesoderm, we said it will give rise to the urogenital system. That's what it is. Now intermediate mesoderm will give rise to all these. We already said it will give rise to the mesonephric duct, it will give rise to the genital ridge and paramesonephric duct. Now guys, this genital ridge, the genital ridge will give rise to the gonads. Testis and ovary will develop from the genital ridge. And mesonephric duct and paramesonephric duct we need to discuss here. So first genital ridge करते हैं. Genital ridge will give rise to gonads. Now first the mesonephric duct, which is also called as a Wolffian duct. Guys, there are common derivatives of mesonephric duct in male and female. Like mesonephric duct, first of all, it will give rise to one of the things which is derived from the mesonephric duct is a posterior wall of urethra. Posterior wall of female urethra also, posterior wall of male urethra also, but male urethra only till the ejaculatory ducts. But common to hai, posterior wall of urethra, it is still ejaculatory ducts only. Then ureteric bud and derivatives. Now ureteric bud is derived from mesonephric duct only. Ureteric bud is something which will give rise to the entire collecting portion of kidney. The entire collecting portion of kidney. Kuch bhi, collecting duct, renal papillae, major minor calyces, renal pelvis, ureter, they're all derived from ureteric bud. So all the ureteric bud and the derivative, ureteric bud and derivative. Till here common. Then trigone. Mesonephric duct get absorbed in the urogenital sinus and will give rise to a trigone in male also and female also. So यहाँ तक तो common है. Mesonephric duct is required for both male and female. But from this point onwards, I would say mesonephric duct is more important, or it's like it is giving rise to more structures in case of male, because mesonephric duct will give rise to the entire spermatic pathway, whatever it is in the spermatic pathway, guys. Vas deferens, ejaculatory duct, seminal vesicle, epididymis, appendix of epididymis, even the remnant also. So entire spermatic pathway. The moment you think of spermatic pathway, think of mesonephric duct. Female, then obviously we only have the remnant there, and the remnant in the female of the mesonephric duct, which also is a recent question only, that is the duct of epiphoron, which is famously called as a Gartner's duct. Now guys, it is the Gartner's duct we are talking about, not the Gartner's cyst. Look here, Gartner's cyst is present in the upper vaginal wall. Bartholin cyst in the lower vaginal wall, Gartner's cyst in the upper vaginal wall. Gartner's duct का अगर location पूछा है, do not make a mistake in this. It is derived, or it is present where? In the broad ligament. It is present between the two layers of broad ligament. So Gartner, just be careful, read the question carefully, whether it is a Gartner's duct location or Gartner's cyst location. Duct is present between the two layers of broad ligament. Exactly, the duct of epiphoron. Okay. Now paramesonephric duct, guys. Paramesonephric duct or Mullerian duct. Well, paramesonephric duct is main duct for female. Now it is giving rise to the fallopian tube, the uterus, upper part of vaginal wall, vaginal fornices. So that is all in female is derived from the paramesonephric duct. So obviously male के case में खाली remnants होंगे, कुछ homologous organs होंगे. So in case of male, we have the appendix of testis. And be careful, it's appendix of epididymis from the mesonephric duct. That is appendix of testis, I'm saying. Appendix of testis and prostatic utricle. Prostatic utricle, which is also called as a masculine vagina. It is a small diverticulum which is present in the prostatic urethra, guys. Blind diverticulum goes for a few centimeters and it's blind only. So that prostatic utricle basically corresponds to the vagina. It's a homologous organ to vagina in male. So that is also called as a male vagina or masculine vagina. That is a prostatic utricle. So remnants hai paramesonephric duct in case of male. So that's about the embryo part. We covered quite a lot in this time. Chalo guys, no break, nothing. Let's move on to the next topic, and after this I am starting with the upper limb. So let's start with the limbs first. We'll discuss the upper limb and lower limb, and then we'll move on to the head and neck and neuro part here. Come on. I hope everything is going okay. My speed is okay. मुझे कुछ कम ज़्यादा करने की ज़रूरत नहीं है. You can just give me the feedback. Although I will not be able to alter much because we have to cover a lot and in the stipulated time. Thank you for all the lovely messages, guys. सब पढ़ूंगा मैं बैठ के आराम से. I'm going to read all these messages one by one in detail. That's what I'm going to spend my night in. But okay, thank you. थोड़ा और फास्ट कीजिए. अरे नहीं, और फास्ट की जरूरत नहीं है. Perfect, guys. Thank you so much. Okay. Chalo, let's move on. Let's start with the upper limb now. Now in the upper limb, I'm first want to start with the a picture of a humerus. Upper end of the humerus and upper end of femur, I always say in my class also that's very important, because the muscles of the shoulder joint and the hip joint are attached there, and the shoulder joint movement and hip joint movement is something that you should know about, and there are questions asked on that here. Now when you look at the upper end of the humerus here and along with the scapula, now obviously I don't have to tell you these are the bony prominence, that's a lesser tubercle you're looking at, that's a coracoid process, acromion process, and that's a lesser tubercle, that's a greater tubercle, and there is a bicipital groove in between. Now, the muscle which is attached to the lesser tubercle, guys, that muscle attached to the lesser tubercle is subscapularis muscle. Now, this subscapularis muscle is inserted, it's coming from the subscapular fossa and inserted onto the lesser tubercle. And I want to go in a certain sequence here. After the lesser tubercle, if I take you to the floor of the bicipital groove, now there is a very famous mnemonic for these muscles. We say a lady between two major, so that the lady is there and the two majors are covering it. The major toward the right, to the lateral side is pectoralis major, and the major toward the medial side is teres major. So from lateral to medial side, if we go the lady between two major, it's a pectoralis major, we have a latissimus dorsi, and then we have teres major. The reason I'm going with these muscles together is, see, it doesn't make a difference that where the muscle is originating from. Insertion important here. Subscapularis is coming from the anterior surface of scapula and it is going toward the humerus in front of the humerus. Humerus ke aage ja raha hai. Similarly, look at these muscles, guys, having a diverse origin. Pectoralis major muscle is coming from the anterior chest wall. Latissimus dorsi is coming from the back. Imagine, teres major is coming from lateral border of scapula. जितनी भी variety हो सकती है सब कुछ है हमारे पास. But ultimately all the three muscles are coming and inserting in front of the humerus. And that's why all these four muscles, whether it is subscapularis, whether it is latissimus dorsi, whether it is pectoralis major, they will all pull the humerus inside. So they will cause adduction and internal rotation. They will cause adduction and internal rotation. Always try to look at the attachment of the muscles having the same action together. It's always easy to remember the attachment of the muscle also. So subscapularis, so pectoralis major or latissimus dorsi, teres major, that one common action they all have is adduction and internal rotation. Adduction and internal rotation. Okay. Then greater tubercle, obviously we all know that the sit muscles, the supraspinatus, the infraspinatus and teres minor muscle, these are the three muscles which are sitting on the greater tubercle, the sit muscles, SIT. Well, supraspinatus, we know it is known for the initiation of abduction. 0 to 15 degree of abduction is done by the supraspinatus, whereas infraspinatus, now again the same principle again, infraspinatus muscle and teres minor muscle are running horizontally, but they are पीछे से, वो पीछे की तरफ से आ रही है. They're going to the greater tubercle from the posterior side, so they will also pull the humerus inside, adduction, but this time they will cause what? External rotation, because these muscles are present at the back. So infraspinatus and teres minor are for the external rotation. So especially I wanted to be careful with this muscle, guys, teres minor and teres major. Teres minor and teres major, the common function is adduction. That's the synergist in the adduction here. But when it comes to the rotation, one is the external rotator and one is the internal rotator. So that's an example of a muscle which is a synergist also, and it is an antagonist also when it comes to the rotatory movement at the shoulder. Well, guys, coracoid process. Well, there was another question asked, like काफी पहले पूछा है question that the part of the scapula which can be felt below the clavicle, that's a coracoid process, guys. Coracoid process को आप you can feel it under the clavicle in the palpation in the scapular region here. And the coracoid process is giving origin to the short head of biceps, and also to the coracobrachialis muscle. और ये दोनों short head of biceps and coracobrachialis at the shoulder, they are helping in the flexion only, weak flexors only. And pectoralis minor muscle is inserted on it. Pectoralis minor muscle is inserted on it here. I tell you, see, these are the kind of questions they can frame it on their own will. आपको ऐसे बोलेंगे कि there is a fracture of the coracoid process. Let's say there is a fracture at the base of coracoid process. So that action of which muscle will get hampered. So you need to know that which important muscles are attached to these bony prominences. So short head of biceps, coracobrachialis and pectoralis minor, they are attached on the coracoid process. Well, the next thing, guys, you're looking at the humerus from the anterior view. Like the reason I'm showing you the picture of the humerus again, because I want to tell you some vulnerable point of injuries to the different nerves there, and this also is the question asked in the previous exam here. Now, if you look at that area over there, that's the surgical neck of the humerus. Now, the fracture of the surgical neck of the humerus, or the nerve which is vulnerable to injury in the surgical neck of the humerus fracture, is the axillary nerve. Axillary nerve winds around the surgical neck of the humerus posteriorly. That's why it can get injured there here. Shaft fracture, guys. If there is a shaft fracture, the humeral shaft fracture, the nerve which is running posterior to the shaft here, that is a radial nerve which is running in the spiral groove, is likely to get injured here. If it is a supracondylar fracture, now the supracondylar fracture, the nerve which is likely to get injured here is a branch of median nerve. Now if median nerve is given and anterior interosseous nerve is given, go with anterior interosseous nerve, guys. Anterior interosseous nerve is the most common nerve to be involved in the supracondylar fracture. Medial epicondylar fracture, no surprises there. The nerve which is present behind the medial epicondyle, that is the ulnar nerve. So ulnar nerve injuries are common and seen in the medial epicondylar fracture. And if it is a lateral condylar fracture of the humerus, then no surprises again, guys. I mean, no need to be surprised with this, because again, answer is ulnar nerve only. Now, why ulnar nerve get injured in the lateral condylar fracture? And that is a tardy ulnar nerve palsy. There will be obviously the cubitus valgus deformity. There is a stretch, undue stretch on the medial side, and that will cause the ulnar nerve palsy. So, be it a medial epicondylar fracture or the lateral condylar fracture, the ulnar nerve is the one which is more commonly involved, or most commonly involved in these. Okay, next we're looking at, well, we have to kind of give time to this topic, guys. Intrinsic muscle of hand. This is coming in the exam. Like it's not that इसमें से question आ सकता है. Like every year they are asking questions from the intrinsic muscle of hand. So one hell of an important topic which you need to pay attention to, guys. Now when it comes to the intrinsic muscle of hand, you're looking at the four groups there: the thenars, the hypothenars, the interossei, and the lumbricals. Now the thenar muscle, guys. Thenar muscles are thumb muscles. Well, obviously there are 4 thenar muscles, and any superficial dissection when you look at, and I'll tell you guys, you will get a question on the superficial dissection of hand only, if the thenar or hypothenar muscles are asked. I'll tell you what other muscle could be asked in that. The muscle that you will see is the abductor pollicis brevis. The muscle which is more outside. The muscle which is more outside will be abductor pollicis brevis. And same origin, same insertion. More or less the same insertion are there for this muscle. But the muscle which is more inside, more toward the palmar aspect, is a flexor pollicis brevis. Brevis muscle, short muscles. So abductor pollicis brevis, and flexor pollicis brevis. These 2 muscles are there to be seen in the superficial dissected specimen of the hand. Opponent's pollicis नहीं दिखेगा unless you remove these 2 muscle. Unless you remove these 2 muscle or make a space between these 2 muscle, you will not be able to see a third muscle, that is opponent's pollicis, guys. Opponent's pollicis is a muscle attached to the metacarpal. Opposition is possible when you rotate the metacarpal. So opponent's pollicis muscle is seen only when the metacarpal is exposed. Then only you can see it, or you can see they create a space between the flexor pollicis brevis and abductor pollicis brevis. So इसमें तो आप expect मत करो here. But this one very important muscle, which is another image based question asked in the exam, और आगे future में भी बहुत अच्छे chances हैं, that is the adductor pollicis. Now adductor pollicis muscle, the muscle basically is coming from the shaft of third metacarpal, and this muscle is not a muscle of thenar eminence. It's a thumb muscle only, but it is not a muscle of thenar eminence because it is coming from the palmar aspect. Now look at this. If I remove all these muscles here, the flexor and abductor, and I remove all these tendons also, then I'll be able to see this adductor pollicis muscle better, like in this picture. Can you see that? Now look at that muscle over there, guys. Look at that muscle is coming from the shaft of the third metacarpal. That's a transverse head and running horizontally here. It's a very strong adductor of the thumb, adductor pollicis muscle. And this is the last muscle to be supplied by the ulnar nerve. Now please pay attention to the color code also. I'm using this red color here for the ulnar nerve, the muscle supplied by ulnar nerve, and the rest of the muscles are supplied by the median nerve. Though flexor pollicis brevis, it can be hybrid. So adductor pollicis, that muscle over there is adductor pollicis here. Now adductor pollicis is for the adduction of thumb here, and the test which is done to check the integrity of this muscle, that is the test, we call it the book test, right? If you give a book in hand, like if I'm holding the book, obviously I'll use my adductor pollicis muscle to hold the book here. But let's say if my ulnar nerve is paralyzed and I'm not able to use the adductor pollicis muscle, then I'll do a trick movement. I'll bend my thumb. And why I'm bending my thumb? Because bending of thumb is done by the muscle called as the flexor pollicis longus, which is supplied by median nerve. So ulnar nerve is not working, so you're using your median nerve to hold the book here. Ulnar nerve, then you would be using the adductor pollicis muscle. That's not working, then obviously using the median nerve that is supplying the flexor pollicis longus muscle, and flexor pollicis longus muscle is to bend the interphalangeal joint of thumb. So if the bending of thumb is there, then it is obviously the positive Froment's sign. Taking to the other side, guys, when you see on the other side, well, we have a hypothenar muscles. When you look at the hypothenar muscle, the principle is same. Muscle more outside is abductor, muscle more inside is flexor, the one which is deep is opponents. Simple. The muscle more outside, this one here, is abductor. The muscle more inside is a flexor digiti minimi. That's for the little finger, obviously. Opponents nahi dikhega. That is opponents digiti minimi. And you will also not be able to see the palmaris brevis. It's a subcutaneous muscle, guys. The muscle is present just under the skin here. Once you remove the skin, the palmaris brevis muscle is also gone. Palmaris longus is a forearm muscle. It's a palmaris brevis muscle. Just like a platysma muscle, there is a subcutaneous muscle over there called as a palmaris brevis. So flexor digiti minimi, abductor digiti minimi, opponents digiti minimi, which is again present deep to it. Unless you remove these two muscles, you'll not be able to see that. And then you're looking at the palmaris brevis, which is a subcutaneous muscle. Okay. Coming to the next picture, guys. In this picture, the same image only, but this time we are not focusing on the thenar and hypothenars. Now I want you to understand the lumbricals here. Now बहुत लोग ये पूछते हैं कि sir, how to differentiate between the lumbricals and interossei, because they get confused between the two. See, lumbricals, whether in hand or in foot, lumbricals ka property is that they originate from tendon, they insert on tendon. They are tendon to tendon muscle. If you're looking at a picture of a lumbrical muscle, tendon to hoga na wahan par. You will be looking at some tendons there. Look at these. Look at all these long tendons here. The flexor digitorum superficialis, the flexor digitorum profundus tendons are visible. Then only you can see lumbricals. The moment you remove the tendon, lumbricals are gone. Interossei muscle, the name says interossei, between the bones. Interossei muscles are between the bones, so you'll be looking at the bones. You'll be looking at the shaft of the metacarpal when the interossei muscle are to be seen. And moreover, to see the interossei muscle, aapko is sab remove karna padega. You have to remove the thenars and hypothenars. You have to remove the tendons and lumbricals. They are the deepest muscle of the hand here. So expect to see the interossei muscle in the deepest dissection with the bone visible there. If you're looking at the tendons, the muscle coming from the tendons, these are lumbricals here. Now, first of all, lumbricals originate from where? It originates from the tendon of flexor digitorum profundus. Although when you see from the front, you're looking at both FDS and FDP tendon. The one in front is FDS, flexor digitorum superficialis, and deep to is flexor digitorum profundus, but they are originating from flexor digitorum profundus, guys. First lumbrical, unipinnate. Second lumbrical, unipinnate. And lumbricals, L for lumbricals, L for lateral. They will go to the lateral side of the respective digit. They will go to the posterior side, but from the lateral side of that respective digit. First lumbrical from the lateral side of the index finger, second lumbrical lateral side of the middle finger, and so on. Third and fourth lumbrical, they will take origin from both the side of FDP tendon, and they are bipinnate muscle, guys. Third and fourth lumbrical are bipinnate, and they are supplied by ulnar nerve. So lumbrical, two lumbricals, guys. First lumbrical was one of the image-based question asked in the exam, cadaveric image-based question. So obviously the counting goes from the lateral to medial. So first and second lumbrical unipinnate supplied by median nerve. Third and fourth lumbrical are bipinnate supplied by the ulnar nerve. Bipinnate lumbricals. That brings us. Now look at this picture here. This is something about the reason I'm showing you this picture here is, guys, opponent's pollicis and opponent's digiti minimi. I told you the opponent's muscle will not be visible. Now because opponent's pollicis muscle will be attached to the shaft of the first metacarpal, and opponent's digiti minimi is attached to the shaft of the fifth metacarpal. Now, but if there is a Bennett's fracture of the base of first metacarpal, or reverse Bennett's fracture, that is a fracture of the base of the fifth metacarpal, then obviously which muscle will pull them away? The fragment will be pulled away. The base of that respective metacarpal will be pulled away by which muscle? And that is abductor pollicis longus and extensor carpi ulnaris. Forearm muscle. It's the pull of the forearm muscle which will pull the fragment away, the muscle which are attached to the base of the respective metacarpals. Base of first metacarpal pe abductor pollicis longus. It's a forearm muscle supplied by radial nerve. Abductor pollicis longus is inserted, and on the base of the fifth metacarpal extensor carpi ulnaris muscle is inserted. So in the Bennett's and the reverse Bennett's fracture, these are the muscles which will pull the fractured fragment away from the bone. Yes, Jones. Interossei, guys. Well, interossei muscle, I told you that intrinsic muscle of hand, anyways, they are important. And in the intrinsic muscle, well, when it comes to especially the interossei, the palmar and dorsal interossei, they're absolutely important now. Now, palmar interossei, look at this. First of all, guys, all the palmar interossei are unipinnate and all the dorsal interossei are bipinnate. Now, you're getting a question from this topic, just mind it here, guys. All palmar interossei are unipinnate, all dorsal interossei are bipinnate. So palmar interossei are taking origin from one metacarpal, and dorsal interossei are taking the origin from adjacent metacarpal here. Now we know that the mnemonic that pad and dab, the palmar interossei is for the adduction and dorsal interossei is for abduction. And be it palmar interossei or dorsal interossei, all interossei are supplied by the, what now? Ulnar nerve. All interossei are supplied by ulnar nerve. Dominant nerve of hand, it supplies all the interossei. It supplies all interossei. Now, to understand these interossei better, guys, see, we know that in the adduction and abduction of the fingers, the principal digit here is a middle finger. Now, that's a middle digit here. The middle finger is a principal digit there. Let's deal with the palmar interossei first. Now, the function of palmar interossei is adduction. Palmar interossei was adduction. So that obviously is pulling the thumb, the index finger, the ring and the little finger toward the middle finger. Look at those arrows, guys. They're pulling it toward the middle finger. So you have a palmar interossei on the thumb, on the index finger, on the ring finger, on the little finger. But obviously the digit which is not having a palmar interossei is a middle finger. When you're doing the adduction, आपको middle finger को move नहीं करना है. You have to move other finger close to the middle finger. So palmar interossei is absent on middle finger. That's one thing. Unipinnate है and the palmar interossei is absent on the middle finger. Now, out of these 4 palmar interossei, there is one more palmar interossei which can be very well absent और कोई फर्क नहीं पड़ता उससे, and that is the first palmar interossei. Guys, the first palmar interossei, which is for the thumb, this very well can be absent. The reason is the first palmar interossei is for the adduction of thumb, and we already have a muscle called as the adductor pollicis. It's a strong muscle that we have for the adduction of thumb called as the adductor pollicis, and that's why this muscle can very well be absent also. So first palmar interossei, or you can say palmar interossei of thumb, can be absent as well. Right, so middle finger definitely is not having a palmar interossei, and thumb may or may not have a palmar interossei. Yes, and the test which is done to check the power of the palmar interossei, the test which is done to check the integrity of the palmar interossei is a card test. You all know that when you put the card between the finger and you pull the card with the respective finger to test the power, adduction power, that is a card test done for the integrity of the palmar interossei. Dorsal interossei, as you can see, dorsal interossei, देखो इसको ऐसे लेते guys. First of all, dorsal interossei is not needed. Let's go with this part. Dorsal interossei is not needed for the thumb and little finger. Thumb and little finger, they're already having their abductors. We already have an abductor for thumb. We have an abductor for little finger. So when you look at the thumb, when I say thumb, guys, just look at the phalanges only, not the metacarpal. Now there is no dorsal interossei inserted here. There is no dorsal interossei inserted on the little finger. So thumb and little finger are devoid of the dorsal interossei. We know dorsal interossei is for abduction, so this time we have to go away. Now forget about the thumb, forget about the little finger because they already have their dorsal interossei. So we have 4 dorsal interossei which are attached on these 3 fingers. So guys, first and the last dorsal interossei are for the index finger and the ring finger. You can see the first dorsal interossei, it is going to the index finger, will pull the index finger away, and the last one will pull the ring finger away from the middle finger. But the second and third dorsal interossei, both of them are attached to the middle finger. The same middle finger which was not having any palmar interossei is having double dorsal interossei. क्योंकि middle finger की दोनों movement, both the movement of the middle finger, the deviation of the middle finger whether toward the radial side or toward the ulnar side is done by the dorsal interossei only. Is done by the dorsal interossei only. So guys, dorsal interossei are bipinnate. That's what we said. Thumb and little finger are devoid of dorsal interossei. There is no dorsal interossei, thumb and little finger here. And we said the middle finger is having a 2 dorsal interossei. Second and third dorsal interossei is present on him. And the test which is done to check the integrity of the dorsal interossei muscle is called as a Agua test. Look at the test, guys, in which you ask the patient to place the hand on the table and then ask him to just move it in the radial and ulnar direction here. That is the Agua test. So you can see middle finger can move in both the direction here. That means the second and third dorsal interossei working. The ulnar nerve supplying these muscles is intact. The Agua test. So that's about the intrinsic muscle of hand, guys. So we talked about the 20 muscles in hand. Okay. Couple of more topics in the upper limb before we go to the nerve and nerve injuries there. Now, clavipectoral fascia. Now, what about this clavipectoral fascia? It is a question which is asked as an image-based question also, and normally also this question is asked here. Clavipectoral fascia, the fascia extending from the clavicle and covering the pectoral muscle. Now, first of all, in this image, the pectoralis major muscle is removed. You can see the cut fibers of pectoralis major muscle are removed. You can see that insertion part is also removed from there. Pectoralis major. Now, the fascia which is present over there, this entire translucent fascia over there is a clavipectoral fascia. Now, there are 2 muscles which are enclosed in the clavipectoral fascia. One of them is the subclavius muscle and the another one is the pectoralis minor. The 2 muscles. That's one question here. The muscles enclosed in the clavipectoral fascia is subclavius and pectoralis minor. Second question, guys, what are the structures piercing the clavipectoral fascia? Look at that area, that circle over there. Now, those are the structures which are piercing the clavipectoral fascia. 2 of them are going inside and 2 are coming out here. The nerve which is coming out to supply the pectoralis major muscle is a lateral pectoral nerve. So structures piercing clavipectoral fascia, एक तो lateral pectoral nerve बाहर आ रहा है, number one. Cephalic vein is going inside, and thoracoacromial artery is coming out. So we have a thoracoacromial artery, which is a branch of axillary artery coming from second part of axillary artery. You can see some arteries over there. And look at this vein, guys, the vein which is passing from this deltopectoral groove and then ultimately piercing this clavipectoral fascia and draining into the axillary vein. That is the cephalic vein. And finally, some lymphatics which are going to drain into the apical lymph node are also there. Some lymphatics are also there. So we have a nerve, we have an artery, we got a vein, we got a lymphatic. सब कुछ एक-एक है. One artery, one vein, lymphatic, and the vein and the nerve also. So this is about the structures piercing clavipectoral fascia. Now this clavipectoral fascia below pectoralis minor muscle, look at this extension over the clavipectoral fascia in this region here. It is forming a ligament in that part here, which is called as a suspensory ligament of axilla, guys. That's a suspensory ligament of axilla. Now if you look at the floor of axilla, it's not flat, it is slightly dome shaped, and the dome of the floor of the axilla is because of this ligament pulling this floor up here. That's a suspensory ligament of axilla. So that's a few things about the clavipectoral fascia. Okay, moving on. The next thing, the brachial plexus, guys. Some relevant discussion on the brachial plexus. Obviously, I don't see that brachial plexus to be asked as an image-based question as till now. Moreover, actually, the kind of the quality of image they give in the NEET exam, I don't expect to give them such a detailed question of identifying the brachial plexus. See, remember one thing, guys. Generally, in the upper limb and lower limb, when you look at the image-based questions, now you don't have to go into too much of detail. It's that just make sure you identify the major structures, identify the muscles around the cubital fossa, about the major nerves and arteries, the major muscles around the shoulder region. That's all is needed here. Now nobody is asking you to identify the thoracodorsal nerve in the axillary dissection here. That's not going to happen, right? So major structures are something which you have to understand. Abhi bhi dekho, last few days back only when the question was asked, sartorius muscle was, imagine what was INICT question here. Last year, incus bone was given over there. The question was about the identification. So it's very basic that they ask here. Last year NEET, there was an ulnar artery which was asked. So it's nothing minute, no cutaneous nerve or nothing, many minute artery or muscle is asked here. It's major structure that you need to identify. Now guys, brachial plexus is formed by the ventral primary rami of C5, C6, C7, C8 and T1. Now C5 and C6 together will give rise to the upper trunk, C7 gives rise to middle trunk, and C8 and T1 you can see they're joining it form the lower trunk here. Trunk ka root value important guys. Upper trunk is by C5 and C6, middle trunk is by C7 and the lower trunk is formed by C8 and T1. Now after the trunk is formed, the next part of the brachial plexus that come is called as a division. We have a ventral and dorsal division, and the purpose of the division is to basically enhance the root value, so that by the time the cords will be formed, unki root value bahut enhanced hogi. Whatever nerve will come out from the cord, radial nerve, axillary nerve, they can take a contribution from the different root values here. So that's an advantage of having a division part. And the one question which was asked about the division in one of the previous year question was that which part of the brachial plexus does not give the branches? And that's the division part. There are no branches, there are no nerves coming out of the division region which will supply any muscle or any skin anywhere. So no branches from the division part. And then finally we have the cords of brachial plexus. Well, the nomenclature of the cords of brachial plexus is based on the relation to axillary artery. So like this over there is lateral to axillary artery, this is posterior to axillary artery, and that is medial to axillary artery. Axillary artery ऐसे निकल के जा रहे हैं यहाँ से इनके. The one which is hiding behind the axillary artery, that is the posterior cord. The one which is medial, that is medial cord, and the moment I remove my hand, that is a posterior cord. That's hiding behind the axillary artery, that is the posterior cord of brachial, lateral, posterior, medial cord. Now once again, you should know the branches coming from the different cord. Honestly, not very important, but at least identify that what is the continuation of the cord. How the cord will continue as, what nerve will be continuing as from the lateral cord. Like if you look at the lateral cord there, like out of the 3 nerves coming from the lateral cord, the continuation of the lateral cord is in the form of the musculocutaneous nerve. Musculocutaneous nerve, guys. It is also one of the recent questions. Musculocutaneous nerve supplies the muscles of the arm and skin on the lateral side here. The BBC muscle, the biceps brachialis and coracobrachialis. Musculocutaneous nerve injured hoga, the person will have a difficulty in the flexion of the elbow, difficulty in the supination. Bicep is a very strong supinator, and there will be sensory loss on the lateral side of forearm. Musculocutaneous. Posterior cord. If you look at the posterior cord, the continuation of the posterior cord is the radial nerve. The radial nerve is a continuation of the posterior cord, although you can see axillary nerve also there, but the radial nerve you need to focus on. And the medial cord continuation here is the ulnar nerve. Medial cord will continue as ulnar nerve. Though the medial cord and lateral cord together will give rise to this nerve. Look at that nerve, and that is the median nerve, guys. That's a median nerve. So median nerve gets one contribution from the lateral cord, and it gets a contribution from medial cord as well. So knowing the trunk, the root value of the trunk, the continuation of the cord, which, that is like good enough. Like we don't have to go into the too much of detail of the brachial plexus. But what is important here is the injury of the upper trunk and the lower trunk, guys. If you look at the brachial plexus, that's again the schematic of the brachial plexus there. Now in this schematic of the brachial plexus, what you see that upper trunk, the upper trunk there and lower trunk, guys. Injury to the upper trunk we all know is called as a Erb's palsy. The root value affected is C5 and C6, and the injury to the lower trunk is a clump case. The root value affected is C8 and T1. If the injury is to the upper trunk of the brachial plexus, then obviously Erb's palsy, we said the upper trunk is involved, and the root value getting affected there is C5 and C6. Now C5 and C6 is present in many nerves. Radial may be hai, ulnar median may be hai. Many nerves are having the C5 and C6, but let's take some specific nerve here. Like C5 and C6 is present in axillary nerve. The root value for the axillary nerve is C5 and C6 only, and musculocutaneous nerve coming from the lateral cord is also having a C5 and C6. In fact, musculocutaneous nerve is having a C5, C6 and C7 also. So there is something additional we have in the musculocutaneous nerve, but axillary nerve is only made up of C5 and C6. Now again, just think of a main muscle, guys. Just like you have to filter out the unnecessary detail at this point of time. Axillary nerve, what is the main muscle supplied by axillary nerve? That is the deltoid muscle. So axillary nerve ka injury hua, to obviously deltoid muscle will be paralyzed. And if the musculocutaneous nerve is gone, then obviously biceps and brachialis will be gone. Coracobrachialis will be spared, guys. Coracobrachialis is supplied by C7, so coracobrachialis is spared in the Erb's palsy. But musculocutaneous nerve ka injury will involve the biceps and brachialis muscle. I've just taken the bicep only. Deltoid and bicep. Now these are too good enough to tell you what is going to happen. If a deltoid is gone, obviously the shoulder will come into adducted position. You have an adducted shoulder, number one. Your bicep is gone, the elbow will come into extended position because bicep is a strong supinator, so elbow will come into extended position. And I told you that bicep is a very strong supinator also, so or also forearm will go into the pronated position here. And that is nothing but the policeman's tip hand. Adducted shoulder hai, extended elbow hai, pronated forearm hai, and that is nothing but the policeman's tip hand. That is a policeman's tip hand. The policeman's tip hand. Clump case. Well, Nikhil, I'm gonna go with my speed, my dear. जल्दी जल्दी करने के चक्कर में like इतना ना खाएं कि digest ना हो पाए. Let's eat as much as we can digest here. और मुझे कहीं जुपिटर से तो लेके आना नहीं है. If you want me again, I can come again live in front of you. So I think whatever we're discussing should make sense rather than I just quickly scroll through the slides. So don't worry. Chill करो. Okay. Now the injury to the lower trunk of the brachial plexus, that is clump case, the clump case palsy. The root value affected in the clump case palsy is C8 and T1. Now C8 and T1 is a major root value for the intrinsic muscle of hand. But the intrinsic muscles of hand are supplied by the ulnar nerve, as well as some of them might be by median nerve also. But if the intrinsic muscle of hand are gone, then obviously the one common function of the intrinsic muscle of hand will get affected here. This is what lumbricals and interossei will do, and that will get affected. There is an antagonistic movement at these joints here. So there will be extension, the hyperextension at metacarpophalangeal joint and flexion at interphalangeal joint, and that will cause claw hand. So in clump case palsy, obviously the feature is a claw hand here. T1 ka involvement hai. T1 involvement can also lead to the clump case palsy also, because T1 is the first sympathetic nerve supplying the face as well. So claw hand is the main thing. So that's the claw hand. Hyperextension, guys. It's a hyperextension at the metacarpophalangeal joint and flexion at the interphalangeal joint. That's the claw hand. So that's about the brachial plexus and the two major injuries of the brachial plexus, the Erb's and the clump case. Chaliye, moving on. Now let's talk about the three important nerves, and I'm sure you read about these nerves in the ortho also. But let me just very quickly go through these three nerves here. The radial nerve. The radial nerve, guys, coming from C5 to T1, the entire brachial plexus will be contributing to the formation of the radial nerve. Now, if you look at the radial nerve, just have a look at this animation, guys. The radial nerve starts from the axilla. It goes into the spiral groove that is behind the humerus, comes in front of the lateral epicondyle, and divides into these two branches. So we have a superficial branch and we have a deep branch, जो supinator को pierce करके जाएगा. That is called as a posterior interosseous nerve. So radial nerve in the spiral groove and then comes in front of the lateral epicondyle, and then it divides into the superficial branch and the posterior interosseous nerve. Posterior interosseous nerve. Now radial nerve, guys, in the axilla, the radial nerve supplies the tricep muscles. Now, whichever head of triceps, long head and medial head, doesn't matter, triceps. Again, the radial nerve supplies the tricep muscle in the spiral groove. Radial nerve, it supplies one of the wrist extensor above the elbow only, above the lateral epicondyle only, क्योंकि उसका origin भी ऊपर ही होता है. And that muscle is ECRL. Extensor carpi radialis longus, the most important muscle to be remembered from here. Extensor carpi radialis longus, guys. It is one of the wrist extensor. All other wrist extensor will be supplied by posterior interosseous nerve. Now, this one wrist extensor is supplied by the main radial nerve before the division. Now, once the radial nerve divides, the superficial branch is cutaneous. It is going to supply the skin. And it's the posterior interosseous nerve which will supply all other extensors. Extensor digitorum, extensor indicis, extensor pollicis longus, extensor pollicis brevis. Zarurat nahi hai. You don't have to remember the names. You just need to remember the function. Extensors of the wrist and fingers will be supplied by the posterior interosseous nerve. Now, the common site of radial nerve injury, guys. Radial nerve injury in the axilla, the crutch palsy. Look at those circles over there. Radial nerve can get injured in the axilla. That is a crutch palsy. Using abnormally long crutches can use the crutch palsy. Radial nerve injury in the spiral groove could be because of the spiral groove fracture also. That is a sedentary palsy, or can say compression of the radial nerve in the spiral groove. Injury of the radial nerve in front of the lateral epicondyle before the nerve divides. And there could be direct trauma to the posterior interosseous nerve. One of the reasons could be the radial head fracture. The common site for the radial nerve injury, guys. The common site for the radial nerve injury. Okay. Now, triceps by the radial nerve, ECRL and other extensors. If you just remember these basic information from the radial nerve, you still will be able to solve the clinical questions on that. Now, look at these four scenario, guys. If I talk about the first case there, if the radial nerve is injured as high as in the axilla, then what will happen? Radial nerve injured in the axilla, then obviously all the extensors are gone. All the extensors are gone. So obviously the elbow will come into extended position, tricep gaya. Okay. So I'm sorry, the elbow will come into the flex position, sorry. The extensor is gone, so elbow will come into the flex position. The wrist will also be dropped. The wrist will also come into flex position. Fingers will also be dropped. That is a finger drop is there. And there obviously is a sensory loss on the lateral 3.5. Whatever area is supplied by the radial nerve, 3.5 or 2.5 varies from person to person. So in crutch palsy or in the higher injury of the radial nerve in the axilla, look at that. There will be flexed elbow, there will be wrist drop, there will be finger drop, and there will be sensory loss. If the radial nerve is injured in the spiral groove, the difference between the A and this first and second case would be, if the nerve is injured at this point here, so some part of the tricep will be spared. Some part will be spared. And if some part of the tricep will be spared, then what will happen? Then we will not have the flexed elbow. There will be weakness. The patient will come with a complaint of weakness in elbow extension because tricep partly काम कर रहा है. Tricep is working partly, so there is a weakness in elbow extension. But flexed elbow is not there. Rest everything is same. We still have the wrist drop, we still have the finger drop, and we still have the sensory loss here. Look at the first point there, the weakness at the elbow, weakness of the extension of elbow. That's the only difference between the two. Third case, when you're looking at the nerve is injured at the level of lateral epicondyle. Now, in this case, one important muscle is also, first of all, tricep is spared, guys. So elbow is perfectly all right. Extension का कोई issue ही नहीं है. Now, ECRL is also spared. Now, if the ECRL is spared, so obviously that means one of the wrist extensor is spared. So there will be no wrist drop. Weakness hoga, there definitely will be weakness in the wrist extension, but there is no wrist drop in this case, and rest is same. So no wrist drop, but finger drop is there because finger extensors are still affected here. So no wrist drop, but finger drop is there along with the sensory loss because still the superficial branch is involved. So there will be sensory loss in this case. Finger drop and sensory loss, no wrist drop. And if the posterior interosseous nerve is injured, then sensory loss bhi nahi hoga because sensory nerve is which one? Superficial branch. This is not motor nerve, guys. Whether the injury is to the anterior interosseous nerve or posterior interosseous nerve, sensory loss to nahi hoga na. Interosseous nerves are deep nerves. They are supplying the muscles. They are not supplying the skin. So injury to precisely to the interosseous nerve, anterior or posterior interosseous nerve, it's only the motor loss here. So in posterior interosseous nerve injury, you only will have finger drop and there is no sensory loss on the dorsum of hand. So this question could be asked in any ways. They can give you the condition and will ask you that what is the level of the injury, or they will give you the level of the injury and will ask you what patient will present with here. So that's about the radial nerve. Now moving on guys, median nerve. So if you find any mistake or something in this presentation, although I don't know, I've not seen it, you can just let me know later on also. I'll correct it, annotate it and then send it to you. Now guys, median nerve, median nerve in the axilla and in the arm, It is not supplying anything. The first supply of the median nerve comes from the cubital fossa only. It is supplying the pronator teres muscle, which is a muscle which is forming the boundary of cubital fossa. So median nerve, first of all, it is a becoming content of the cubital fossa, leaves the cubital fossa, runs in the forearm, passes deep to the flexor retinaculum and goes into the hand. Deep to the flexor retinaculum, that is from carpal tunnel, and goes into the hand. Now, once the median nerve reaches the hand, guys, once the median nerve reaches the hand, then what you'll see, the median nerve in the hand will supply the thenar muscles and first and second lumbricals. If you just think back, we said out of all the intrinsic, the muscles of the hand, thenars, except adductor pollicis, and the first and second lumbricals are supplied by the median nerve in hand. अगर hand की बात करें, thenars with first and second lumbrical, the lateral two lumbricals, unipinnate lumbricals. And there is one important nerve that you should know. Again, I'm just looking at the important thing. और भी बहुत सारी branches है, but I'm just focusing on the important branch. So there is one branch of median nerve which is not passing deep to the flexor retinaculum. In fact, it is passing superficial to the retinaculum, and that is called as a palmar cutaneous branch. That is a palmar cutaneous branch, guys. It is passing superficial to the retinaculum. That's the only branch of median nerve जो कि retinaculum के ऊपर से जाता है. Now, what's the role of median nerve in the forearm? In the forearm, the main median nerve will supply the superficial flexors, like flexor digitorum superficialis. If I talk about the main nerve, it supplies flexor digitorum superficialis and other superficial flexors. And the deep branch of median nerve, called as anterior interosseous nerve, will supply the deep flexors of forearm. Now, what are the deep flexors of forearm? We have a flexor digitorum profundus. The name says profundus, profound. It's a deep muscle. So it's the anterior interosseous nerve which supplies flexor digitorum profundus. But guys, flexor digitorum profundus is a hybrid muscle, so it only supplies the lateral half of flexor digitorum profundus, along with pronator quadratus and flexor pollicis longus also. I'm not writing all the muscle, I'm just writing the important one. So flexor digitorum profundus lateral half and flexor pollicis longus. I told you that. Remember that muscle? Flexor pollicis longus, the one which was enabling the person to hold the book even if the adductor pollicis is not working. The muscle which will help in the flexion of the interphalangeal joint of thumb. That is flexor pollicis longus. Now guys, if the median nerve is injured anywhere, wherever we have the median nerve injury, whether it's axilla, arm, forearm, at the elbow, distal injury, carpal tunnel, wherever it is, एक चीज तो होगी, that is carpal tunnel syndrome. One thing will be there, that is the ape thumb deformity. I'm sorry, there will be ape thumb deformity because the thenar muscles will get affected here, and if the thenar muscles will get affected, the thumb obviously will presume the position of adduction and the external rotation. So there will be ape thumb deformity. So whether the person comes to you with a higher injury or lower injury, the ape thumb deformity is inevitable. Now the question is, if there is a higher injury, let's say if the injury is there, higher injury, and one injury is there, how will you differentiate? Now if I come to you with an ape thumb deformity, how will you say it is a higher injury or lower injury? Well, in case of higher injury, what will happen? In case of higher injury, when you ask the patient after the ape thumb deformity, looking at the ape thumb deformity, you ask the patient to make a fist. While making a fist, he is not able to flex the index finger, or maybe not able to flex both the fingers, the index and middle finger. That is because the FDP of the lateral side and FDS is not working. Flexor digitorum superficialis of all the fingers and flexor digitorum profundus of lateral side is not working. So lateral side की finger की ना तो FDS है ना FDP है. Neither FDS is working nor FDP is working on the lateral side of the finger. So the patient may have either ape thumb deformity, there is a hand of benediction, that is a hand of benediction there, or there will be pointing index finger. But the important thing is while making a fist, guys, when you make a fist, then you see the pointing index finger or hand of benediction while making a fist. If it is a distal injury, if the injury is distal, then obviously all these FDS and FD are working here, so patient can make a fist, no problem with that. So ape thumb deformity will be there. But along with ape thumb deformity, in case of carpal tunnel syndrome, one important factor that will help you is this nerve here, guys, palmar cutaneous branch. Palmar cutaneous branch is passing superficial to the retinaculum, and that's why there will be no sensory loss on the lateral 3.5 palm. There will be sensory loss on the fingers, but there will be no sensory loss on the palm. Palm पे कोई sensory loss नहीं होगा, guys. And that's the thing about the injury. When you see that, that's a hand of benediction you're looking at. That's a, you can, the thenar wasting is there. You can see ape thumb deformity, the thenar wasting. That's a hand of benediction. And if the injury is lower, the carpal tunnel syndrome also, then you will see ape thumb deformity with no sensory loss on the palm. Fingers पे होगा, but there is no sensory loss on the palm area. If anterior interosseous nerve, if there is an isolated injury of the anterior interosseous nerve, guys, let's say only anterior interosseous nerve is injured here. So look at these two muscles, guys, FDP and flexor pollicis longus. Look at me. FDP, flexor digitorum profundus of index finger, not working. You cannot flex the distal interphalangeal joint of the index finger. Flexor pollicis longus, FPL is not working. You cannot flex the distal interphalangeal joint or interphalangeal joint of thumb. And if you cannot flex the interphalangeal joint of thumb and the distal interphalangeal joint of the index finger, then you cannot make a OK sign in a circular manner. You'll make a collapsed OK like this here. The moment you ask the patient to make a OK, he'll make a OK like this. The normal OK is like this, and that's a collapsed OK sign. The weak OK sign is there because the distal interphalangeal joint of the index finger and the interphalangeal joint of thumb is not getting flexed, as FDP of lateral side and flexor pollicis longus is not working. So weak OK sign will be there in the median nerve injury, in the anterior introitious nerve injury. Finally, ulnar nerve, before we switch on to our next topic, guys, ulnar nerve. Now, when you look at the ulnar nerve, again, just like median nerve, ulnar nerve is not supplying anything significant in the arm and forearm. The first muscle supplied by the ulnar nerve is again after the elbow only. So guys, ulnar nerve, it passes behind the medial epicondyle, as you can see. Then it comes into the anterior compartment, passes superficial to the flexor retinaculum, and then it goes through a canal called as a Guyon's canal. It's a ligamentous canal in the carpal bone called as a Guyon's canal, and then it makes an arch in the hand. Now guys, ulnar nerve, it first of all, it runs between the two heads of flexor carpi annularis. Look at that muscle FCE over there. So there are two origins of flexor carpi annularis. So it is passing between those two origins of flexor carpi annularis, and that space or that tunnel is called as a cubital tunnel. Ulnar nerve can get compressed also there. That is called as a cubital tunnel syndrome. We'll call it the cubital tunnel syndrome. And then only thing left for the ulnar nerve to be supplied in the forearm is flexor digitorum profundus medial half. Lateral to ho gaya. Medial half of flexor digitorum profundus will be supplied by that here. So it will supply we'll come to that. The sequencing is a little different in this. So Guyon's canal, the nerve is going through the Guyon's canal, guys. The main trunk of ulnar nerve, the deep branch of ulnar nerve, that's a deep branch here. The one which is making an arch in the hand is called as a deep branch here. But there is a superficial branch also for the ulnar nerve. There is a superficial branch also for the ulnar nerve. Now, as I said, it supplies flexor digitorum profundus, medial half of flexor digitorum profundus in the forearm. That's only 1.5 muscle. One is flexor carpi annularis, and half of flexor digitorum profundus is supplied by the ulnar nerve. Only 1.5 muscle. And then rest everything, all the muscle of the majority of the muscles of the hand will be supplied by the ulnar. Now superficial branch will supply only one muscle. This ka naam hi superficial branch hai, so that will supply what? What muscle? It will supply the palmaris brevis, the subcutaneous muscle. That's the only muscle supplied by superficial branch and the skin. Deep branch will take care of the majority of the muscles of the hand. It supplies what? It supplies hypothenars, remaining hypothenars. It supplies all interossei. It supplies third and fourth lumbrical, guys. Remember, first and second lumbricals are by median nerve, third and fourth lumbrical are by the ulnar nerve, and then ultimately it ends by supplying the adductor pollicis, which is also called as a graveyard of ulnar nerve. Now, adductor pollicis is the last muscle supplied by the ulnar nerve. Basically, ulnar nerve ends by supplying this muscle. We call it the graveyard of ulnar nerve. Ab dekho, ulnar nerve, this is not, ulnar nerve, there is no issue that whether it is a higher injury or lower injury, obviously there will be ulnar claw hand. Intrinsic muscle of hand will be involved. So whether it is a cubital tunnel syndrome, fracture of medial epicondyle, Guyon's canal syndrome, anything. In any of these cases, obviously there will be claw hand here. But the thing is, if there is an injury at the lower end, then the severity of the claw hand, unlike other nerves, in this case, the severity in the distal injury is actually more. So we have a more severe claw hand, more prominent claw hand in the distal injury, and we have a less prominent claw hand in the proximal injury, and that is called as a ulnar paradox. That is called as a ulnar paradox. And just to explain you guys, distal agar injury hua, if the injury is in the distal part here, so claw hand is there, intrinsic muscle involved, there is a claw hand. Obviously there will be claw hand if there is an injury, distal or proximal, whatever. But in the distal injury, the problem is that the FDP is still working. You already have a claw hand, and the muscle which is responsible for the flexion of the distal interphalangeal joint is working. That will cause more prominent flexion here. And that's why in the ulnar nerve, the distal injuries are more prominent, shows more prominent claw hand compared to the proximal injuries. That is ulnar paradox. So that is about the ulnar nerve and about the upper limb. That is about the upper limb. PDF milega beta, don't worry. Manasa ready, you will get this entire presentation. Don't worry, in the group, in my group, I'll tell you the link also. Let's discuss it first, and then the link and everything will sab mil jaye aapko. Don't worry, all these slides are yours. You can just take it. Main kya karunga inka? Obviously, they are for you to read only. So you will get all the slides. Don't worry. Nobody is moving, guys. Nobody is moving. Come on. Lower limb, guys. Now let's start the lower limb with the lumbar plexus. Let's talk about now the reason I want to discuss a little about the lumbar plexus, because there are some important nerves in the lumbar plexus which is not important only for the lower limb but for the posterior abdominal wall also, and there are some good clinical questions in there. Well, now look at this. First of all, please get oriented to this image. I do not want you to see anything extra and unnecessary here. Just focus on the two muscles. One is the psoas major muscle originating from the lumbar vertebrae, and the iliacus muscle. You're looking at the psoas major muscle which is originating from the lumbar vertebrae, and look at the iliacus muscle taking the origin from the iliac fossa, and then both these muscles, they go together, they form a common tendon called as the iliopsoas tendon, and which inserts on the lesser trochanter. We'll discuss that, we'll come to that in the osteology part. So iliacus and psoas, iliopsoas muscle. Psoas minor can be seen, कोई खास muscle नहीं, कई बार it's not an important muscle. Psoas minor can be seen, but you need to focus on psoas major muscle and the iliacus muscle. And the thing about the psoas major muscle is it is basically hiding the lumbar plexus. The lumbar plexus originates from L1, L2, L3, L4, L5 nerve, and this psoas major muscle is hiding it. It is in front of it here. Now the nerves are having three options. या तो उसको pierce करके बाहर आए. Either the nerves will pierce this and come out. Some nerves will come out from the lateral side and some nerves will come out from the medial side. And that's how you are going to identify the nerves in the lumbar plexus. Look at this picture, guys. Look at this transition there. Now that's a picture. Again, you can appreciate the psoas major muscle. Let me just do it again. That's a muscle only. And this time you're looking at the picture with the muscle but with the nerves here. Now let's start the identification from the top here. Okay. Now what you see, guys, if you look at this nerve here, that nerve over there, it is actually coming out just below deep to this arcuate ligament that is called as a lateral arcuate ligament, and that nerve is a subcostal nerve. That basically is a nerve passing below the 12th rib, so we call it a subcostal nerve. That is a T12 nerve. So when you look at the diaphragm and you look at that lateral arcuate ligament, जो एक ही nerve आपको दिखेगी वहाँ से निकलती, that is subcostal nerve. Generally seen with the subcostal nerve will be seen with the subcostal vessels also, but as of now you're looking at the nerve only here. Okay, then look at the next two nerves here, which are both coming from L1 and then they are bifurcating. And that nerve, these are called as the iliohypogastric and ilioinguinal nerve in that sequence here. We have iliohypogastric and then ऊपर वाला iliohypogastric, नीचे वाला ilioinguinal nerve, the nerve supplying the abdominal wall, muscles of the abdominal wall. Now look at the muscles, the nerve which are coming out. Some are lateral to psoas major, some medial to psoas major, some piercing the psoas major. Now the one which is piercing the psoas major muscle and coming out is the genitofemoral nerve. I'll tell you more about these couple of important nerves separately also. Now that nerve is called as the genitofemoral nerve. So if you're looking at the psoas major muscle, then you're looking at a nerve piercing the muscle and coming out, that is the genitofemoral nerve. That's a genitofemoral nerve. Then look at the nerve, guys, which is present, which is coming out lateral. Again, it is emerging from the psoas major muscle, behind the psoas major muscle. But important thing is it is winding inside the iliac fossa. It is winding inside. Iliac fossa के अंदर move कर रहा है. It is running within the iliac fossa inside the iliacus muscle, and then it will be crossing the inguinal ligament, sometime piercing the inguinal ligament also. That is the lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. And then look at these two important nerves, guys. Look at these two important nerves. One medial to the psoas major, one lateral to psoas major. The one which is medial to the psoas major, that thin nerve over there, if I just continue, look at my finger here, if I continue like this, it will run into the pelvis and will come out from this foramen here. That is what foramen? Obturator foramen. So obviously what nerve is that? That is the obturator nerve. And the nerve which is running between the iliacus and psoas major muscle is the main nerve passing deep to the inguinal ligament, and it's the main nerve supplying the anterior compartment of the thigh, that is the femoral nerve. So psoas major के lateral है तो femoral nerve, psoas major के medial दिख रहा है आपको, that is the obturator nerve. So these are the branches of the lumbar plexus, and that's how you're going to identify them, guys. That's how you're going to identify them. Now look at this. I want all of you to please look at the screen, guys. Out of all these nerves, look at the subcostal nerve, iliohypogastric nerve and ilioinguinal nerve. Now the importance of these nerves as per this discussion is that these nerves are also forming the posterior relation of kidney. Now they are present just behind the kidney. Look at this again. They're forming the posterior relation of kidney, and that's why these nerves are vulnerable to injury when obviously you approach the kidney surgically from the posterior side. So subcostal nerve, iliohypogastric nerve, ilioinguinal nerve, renal bed. They are present in the renal bed, or you can say they are in the posterior relation of the kidney. Genitofemoral nerve, lateral cutaneous nerve thigh, and femoral nerve. Look at these three, guys. Look at these three nerves, and obviously toward the right side, or left में हो नहीं सकता, they are forming cecal bed. These nerves are present in the cecal bed. Look at that over there. You can see that that is a cecum over there. So cecum is basically covering these three nerves. It is present in front of the genitofemoral nerve, lateral cutaneous nerve of thigh, and the femoral nerve. So the nerve which are vulnerable to injury behind the cecum, especially if there's a retrocecal appendix and you're trying to explore that appendix here, you obviously can injure any of these nerves. And then obturator nerve, which is running within the pelvic fossa, that is in close relation to the ovary. That is in close relation to the ovary. So these are the nerves which are present coming from the lumbar plexus, and a few important relations of the nerve to the viscera here. So, important, yeah, you don't have to sit down and read all the relations here. Nobody's going to remember all the relations, right? There are certain relations that you need to remember, the important one, and these are the one important relations because they are forming some important relation to the viscera. Now, out of all these guys, the psoas major muscle was one of the questions. The psoas abscess was one of the questions asked in the last NEET exam. Now, the psoas major, if you know the psoas major muscle, you can make out the psoas major muscle ka shape, and you can make out the psoas abscess also. You can see the lumbar vertebrae, you can see the muscle which is running along with that. That's a psoas major muscle, and that's a picture of a psoas abscess only. That's a bone here. That's a iliac bone. Iliac bone के अंदर जो मसल दिख रहा है आपको, this muscle is iliacus. That muscle is psoas major. और iliac bone के बाहर अगर आपको muscle दिख रहे हैं, these are the gluteal muscles obviously. These are the gluteal muscles there. That's a iliacus muscle. That's a psoas major. Together they will form the iliopsoas tendon here, and that's a picture of the psoas abscess. And that psoas abscess obviously can track along with the psoas major muscle, can come downward to the lesser trochanter, mimicking the inguinal hernia also. Now, look at this nerve, guys. Again, coming back, the same nerve, that's a genitofemoral nerve. Now, tell you a little more about the genitofemoral nerve because there are some questions asked on this. Guys, genitofemoral nerve के दो branches है. When the genitofemoral nerve pierces the psoas major muscle, it is having a nerve which is called, it is having a branch, the one which is more laterally placed is called as the femoral branch of genitofemoral nerve. And this femoral branch of genitofemoral nerve, as you can see the branches coming out, they're supplying the skin over the femoral triangle. Look at that, they're supplying the skin over the femoral triangle. Whereas the genital branch of genitofemoral nerve, which is like more medially placed, makes sense also. It is more medially placed because it has to go into the spermatic cord and supply the cremastric muscle. Cremastric muscle. Now there are two important questions. One of them is a very recent question only. One is that genitofemoral nerve will form the afferent as well as efferent of the cremastric reflex. Femoral branch will take the afferent, and genital branch will bring the efferent of the cremastric reflex. And number two, one of the recent question only, in femoral vein cannulation. Obviously, when you do the femoral vein cannulation, you will do it from the femoral triangle only. Then obviously, which nerve need to be anesthetized here? And that is the femoral branch of genitofemoral nerve. So, afferent and efferent limbs of cremastric reflexes by genitofemoral nerve. And this femoral branch of the genitofemoral nerve need to be anesthetized in the femoral vein cannulation because that's the nerve supplying the skin over the femoral triangle. Supplying the skin over the femoral triangle. Another nerve, guys, another important question. Some of you have already given the answer for that here. Look at the nerve which is again coming out from behind the psoas major, but how you identified it? Look at the nerve running within the iliac fossa. Iliac fossa के अंदर से होके आ रही nerve, and then it is either piercing the inguinal ligament or passing deep to the inguinal ligament or passing superficial to the inguinal ligament. Anything is possible. कोई भी relation हो सकता है. Now this nerve is called as the lateral cutaneous nerve of thigh. The thigh is supplied by three cutaneous nerves, the lateral, intermediate and medial. And only lateral cutaneous nerve of thigh is coming directly from the lumbar plexus. That's the lateral cutaneous nerve of thigh, or lateral femoral cutaneous nerve you can say. And this lateral cutaneous nerve of thigh, if it get compressed deep to the inguinal ligament, like in extreme squatting, if you go in a deep squat, prolonged lithotomy position, or any condition, if the nerve get compressed over there, that will cause this burning and tingling sensation on the lateral side of thigh. That is called as a meralgia paresthetica. Wonderful. That is meralgia paresthetica. You all smart people, you know this. Okay. I need to take a 10-second vocal rest. Okay, chalo guys, moving on. Chalo, let's talk about some osteology here. Now, when you're looking at this hip bone and the femur from the front, now what you look at, that the two bony prominences which I marked over there, those circle here, that is the anterior superior iliac spine and anterior inferior iliac spine. Anterior superior iliac spine is giving attachment to the inguinal ligament and the origin of the sartorius muscle. ASIS, it's an inguinal ligament attachment and the sartorius muscle origin of sartorius muscle. And AIIS, anterior inferior iliac spine, will give origin to the rectus femoris. To be more precise, the straight head of rectus femoris, or simply let's go rectus femoris. Now sartorius and rectus femoris, the two muscles of the anterior compartment of thigh, and taking origin from the hip bone, so obviously इनको femur के सामने से जाना पड़ेगा. Both these muscles will take the origin, and obviously both these muscles, they will go downward, they will go in front of the femur, in front of the hip joint here, and that's why both of them are the flexors of the hip joint here. They have other functions also, but at the hip joint, both sartorius and rectus femoris, they cause flexion. They both are the flexors of the hip joint. What do you see over there? You can see the greater trochanter. Lesser trochanter can be appreciated better from the posterior view. I'll show you in the next picture here. Greater trochanter, anteriorly, anterior surface of greater trochanter gives attachment to the gluteus minimus muscle, guys. Please, ये trochanter की muscle जरूर याद रखना है आपको. Gluteus minimus muscle is inserted on the anterior surface of the greater trochanter, and gluteus minimus is one of the muscle which cause the abduction at the hip, and not only abduction, it also causes the internal rotation also. Internal rotation of the hip. The gluteus minimus muscle is a muscle for the abduction and internal rotation. It's a weak abductor and internal rotator, but yes, the muscle is there and that is causing the internal rotation and the abduction at the hip joint. Now that's the minimus muscle you can see from the front. Let's turn this entire thing, guys. Let's turn this picture. The moment you turn this picture, now you're looking at from the posterior side. Now when you look at this hip bone and the femur from the posterior side, again, I wanted to take your attention to the greater trochanter. Look at the muscle on the greater trochanter there. That muscle is inserted on the lateral side of greater trochanter, and that is gluteus medius muscle. Now very, very important muscle, the gluteus medius muscle. This gluteus medius muscle, which is inserted on the greater trochanter, now this muscle is also for the internal rotation and abductor, and it's a major abductor of the hip joint here. That is a major abductor of the hip joint. Now gluteus medius muscle and gluteus minimus muscle, that means they both are attached to the greater trochanter, guys. So if you get a question like the greater trochanter fracture, look at this picture. Looking at the trochanteric fracture can be seen here. You can see there's a fragment, the greater trochanter fragment is kind of fractured there. Well, the muscle which will get disrupted in this case is the gluteus minimus and medius. Maximus nahi hoga. Why? Because gluteus maximus muscle is not attached to the trochanter. The one of the major attachment, one of the major bony attachment of gluteus maximus muscle is actually on the look. Can you see the gruff area over there? That's the gluteal tuberosity, and on the gluteal tuberosity we have the insertion for the gluteus maximus muscle. The gluteus maximus muscle, which is the extensor and the external rotator of the hip, guys. External rotator. It's an extensor and the external rotator. It's a main muscle for the extension at the hip joint and also helps in the external rotation. As I said, lesser trochanter is better visible from posterior side. Lesser trochanter projection पीछे की side पे होती है. So you can see the lesser trochanter better from this posterior side. Now this lesser trochanter is giving insertion. It is giving insertion to which muscle? Iliopsoas. Now you will say how iliopsoas is inserted to it. अभी lesser trochanter तो उधर present है. Iliopsoas will come from the front here. Well guys, if this is a femur here, iliopsoas muscle will come from the front here, and then they will turn and then attach to the lesser trochanter here. That actually provides a more effective torque to these muscles here. So iliopsoas muscle आगे से आके turn करके then they will insert to the lesser trochanter, and that's how they are effective flexor of the hip joint also. The iliopsoas muscle, they are the effective flexor of the hip joint. They flexes the hip joint. Another important bony prominence, which also is one of the previous year question, is this, guys. Ischial spine. Now that is a greater sciatic notch. Look at, that's a greater sciatic notch here, and that's a lesser sciatic notch. And in between them, this bony spine here is called as the ischial spine here. Now there are some structures which are related to ischial spine, which are coming out of the greater sciatic notch and then entering into the lesser sciatic notch. The reason is basically these structures are coming from the pelvis and they're getting inside the perineum here. And those structures are famously called as a pin structures. Pin, pudendal nerve, internal pudendal vessel, and nerve to obturator internus. Look at those, guys. Those are pin structures over pudendal nerve, internal pudendal vessel, and nerve to obturator internus. And out of this, the pudendal nerve is something you need to keep an eye on, because pudendal nerve supplies the muscles of the perineum. That's an important nerve which supplies the muscles of perineum here. So if the question, this is how the question was. If there is an injury to the ischial spine, or the nerve which is injured while doing the blockage at the level of the ischial spine is a pudendal nerve, the pudendal nerve is injured, then obviously what muscle will get affected? The perineal muscle will get affected. All the ischiocavernosus, the bulbospongiosus, perineal transverse perineal muscle, external sphincter. So all those muscles will get affected if the injury to the pudendal nerve is there at the level of ischial spine. So that's the three important structures which are running on the ischial spine. In fact, the pudendal nerve block is done against the ischial spine only. Nerve to obturator internus is also there. Yes, nerve to obturator internus is also there. That is, obturator internus is a muscle of the ischiorectal fossa of perineum also, and it's a muscle of the gluteal region also. Now guys, look at this. Now on the next picture that you're looking at here, now what you're looking at right now, can you see a band on the lateral side here? Now that band on the lateral side is a modification of the deep fascia of thigh, and that is called as the fascia lata, guys. Fascia lata, iliotibial tract, which is a modification of fascia lata, I'm sorry. This iliotibial band is present on the lateral side of thigh. We call it iliotibial band because it starts from the iliac bone and inserts to the lateral tibial condyle. Fibula pene, guys, lateral tibial condyle by attached, that is the iliotibial band. To good questions there. The iliotibial band, first of all, it is giving insertion to two muscle. One is the tensor fascial lata. Look at that muscle, that small muscle seen on the lateral side is tensor fascial lata. One of the gluteal muscle only, supplied by superior gluteal nerve. And we have a gluteus maximus. Can you see the attachment of gluteus maximus to the gluteal tuberosity? Look at that, guys. The one which we just discussed here. Gluteal tuberosity giving attachment to gluteus maximus. And the upper part of this gluteus maximus is inserted to the tensor fascial lata, the tensor fascial lata. The lower part of gluteus maximus helps more in the extension. Upper part of gluteus maximus helps more in the external rotation. So gluteus maximus and tensor fascial lata, these are the two muscles which are inserted on the iliotibial band. Now, in case of iliotibial band contracture, if there is a IT band contracture, what will happen, guys? Like in case of poliomyelitis, there is a contracture of iliotibial band. The hip joint will presume a position of the flexion, abduction, and external rotation. Your hip joint will be flexed, abducted, and external rotated here. And that is a Faber position. The hip joint is in Faber position. Flexion, abduction, and external rotation. And knee joint, you can see the knee joint is also, now knee joint is also flexed. The iliotibial band is attached to the lateral side, so tibia is also rotated laterally. So knee joint is also flexed, and there is an external rotation of the tibia. There is ER is external rotation of tibia here. So in case of the IT band contracture, there is a Faber position of the hip joint, and there is this flexion and external rotation of the tibia as well. Okay, moving on, guys, look at the muscles of the anterior compartment. One of the, again, recent question asked. Now, you're looking at all the muscles, most of the muscles of the anterior compartment of thigh, and let me compare this atlas image with one of the real-time cadaveric picture here. Now, let me just put these two muscles side by side, and let's try to compare them here. Now, first of all, when you're looking at the anterior compartment, guys, first of all, look at the muscle sartorius, the most superficial and the longest muscle, the easy to identify muscle. The moment you look at the sartorius muscle, you can basically divide the entire thigh in two parts. One, you're looking toward the medial side of the sartorius and the lateral side of sartorius. Now this is sartorius muscle, guys. Sartorius muscle is crossing the hip joint also, and you can see it is coming toward the medial side and crossing the knee joint also before it attached to the medial surface of the upper end of tibia. That's a sartorius muscle. Action of sartorius muscle can be remembered if you knew what happened in the contracture of iliotibial band. जो iliotibial band के contracture में हुआ था, whatever function of the hip joint and knee joint can be remembered from that. Like Faber, sartorius is also doing the Faber at the hip joint. It is also causing the flexion, abduction, and external rotation at the hip. And knee joint, it is crossing the knee joint. It is crossing the knee joint from the posterior side, so it is causing the flexion at the knee joint also, guys. So sartorius is causing flexion, abduction, and external rotation at the hip joint, and flexion at the knee joint here, and the flexion at the knee joint here. So this, the question asked was, they gave the action, and they asked that this is the action of which of the following muscle, and sartorius muscle was to be identified in that image based question here. So flexion, external rotation, and abduction at the hip, and flexion at the knee joint is a function of sartorius. Now, if I look at lateral to sartorius, guys, look at this muscle which is cut over there, and that muscle is rectus femoris. That muscle there is a rectus femoris muscle here. You can see the cut end of the muscle over there. That is a rectus femoris muscle. Now, rectus femoris muscle, we already saw it is coming from where? From the hip bone, from the anterior inferior iliac spine, and it was causing the flexion at the hip joint. The rectus femoris is causing the flexion at the hip joint because muscle सामने से आ रहा है hip joint का, and now this muscle is obviously passing in front of the knee joint, so it is causing the extension at the knee joint. So flexion at the hip and extension at the knee, that's a function of the rectus femoris muscle. Quadriceps femoris muscle is having 4 parts, but only rectus femoris muscle is crossing both the joints. Vasta तो अंदर ही है ना, देखो vastus intermedius, look at that, vastus intermedius, vastus lateralis, vastus medialis. These muscles are only helping in the knee extension. They have no function at the hip joint. The only part of quadriceps muscle which is having a function at the hip joint also is rectus femoris, क्योंकि वो hip bone से originate कर रहा है. Again, in that picture also you can see that is vastus medialis and that is vastus lateralis, more lateral to the rectus femoris. Now this was the view lateral to the sartorius. अब जरा देखते हैं medial to sartorius, guys. Now look at medial to sartorius and start looking from the very much lateral side. You already know these two muscles here. Now that muscle is what? Iliacus. You know already that. That muscle is iliacus. The next muscle is what? Psoas major. आप देख रहे हैं दोनों साथ में आ रहे हैं, iliopsoas. The next muscle you see over there is a pectineus muscle, and the next one is the adductor longus, guys. Although it is the anterior compartment we are looking at, but adductor longus is also visible there. Iliacus, psoas major, pectineus, and adductor longus. From lateral to medial, these are the muscles which are also contributing in the formation of the floor of the femoral triangle. They are forming the floor of the femoral triangle, guys. Iliacus, psoas major, pectineus, and adductor longus, they are forming the floor of the femoral triangle. Honeymoon muscle is, well, leave it. Okay, now that was about the muscle part here. Now guys, the nerve which is supplying the anterior compartment of thigh, the femoral nerve. Let's talk a little about the femoral nerve here, guys. The femoral nerve starting from L2, L3, L4, the femoral nerve is passing deep to the inguinal ligament. Now the femoral nerve, after passing deep to the inguinal ligament, divides into the anterior and posterior division, right? The femoral nerve divides into anterior and posterior division. The anterior division of femoral nerve, the anterior division of femoral nerve, it supplies only one muscle, and that is sartorius. It just supplies one muscle. First of all, trunk supplies two muscles, iliacus and pectineus. The two muscles supplied by the trunk is iliacus and pectineus by the femoral nerve. Iliacus and pectineus, and not psoas major. Be careful. It's iliacus and pectineus. Anterior division supplies the sartorius muscle. And see, the name says anterior. Anterior मतलब आगे सोचना आपको. Anterior division supplies the sartorius muscle, and what you can think more anterior to sartorius is skin only. So apart from sartorius, it gives off the two cutaneous branches called as intermediate and the medial cutaneous nerve of thigh. You already know that lateral cutaneous nerve of thigh is coming directly from the lumbar plexus. It's the medial and intermediate cutaneous nerve of thigh. Posterior division is supplying the hip joint. One, it supplies hip joint, and posterior division also supplies the quadriceps muscle, quadriceps femoris muscle, all part of it, rectus femoris, vastus lateralis, intermedius, they're all supplied by the posterior division. But that is still not the end, guys. Posterior division will continue as the longest cutaneous nerve in the body, and that is called as the saphenous nerve, and we call it saphenous nerve because it runs with the great saphenous vein. It runs with the great saphenous vein, and that's how it is going to supply the skin on the medial side of the leg and foot. It supplies the skin on the medial side of the leg and foot till the ball of great toe. Till the ball of great toe. So saphenous nerve is a branch of femoral nerve, and that is running with the great saphenous vein. Hip joint pain, guys. The pain of hip joint can be referred to the medial side of leg. देखो ना, hip joint is supplied by posterior division, and then skin on the medial side of leg and foot is also supplied by the femoral nerve. So hip joint की जो pain होते, they can be referred to the medial side of leg and foot because of femoral nerve only. Femoral nerve is responsible for the referred pain of hip joint to the medial side of leg and foot. To the medial side of leg and foot. Rajat sir will talk more about the gracilis muscle in detail. And the people who are asking when the session is going to get over, यार मुझे तो घर जाने की कोई वो नहीं है. If you are the one, you can always watch it later also. But I would still say, if you are sitting there, let's stick to it. Whatever the plan is, let's finish it off. Doesn't matter if the class finishes at 11 o'clock or finishes at 11:30 or whatever. I don't care. I just want to finish off whatever plan I have with me. उससे पहले तो मैं उठने वाला हूँ नहीं यहाँ से. Okay, I'm not. Hi, Dr. Ranjit. Good to see you, man. Thank you for being here. Chalo guys, moving on. Now from the femoral nerve, let's now move on to the gluteal region. Now, first of all, if you get an image-based question on the gluteal region, presume that the gluteus maximus muscle is either reflected or it is cut. Because if the gluteus maximus muscle is intact there, then obviously you will not be able to visualize the muscles, the other muscles, and the the nerves and vessels in that area here. So in this picture, the gluteus maximus muscle is removed, and you can see the gluteus medius is intact. Now when the gluteus medius muscle is intact, the gluteus minimus is not visible because वो उसके भी deep present है यहाँ पे. Now, let me just first compare this picture because it's more likely to get an image-based question, a cadaveric image-based question in this image. So, like, I'm just trying to compare this one with this image here. Okay, now, first of all, that's a gluteus medius muscle. You can see on both the sides, that's a maximus muscle is being removed. That's a maximus muscle. You can see intact maximus is hiding everything here. The maximus is removed, and you can see the medius muscle. And then a very, very important muscle, if you are looking at the gluteal region, the muscle which will help you identify the nerves and vessel in that area is the next muscle, that is piriformis. Look at that muscle, guys, coming from the greater sciatic notch. That's a greater sciatic notch there, and that's the piriformis muscle coming out from there. Look at that piriformis muscle coming out from the greater sciatic notch. You can clearly see the tendon of this piriformis muscle going toward the greater trochanter. Below piriformis, now I want all of you to look here, guys. Below piriformis, look at this set over there. Now, can you see a tendon? Can you see that whitish tendon in between? So that is a tendon of obturator internus muscle, जिसके ऊपर और नीचे gemellai muscle है. We have a gemellus superior and gemellus inferior here. So that is an obturator internus tendon. Look at this whitish tendon over there, and we have a gemellus superior and gemellus inferior. Look at that on that side also. In fact, it is better visible in this cadaveric picture here. So we have this obturator internus tendon in the center, in the middle. Above and below we have a gemellus superior and gemellus inferior, and just below that we have one more muscle present over there, which is a quadrangular muscle in the gluteal region called as a quadratus femoris. Quadratus femoris. It usually actually boils down to identification of the structures in the gluteal region, guys. So gluteus medius was one of the very recent question asked only. Now, if you, first of all, if you, although I'm not showing a picture for that here, if you look at any nerve or vessel coming out above the piriform, यहाँ से कोई nerve or vessel निकल के आ रहा है ऊपर से, that's superior gluteal nerve and vessel. If you see a nerve and vessel is coming out below the piriformis, that is inferior gluteal nerve and vessel. So superior and inferior gluteal nerves and vessels are identified based on this piriformis muscle. You got to see it above and below that. Even the sciatic nerve will come out below the piriformis only, which I will discuss with you separately. Now, gluteus medius muscle. Now again, let's focus on the gluteus medius muscle, guys. A normal gluteus medius muscle, we said it is a muscle for the internal rotation, and main action is the abduction. So in the normal position, you can see if let's say in this case the left foot is off the ground and still the pelvis is leveled, because right side gluteus medius is intact, it's normal, and that is not allowing the pelvis of the right side gluteus medius is not allowing the left pelvis to drop down. But let's say if there is a superior gluteal nerve injury, the nerve which is supplying the gluteus medius muscle, if there is a superior gluteal nerve injury, then obviously gluteus medius muscle will not be working, will not be able to hold the pelvis at the same level, and if the moment you take the foot off the ground, that pelvis will drop here. You can see not able to hold the weight of the pelvis, it is dropping down because the opposite side, gluteus medius, is not working. So let's say if you ask the patient to raise the left leg off the ground and the left pelvis is dropping, that is because of the right gluteus medius and the right superior gluteal nerve injury. The Trendelenburg test, the Trendelenburg sign. I have to read all these messages, guys. I have to read all these messages, but after the session is done, I'm so tempted to read whatever you people are writing in between, but I really want to stay focused because we have to discuss a lot of it. Chalo. Next, guys, the nerve, that major nerve we'll discuss here is the sciatic nerve. Now the nerve which is starting from L4, L5, S1, S2, S3, the lumbosacral plexus. The sciatic nerve, guys, first of all, it in the gluteal region, we just saw the piriformis muscle. The nerve will pass deep to the piriformis. Not supplying it, it is passing deep to the piriformis, sometimes piercing piriformis also. In piriformis syndrome, the nerve can get involved as well. So that's passing deep to the piriformis muscle. The nerve reaches the hamstring compartment, and in the hamstring compartment, the sciatic nerve supplies all hamstrings. Semitendinosus, semimembranosus, the biceps femoris, arrector magnus, all of them. Now once the nerve enters the popliteal fossa, look at the diamond shaped fossa, the popliteal fossa. In the beginning of the popliteal fossa only, the nerve divides into the tibial nerve. The tibial nerve which runs straight below, and then we have this common peroneal nerve which is going toward the lateral side. The common peroneal nerve, the tibial nerve to piche ja raha, guys. Tibial nerve is the one which is going to supply the calf muscle, that is going posteriorly. The common peroneal nerve, as you can see in that image, it is basically going toward the fibula. It is winding around the neck of the fibula and then dividing into these two branches here. And that's the vulnerable site of injury also. We all know that fibular neck fracture, the common peroneal nerve is injured here. So once the common peroneal nerve winds around the neck of fibula, the nerve which is supplying the anterior compartment is the deep peroneal nerve, and the nerve supplying the lateral compartment is the superficial peroneal nerve. Look at the DPN and SPN, the superficial peroneal nerve and deep peroneal nerve. Now if I focus on the tibial nerve first, tibial nerve is the nerve of the posterior compartment, calf muscle ko supply kar raha hai, so obviously supplying the plantar flexus, gastrocnemius, soleus, plantaris, all the plantar flexors are supplied by this. It's not only the plantar flexus, this nerve is also supplying the tibialis posterior, and in fact few more muscle like flexor digitorum longus and all, which are inverters. So majority of the inverters, not all of them, but majority of the inverters are also supplied by the tibial nerve here. So plantar flexors and majority of the inverters. And then this nerve will divide into the foot, into the medial plantar nerve and lateral plantar nerve, supplying the muscles of the sole of foot, which is not very important to remember. Important thing यहाँ पर ये है guys, plantar flexors are supplied by tibial nerve. Neck of the fibula, once the nerve winds around the neck of the fibula, the deep peroneal nerve, guys, the deep peroneal nerve here, first of all, superficial peroneal nerve is going to supply the everters, the two everters in the leg, peroneus longus and peroneus brevis. The only two muscles are in the lateral compartment of the leg, and both are supplied by the superficial peroneal nerve, the two everters. Deep peroneal nerve is supplying the muscles of anterior compartment. And what are the muscles of anterior compartment of leg? They are dorsiflexors. Dorsiflexors and tibialis anterior also, which is also an inverter here. Dorsiflexor and tibialis anterior, which is an inverter. Tibialis posterior bhi inverter hai, tibialis anterior bhi inverter hai. So inverters are supplied by both tibial nerve as well as deep peroneal nerve. The nerve of the posterior compartment is tibial. The nerve of the lateral compartment is superficial peroneal. The nerve of the anterior compartment is deep peroneal nerve. Now what is the fate? Ultimately, the superficial peroneal nerve goes and supplies the skin on the dorsum of foot. Majority of the dorsum of foot is supplied by superficial peroneal nerve, except the first web space, guys. The first web space is supplied by the deep peroneal nerve. The deep peroneal nerve supplies the skin of the first web space. It supplies the skin between the first and the second toes. The first and second digit के बीच में supply करता है. Okay, now tibial nerve, guys. If the tibial nerve is injured, not a very common site of a individual tibial nerve injury, but let's say if the tibial nerve is injured, in case of tibial nerve injury, obviously which nerve muscles are gone? The plantar plexus are gone here. So in case of tibial nerve injury, obviously the plantar plexus are gone, and the major inverters are also affected here, and that's why the foot will come into what position? It will come into dorsiflex position and everted foot. Dorsiflex and everted foot here, and that is a calcaneovalgus. Look at this picture, guys. Calcaneovalgus foot here, and that is because of a tibial nerve injury, and in that case, obviously the type of gait will be the calcaneal gait. The patient will walk on heel. जो normal gait cycle के अंदर foot flat, heel off, toe off वाले जो stages आते हैं, all stages will not be there. So that is called as a calcaneal gait, guys. That will be a calcaneal gait in the tibial nerve injury. Well, the most common scenario, the common peroneal nerve injury. If the common peroneal nerve is injured, and the injury is usually at the neck of the fibula, the fractured neck of the fibula, which again is one of the recent question. Now, in the common peroneal nerve injury, what will happen? Obviously, deep peroneal nerve is gone and superficial peroneal nerve is gone. Now, because of the common peroneal nerve injury, what will happen, guys? The dorsiflexus and everters दोनों चले गए. Dorsiflexus are gone, so obviously foot will come into plantar flex position, so that is a foot drop. And everters are gone, so foot will come into inverted position. Plantar flex is foot drop, and inverted foot will be there, and that is the equinovarus position of the foot, something like this, the equinovarus position of the foot. And when the foot is dropped and inverted, obviously when you walk with the foot drop, you tend to take a high steps to clear the foot off the ground so that the toes will not drag on the ground, and that is called as a high steppage gait. That is a high steppage gait. High steppage gait. Okay, moving on. Now, guys, just one thing, I want to show you these two pictures here, because at times I've seen people get it wrong here. Great saphenous vein, which we talked about, the nerve running with the great saphenous vein is a saphenous nerve, and saphenous nerve is a branch of femoral nerve, and that is running on the medial side. So let's say in CABG, when you're taking the graft from the great saphenous vein, the nerve which is likely to get injured is the saphenous nerve, which is a branch of femoral nerve. But let's say if you take a graft from the small saphenous vein is the one which is draining into the popliteal vein. Small saphenous vein is present toward the posterior lateral side here, and that is running with the sural nerve. And sural nerve दोनों से आता है, tibial nerve and common peroneal nerve. It is found by the tibial nerve and common peroneal nerve. That sural nerve is basically supplying the skin on the posterior lateral side of the calf here. So if the sural nerve is injured while taking the graft from the short saphenous vein, sensory loss lateral side में होगा, posterior lateral side of calf. If the saphenous nerve is injured while taking a graft from the great saphenous vein, the sensory loss will be seen on the medial side of the leg and foot here. So please don't mix these two nerves with each other. Now, just couple of ligaments I want to discuss with you quickly before we move on to the next topic, guys. The spring ligament. Now, the spring ligament, first of all, get oriented to this image here. You're looking at the foot from the medial side. When you look at the foot from the medial side, look at this ligament, guys, जो calcaneum से जा रहा है. That's a sustentaculum tela. It's a part of calcaneum only. So it's come from the calcaneum and goes to the navicular tuberosity, navicular bone, and that is called as the spring ligament. It is present on the plantar surface, so we also call it the plantar calcaneonavicular ligament. That is also called as the plantar calcaneonavicular ligament, and that ligament is a major support for the head of the talus. It's the main ligament supporting the talus, or it's a main ligament, you can say, of the medial longitudinal arch. If this ligament is broken, the head of the talus will come down and that will become flat foot only. So it's a main ligament supporting the head of the talus. A question पूछा भी हुआ है. Now that's a short and long plantar calcaneocuboid. अगर आप lateral side पे सोचो, although the views from medial side, from the calcaneum to cuboid bone, look at that, from calcaneum to cuboid bone, that ligament is called as a calcaneocuboid. Plantar side पे, on the plantar side, plantar calcaneocuboid ligament. One is long, one is short. Long and short plantar calcaneocuboid ligament, the two major ligaments supporting the lateral longitudinal arch. The two major ligaments supporting the lateral longitudinal arch. Now that's another view. If you see from the plantar surface here, you can see that's a plantar ligament, plantar calcaneocuboid ligament here, and that's a spring ligament over there. That's a view from the inferior side. आपको एक calcaneum bone दिख रहा है, that's a cuboid over there, and that's a navicular over there. That's another view of the same ligament from the inferior aspect. Now, if there's some issue with the light, guys, just one second. Just 1 second, guys. Just 1 second. Don't go anywhere. Don't go anywhere. Sound मत बंद करो. Sound. ये this something happened to this light. Stay there only, guys. Don't go anywhere. The only place you can go is to washroom only. Yes, में कुछ something happened to this light actually. अब एक काम करो, you can just in the meantime you can just get the light from other studio only. Yes, that's what we need. Yeah, I know that you got the Foley's catheter. You can use it. कोई ब्रेक नहीं 5 मिनट का. Just stay there only, guys. सुनील जी, आप दूसरे स्टूडियो से वो ले आओ ना, दूसरी लाइट ला देना बस. Well, as long as you people can hear my voice, I think I should continue the session, because why to waste it? It's just that I'm not visible, but I can still continue. Well, okay, let's continue only, guys. Let's continue. रुकते नहीं है. What you're looking at here, you're looking at the ankle from the medial side. Now you're looking at this ligament here. It's one of the very strong ligament of the ankle called as the deltoid ligament. Well, the deltoid ligament is the one which is basically attached to 4 bones, guys. It's also called as the medial collateral ligament of the ankle. It's a ligament present toward the medial side. Now this deltoid ligament is attached to 4 bones. Obviously it is attached to the medial malleolus, so एक तो obviously tibia हो गया. It is attached to the navicular bone there. It is attached to the calcaneum, and it is also attached to the talus. The posterior fibers are attached to the talus as well here. Posterior fibers are attached to the talus. Look at that. The bones to which the deltoid ligament is attached to. These are the 4 bones. एक बार question आया भी हुआ इसके ऊपर, that to which bone the deltoid ligament is not attached, and the medial cuneiform was in the option here. So it's not attached to this medial cuneiform. It is attached to rest of the bones in there. Okay. Then deltoid ligament, guys, it's such a strong ligament. ये injured होता ही नहीं easily. It's not easily injured. In the eversion injury of the foot are not the common injury. It's the inversion injury which are the common one here. Okay. So this ligament is not usually injured, but if this ligament is injured, if there is extreme eversion at the ankle, so it is usually in combination with the fracture of the lateral malleolus. That's how strong this ligament is. With the fracture of the lateral malleolus, then obviously the range of motion of the foot will be more, and this deltoid ligament can be seen. So it is usually seen in the combination with the fracture of the lateral malleolus, as you can see in this picture here. That's the deltoid ligament present toward the medial side, and you can see that's where this eversion injury is occurring here. And if the ligament get ruptured, that is usually associated with the fracture of this lateral malleolus. If you look the foot from the lateral side, when you look at the foot from the lateral side, is it done? Is it done, Sunilji? Thank you so much. On कर दीजिए एक बार कैमरा प्लीज. And make a full screen, please. Hi, I'm back. So guys, the lateral ligament of the ankle, if you're looking at the foot from the lateral side, then these 3 ligaments over there, you can see the anterior talofibular ligament, we have a posterior talofibular ligament, and calcaneofibular, the 3 ligaments supporting the ankle from the lateral side. Now, out of these 3 ligaments, it's the anterior talofibular ligament which is most commonly injured in the inversion injury of the foot. Inversion का range of motion भी ज़्यादा होता है. Inversion injuries are obviously the more common here, and out of these 3 ligaments, the ligament which is more commonly injured is the anterior talofibular ligament. Now, there is one more ligament which is very commonly injured in the inversion injury if the foot is in the plantar flex position. If the foot is in extreme plantar flex position, there is one more ligament which can get injured there. That is called as a bifurcate ligament, guys. Let me show it to you. Now, just look at the ligament which I'm showing you. बहुत सारे ligament दिख रहे हैं यहाँ पे. Don't get confused. Just focus on that one here. Look at that ligament which is having a stem attached to the calcaneum, and it is bifurcating in 2 parts here. One of the part is attached to the cuboid bone, that's a foot from the lateral side, that's to the cuboid bone, and one is attached to the navicular bone, that's a bifurcate ligament having two bands. We have a ligament called as a calcaneonavicular band is there, you can say calcaneonavicular ligament, and we have a calcaneocuboid band is also there, or calcaneocuboid ligament. So these are the two parts of bifurcated ligament, and that's how this ligament will look like. It's a very nice picture of this bifurcated ligament. Look at the two band over there, the calcaneonavicular to the navicular bone, and calcaneocuboid, that's a cuboid bone in there. And look at this condition here, when the foot is in the plantar flexed position, can like wearing high heels, and if there is an inversion injury, then along with anterior talofibular ligament, this bifurcated ligament also is very commonly injured if the inversion injury takes place at the ankle in the plantar flexed foot. Okay. The next one, guys, which is again one of the question asked here, the ligament, which is basically, it's a complete ligament complex called as the Lisfranc ligament complex is there, but there is a ligament which is basically holding the medial cuneiform to the base of second metatarsal, guys. Medial cuneiform to the base of second metatarsal, that is a Lisfranc ligament here. And this Lisfranc ligament can get injured, let's say this injury can be seen in athletes also, if the foot is in the plantar flex position, and there is too much of forces exerted from above here. Let's say if you jump from the height and you try to land on the toes, like in this condition, look at this picture here. If you jump from the height, there's too much of force from above, and you're trying to land on the toes here, and there could be the rupture of this Lisfranc ligament, and you can see this second metatarsal dislocating more anteriorly. The second metatarsal, if this Lisfranc ligament is broken, what will happen? The gap between the base of first and second metatarsal will increase, and that's very easily or clearly visible in the radiograph also. Have a look at this picture here, have a look at this radiograph, and you can clearly see the gap which is in between this base of first and the second metatarsal here. Lisfranc ligament, we said it is from the medial cuneiform to the base of the second metatarsal. That's where the Lisfranc ligament would be here. The ligament is broken, and you can see the space is widening up more than 2 millimeter. That's a Lisfranc ligament injury. The next chapter, come on, head, neck and face. Now, the next two chapters that we talk about is the head, neck, face and neuroanatomy. Obviously, when I look at the number of questions asked on these topics, like there are way too many questions from there. There are some important topics where we really need to focus on. Now, in the head, neck and face, guys, I'm going to start first with the cranial nerve nuclei, although I'm not going to discuss the cranial nerve nuclei in detail, but there are some important details from the cranial nerve nuclei that I wanted to understand first. There we go. Now, there's a chart, guys. I'm sure you all read about this wherever you attended the class, but you have read about these cranial nerve nuclei column. I know your cranial nerve nuclei bhul jate hain. We tend to forget about these columns. That doesn't matter. Just very quickly, guys. I'll just take 1 minute to quickly explain this thing here, so that when you read these slides, you can kind of understand this. The first column is general somatic efferent. The first column is basically for extraocular and tongue muscle. So whatever nuclei you're looking at here, they're supplying the extraocular and tongue muscle only. 3, 4, 6 and 12. Extraocular and tongue muscle. Second column is SVE, special visceral efferent, pharyngeal arch column hai. The nerves of pharyngeal arches, mandibular nerve, facial nerve, glossopharyngeal nerve, basically nucleus ambiguous is there. So pharyngeal arch column is there. First two columns are basically for skeletal muscle, and the third column, which I'm going to discuss with you separately in detail, that is a GVE column called as a parasympathetic column, because all the parasympathetic nuclei are there, Edinger-Westphal, salivatory nucleus, dorsal nucleus of vagus. I'll discuss this separately with you, so just leave it for now. Then we have afferent columns, the GVA and SVA. The GVA and SVA, we have a common nucleus in them called as the nucleus of tractus solitarius, a very, very important nucleus, guys. Nucleus of tractus solitarius. It's a nucleus which is alone. There is nothing above, there is nothing below this nucleus, and this nucleus of tractus solitarius is a visceral nucleus. The visceral sensation will go into it here. Taste sensation, any visceral sensation will come into it here. So if this nucleus is injured, aap ye maan ke chalo ki visceral sensation is gone. Another column which I will discuss with you separately, that is GSA column, having a trigeminal nuclei, a huge column, an important column. We'll discuss that in separately. And then finally we have a column called as a SSA, special somatic afferent, and that includes vestibular and cochlear nuclei. The vestibular cochlear, the nerves which are carrying the special sensation, and still that area is developing or is somatic in nature here. So again, obviously this is not the time to understand the details of these columns here, but agar hum questions ke point of view se baat kare, guys, what is the important thing to be remembered from these columns here? Now, first of all, the nerves which are important to remember are the parasympathetic cranial nerve, 3, 7, 9, 10, 3, 7, 9, 10. We know the third nerve, 7th nerve, 9th nerve, 10th nerve are parasympathetic. Now, what are the two columns for third nerve, guys? Third nerve, you can see that is a nucleus for third nerve. So one column is GAC, And Edinger-Westphal is also the nucleus for third nerve, so GVE is also column. Guys, the column for third nerve is GAC and GVE, general somatic efferent and general visceral efferent. 7th, 9th and 10th nerve, well, nice and easy guys. 7th, 9th and 10th ज़्यादा कुछ दिमाग लगाना ही नहीं है. 7th, 9th and 10th nerve are related to all columns except first and last. पहले वाले को छोड़ दो, last वाले को छोड़ दो. All the columns are related to the 7th, 9th and 10th nerve. Now what is the reason for that you don't have to go into that here. This is not the time you understand why this column is related to the nerve. अब बस याद रखो कि 7th, 9th and 10th nerve are related to all the columns except the first one and the last one. Except the first one and the last one, all the columns are there for the 7th, 9th and 10th nerve. If the question is asked which of the following column is not related to 7th nerve, you have to choose either GAC or SSA. So you just have to keep the two columns which are not there. बाकी सारे हैं उसके अंदर. Now let's take a couple of columns in detail guys. Now look at the GSA column. पहले GSA column लेते हैं, then I'll take you GVE column because there are some separate questions on that here. Now general somatic afferent, the nuclei which are present inside the general somatic afferent column, this nucleus is called as a trigeminal nuclei. This big trigeminal nuclei is there, present in the midbrain, pons and medulla oblongata, even crossing the medulla oblongata also. Now this trigeminal nuclei is having three parts. We have a mesencephalic nucleus. It's present in the midbrain, so cranial part is called as the mesencephalic. Middle part is called as the principal sensory or chief sensory nucleus. And then we have a spinal nucleus which is present in the medulla oblongata, reaching till the spinal cord also, C2 level of spinal cord. The reason for three different nuclei because they are carrying different function. Mesencephalic nucleus is responsible for proprioception, carrying proprioception. Principal sensory nucleus is for the touch and pressure, and spinal nucleus will receive the pain and temperature. अब face के बारे में सोचो. All the proprioceptive information will go to the mesencephalic nucleus. Touch and pressure sensation goes into the principal sensory nucleus, and all the pain and temperature sensation in the head and neck area will reach the spinal nucleus here. Now this mesencephalic nucleus for some reason has been one of the very important or repeatedly asked question. Mesencephalic nucleus is for proprioception guys. This is the center for jaw reflex also. It is a center for jaw reflex, or you can say mesenteric reflex. And one speciality of this mesencephalic nucleus is it is the only site in central nervous system having pseudo unipolar neuron. CNS के बाहर तो बहुत मिल जाएंगे. Outside CNS we have a lot of pseudo unipolar neuron, but inside CNS this is the only site for pseudo unipolar neuron. That is a mesencephalic nucleus. That's mesencephalic nucleus. Okay, now coming to GV, general visceral efferent. Now the three parts which I have divided over there is midbrain, pons and medulla oblongata. Guys, in midbrain, the GV, general visceral efferent. Now one nucleus there is called as the Edinger-Westphal. Edinger-Westphal nucleus. In the pons we have the two salivatory nucleus called as superior salivatory and inferior salivatory nucleus. And then in the medulla oblongata we have a nucleus called as the dorsal nucleus of vagus. That is called as the dorsal nucleus of vagus. Now Edinger-Westphal, superior salivatory, inferior salivatory, dorsal nucleus of vagus, these nucleus are going to supply the muscles which are either smooth muscle or glands. Now let's take the first one guys. The nerve for the Edinger-Westphal is what? Third nerve. Oculomotor nerve is nerve for the Edinger-Westphal nucleus. Now this third nerve coming from Edinger-Westphal will relay into the ciliary ganglion. Once it relay into the ciliary ganglion, the post-ganglionic fibers, the post-ganglionic nerve, those called as short ciliary nerves, will go out to supply the sphincter pupillae and ciliaris muscle. They will supply the sphincter pupillae and ciliaris. Superior salivatory nucleus, the nerve for superior salivatory nucleus is facial nerve. Now there are two branches of facial nerve we need to consider here guys. One of the branch of facial nerve is called as the greater petrosal nerve, which we are taking first. Now this greater petrosal nerve will relay into the ganglion called the pterygopalatine ganglion, the PPG, the pterygopalatine ganglion, and then the post-ganglionic fiber from pterygopalatine ganglion will supply the lacrimal gland, So it is carrying the secretomotor fiber to lacrimal gland. That is one function of facial nerve, one of the parasympathetic function of facial nerve. Another branch of facial nerve, that is cauda tympani. Cauda tympani is a branch of facial nerve. Now cauda tympani with the help of lingual nerve will relay into the what ganglion? Submandibular ganglion. That will relay into the submandibular ganglion, and from the submandibular ganglion the post-ganglionic fibers will supply submandibular gland and sublingual gland. So yaad rakhna guys, the name says superior salivatory nucleus. Name is superior salivatory nucleus, but that doesn't mean it is only supplying the salivary gland. It is not only supplying the submandibular and sublingual gland, it is supplying the lacrimal gland also. That's the question here. The name says lacrimal gland, but it is supplied by superior salivatory nucleus. Inferior salivatory nucleus, the nerve for inferior salivatory nucleus is glossopharyngeal nerve, the ninth nerve. Now, one of the branch of ninth nerve called as the lesser petrosal nerve, we are not going into the detail of that. that ninth nerve will relay into the otic ganglion. It's very important to know what are the preganglionic nerves of these ganglion here. So ninth nerve relays into the otic ganglion, and the postganglionic fibers from the otic ganglion, which is basically auriculotemporal nerve, supplies the parotid gland. So inferior salivatory nucleus is for the parotid gland. And dorsal, so these are the four parasympathetic ganglion that we have in head and neck here. Dorsal nucleus of vagus, obviously vagus nerve will come out of it. Now vagus nerve is not having a parasympathetic ganglion in head and neck. Vagus nerve के ganglion नीचे होते हैं, below head and neck here. So vagus nerve is basically going down beyond the head and neck and supplying the smooth muscles and glands, mainly in the thorax and in the abdominal cavity. Thorax and in the abdomen here. So that's about the GVE column, the parasympathetic column, guys. Obviously, if it is a parasympathetic column, all these nerves are parasympathetic nerves only. 3, 7, 9, 10, all these nerves are parasympathetic nerve. And if the question says parasympathetic outflow, now we know parasympathetic outflow is also called as a craniosacral outflow. Cranial nerves and sacral nerves together are parasympathetic. Which cranial nerve? 3, 7, 9, 10. Which sacral nerves? S2, S3, S4. So parasympathetic outflow is 3, 7, 9, 10, S2, S3, S4. S2, S3, S4. And sympathetic outflow is thoracolumbar outflow. That means starting from T1 nerve to L2 nerve. T1 to L2 nerve are sympathetic nerve. T1 to L2 nerve are sympathetic nerve. That's sympathetic outflow. Okay, now rule of 17. In the cranial nerve injury, there is one very important rule based on some image-based questions are also asked here, guys. The rule of 17 says that you can write 17 as 10 plus 7 is 17 and 12 plus 5 is also 17. Now 10th nerve and 7th nerve I've written together. The reason is 10th and 7th nerve, they have something in common. Injury to the 10th and 7th nerve, the deviation of the structure they're supplying is always on the contralateral side. Whatever 10th nerve and 12th, 7th nerve will supply, if the injury is to that nerve, the deviation will be seen toward the contralateral side. Like, if you take the example of 10th nerve first, guys. 10th nerve, vagus nerve, like supplying the uvula. So let's say in this picture, the uvula is deviating toward what side? The uvula is deviating toward the uvula is deviating toward the left side. So it's because of the right vagal nerve injury. Right vagal nerve injury, contralateral deviation of the uvula. 7th nerve. In case of 7th nerve, facial nerve. Facial nerve injury, then obviously the angle of mouth, not the jaw, angle of mouth will deviate toward the contralateral side. As you can see, the angle of mouth is deviating toward the left side here. So it's because of the right side facial nerve injury. So in the 10th nerve and 7th nerve lesion, the deviation is seen toward the contralateral side. 12 plus 5, guys. 12 plus 5. In case of 12 plus 5, the deviation will be seen on the ipsilateral side. Like, if there is a hypoglossal nerve injury, guys, in case of hypoglossal nerve injury, the tongue will deviate toward the side of the lesion. You can see if the tongue is deviating toward the left side, as in this picture, it's because of the left hypoglossal nerve injury also. This side का nerve injury, उसी side पे deviation है. The tongue deviates toward the same side when you ask the patient to protrude the tongue. And then 5th nerve, especially the mandibular nerve supplies the muscle of mastication. Now one of the function of muscle of mastication is to push the mandible. Pterygoids push the mandible to the other side here. If the mandibular nerve, or simply if I say trigeminal nerve injury is there, so your jaw will be deviated toward the ipsilateral side. Let's say in this case the jaw is deviated toward the left side, so it's because of the left side nerve injury only. Left mandibular nerve or left trigeminal nerve injury, the deviation is toward the same side here. So ipsilateral deviation in the 10th and 12th and 5th nerve, and 10th and 7th nerve injury, the deviation will be seen toward the contralateral side. Okay, now a picture which is very very important. बहुत बार question आया इसके अंदर से. Now there are two important things we need to understand in this picture, guys. Identifying the nerves and identifying the spaces. Now that's a picture of the transverse section of the neck. Now first what we'll be looking at, the nerves here. Now there are some animated circles which I wanted to people look at here. Look at this one circle over there, which is encircling the nerve there. Look at the second one there, the third one, the fourth one, and the fifth one. Now look at all these rings there. The first one, look at the nerve, guys. That nerve is actually present between the trachea and esophagus in the tracheo-esophageal groove, just medial to the thyroid gland here. That is called as a recurrent laryngeal nerve. That's where the recurrent laryngeal nerve is present. It is exactly between the trachea and esophagus in the tracheo-esophageal groove. The nerve that is present inside the carotid sheath, no question about that. That is the vagus nerve, which is one of the image-based question asked. Vagus nerve is present inside the carotid sheath. Look at the nerve, guys. Now look at that nerve over there, which is present behind the carotid sheath, but in front of the prevertebral fascia. That fascia is prevertebral fascia. So fascia, prevertebral fascia के सामने है, but carotid sheath के पीछे है, and that is a sympathetic chain. Sympathetic chain is between the carotid sheath and prevertebral fascia. Look at the nerve there, which is in front of the scalenus anterior. Like these muscles, this is scalenus anterior, this is scalenus medial, that is scalenus posterior. These are scalene muscles. The nerve which is running in front of the scalenus anterior muscle, but more importantly behind prevertebral fascia, and that is the phrenic nerve. स्केलेनस इंटीरियर सामने रन कर रहा है, बट किसके पीछे? प्रीवर्टेब्रल फेशिया के पीछे, guys. The one which is behind the prevertebral fascia, that is a phrenic nerve. And look at these nerves, guys. When you see the nerve coming out from the spinal cord, they are actually passing between them, the scalenus anterior and medius, and coming out. And that is the brachial plexus. The cervical nerves, whatever cervical nerves will come out from there, the C5, C6, C7, they will contribute to the formation of the brachial plexus running between the scalenus anterior and scalenus medius here. So that's the first job here, to identify the nerves, and that's where these major nerves are present here. Now, let me again just remove the nerve from this picture here, and this time let's look at some important spaces. Now, when you look at some important spaces there, guys, that fascia over there, look at that fascia, obviously the fascia which is present outside the pharynx here, let me just put a pointer there. Look at the fascia which is present around the pharyngeal wall, that is a buccopharyngeal fascia. Buccopharyngeal fascia is one of the extension of pretracheal fascia only. जो thyroid gland को cover कर रहा है, वही same fascia pharynx के around present है, buccopharyngeal fascia. So that is a buccopharyngeal fascia there, that one. Now that fascia which is behind here, that is, we already said that is what fascia? That is a prevertebral fascia. That's a prevertebral fascia. And then there is another fascia in between, which is also called as the anterior layer of prevertebral fascia, also called as the alar fascia. Anterior layer of prevertebral fascia or alar fascia. So you can see three fascias over there. Now, the space which is present between the buccopharyngeal fascia and the alar fascia, that space over there, guys, that space is called as a retropharyngeal space. And this retropharyngeal space is obliterated below. ये नीचे बंद है. At the level of C7 to T4, it is like closed, because the alar fascia and buccopharyngeal fascia in the lower part will fuse. They will fuse with each other, so that space is closed below. But this alar fascia and prevertebral fascia, they never fuse with each other. And that's why the space between the alar fascia and prevertebral fascia, it is this space over there, the one which I'm pointing at right now. Look at that, guys. That space over there is called as a danger space of the neck here. That's a danger space of the neck between the alar fascia and prevertebral fascia, because if this space is open below, this space is open below till the diaphragm. Till the diaphragm here. So any infection or abscess of this space can drop down into the posterior mediastinum and even can cause dysphagia and dyspnea as well. It can cause dysphagia and dyspnea, and that's why it's a danger space of the neck, the dangerous space of the neck. अगर ये आपको longitudinal section भी देते हैं, guys, even if they give you a longitudinal section or something, you just have to look at the space which is continuous below. There's no surprise in this. It's not difficult to identify. Find out the space which is continuing below and reaching till the diaphragm or extending into the posterior mediastinum. That is dangerous space, because that space is extending below. So that's a dangerous space of the neck. Now let's focus on one more thing in the carotid sheath, because carotid sheath is asked as a separate question also, guys. Now let me just take the carotid sheath out of this picture here. Now carotid sheath, if you look at the content, more outside we have a vein, more inside we have artery. Common carotid artery and internal carotid artery is a content, guys. Common carotid artery and internal carotid artery, not external carotid. So content of the carotid sheath is common carotid, internal jugular vein, and vagus nerve. Vagus nerve we already said here. But see, what is the relation, guys? Let's say if you're approaching the carotid sheath anteriorly from the anterior side in the carotid triangle, so what nerve can get injured? The nerve which is, it's not the vagus nerve, because vagus nerve is kind of grooved between the artery and vein. The nerve which is more likely to get injured in the approach to the carotid sheath from the front is the ansa cervicalis. The anterior wall of the carotid sheath, the relation is the ansa cervicalis is adherent to it. और पोस्टीरियर रिलेशन तो हम ऑलरेडी देख ही चुके हैं. द सिंपैथेटिक चेन इज प्रेजेंट बिहाइंड दैट, बिहाइंड द कैरोटिड शीथ, बट इन फ्रंट ऑफ व्हाट फेशिया? प्री-वर्टेब्रल फेशिया. इन फ्रंट ऑफ द प्री-वर्टेब्रल फेशिया. Investing layer, guys, just very quickly about the investing layer. Now in this picture, investing layer is this. You can see the layer which is covering the entire neck, that is called as the investing layer. Now the investing layer of deep cervical fascia is basically enclosing many structures. Investing layer is enclosing the muscles, investing layer is enclosing the glands, enclosing the pulleys and ligaments. So there is a rule of two for the investing layer, which could be a good question to ask. Now first of all, investing layer is covering two muscles. One is the sternocleidomastoid and the trapezius muscle. Second question, investing layer is covering two glands also, parotid gland and submandibular gland. Face के ऊपर there is no deep fascia, guys. There is no deep fascia on the face except for the parotid gland, which is covered in the investing layer only. It is basically forming two ligaments also, the two ligaments of mandible called as stylomandibular and sphenomandibular ligament. It is also enclosing two space, one above the clavicle, one above the sternum and above the clavicle. We call it suprasternal space, also called as a burn space, and there is a supraclavicular space also. And it also forms the two pulleys, guys. Which muscle will node a pulley? Pulley कौन सी muscle को चाहिए? The muscle which is having double belly. So digastric pulley and omohyoid pulley, they are also made up of investing layer. The rule of two for the investing layer, enclosing two muscles, two glands, two ligaments, two spaces, and making two pulleys also. That's about the deep cervical fascia. Okay. Now, this next picture that you're looking at, guys, this is a picture of the cavernous sinus here. Now, relations of cavernous sinus has always been important, guys. Now, if you look at this, this is a cavernous sinus. This all this blue thing is a cavernous sinus here. Now, in the lateral wall of cavernous sinus, I'm sure that's a very common question. Everyone knows about that. We have third nerve, fourth nerve, ophthalmic nerve, and arguably maxillary nerve also. Although Gray's 41st says it's not there, but let's stick to the most of the picture which is given in the books here. So there are four nerves in the lateral wall of the cavernous sinus. We have a third nerve, fourth nerve, ophthalmic nerve, and the maxillary nerve. And the only nerve which is running inside the cavernous sinus and inferior lateral to the internal carotid artery. Internal carotid artery andar hai, inferior lateral to internal carotid artery, that is the abducent nerve, guys. That's the abducent nerve which is inside the cavernous sinus. So cavernous sinus thrombus mein sabse pehle jo nerve jayegi wo abducent nerve jayega. Now, in the internal carotid artery is inside the cavernous sinus. Now, let's say if the internal carotid artery ruptures, if there is an aneurysm of internal carotid artery and that aneurysm ruptures, then there obviously will be the communication between the internal carotid artery and cavernous sinus, and that is a carotido-cavernous fistula. That is a carotido-cavernous fistula. Now, in case of carotido-cavernous fistula, what will happen, guys, when internal carotid artery will pulsate, pura cavernous sinus pulsate karega. And because anterior relation of cavernous sinus is superior orbital fissure, the anterior relation of cavernous sinus is superior orbital fissure, so the cavernous sinus will also pulsate and will push the content of the orbit and will lead to the pulsatile proptosis. Look at this picture, guys. Look at this video here. You can see the pulsatile proptosis. It's a very nice video showing the pulsatile proptosis here. That's because of the carotido-cavernous fistula formed. That's a pulsatile proptosis. Okay, now moving on. The next thing that we're going to discuss here is about the muscles of mastication. One very, very important question and very frequently asked question from the head and neck is the muscle of mastication, about its innervation, about their action and identification. And it could be a radiological question also, guys. Now, first of all, just get oriented based on this small animated video here. Now, what do you see, guys? Now, when you look at this, the temporalis and masseter muscle are outside, and the muscle that we can see inside here, these muscles are the medial pterygoid and the lateral pterygoid. Now, once again, look at this masseter muscle outside and the temporalis inside. Now, I need to pause this video for 1 second. Yes, I need to find out a right place to pause it. Yeah. Now, look at that muscle over there is a medial pterygoid. The medial pterygoid muscle, it is present on the medial side, but the important thing is it is inserted on the medial side of the ramus of mandible, close to the angle of mandible. This is very important. If it is a question to identify if it is a cadaveric picture or especially if it's a radiological image, how will you identify medial pterygoid muscle? It's on the medial surface, medially placed and inserting below. Niche insert, guys. It is inserting like close to the angle of mandible. The muscle which will be higher above, going to the neck of mandible, is a lateral pterygoid muscle. The muscle going higher will be the lateral pterygoid muscle here. Let me just display that video for you once again. Sorry. So that muscle that you see from inside, that's the pterygoid, that's a medial pterygoid muscle. Or jo andar muscle wahan pe dikh rahi, guys, that over there inside going to the neck of the mandible, that is a lateral pterygoid muscle. Let it come back here. That muscle which will be going to the neck over there, that muscle to the neck over there is the lateral pterygoid. Well, guys, see. Now, if you understood this point, let's try to identify the muscle in this here. First of all, if you look at this transverse section here, now here is the mandible. Look at that mandible. You can see the anterior border and posterior border that is thick, and that you can see the ramus in between here. Now, obviously the muscle which is present outside here, that is a masseter muscle. Masseter to bahar present hoga. The muscle for the clenching. So the moment you find out the ramus of mandible, the muscle outside is medial pterygoid. Now, inside, if I go innermost muscle over there is medial pterygoid. Now, guys, if you compare the medial and lateral pterygoid originates from the medial surface of lateral pterygoid plate. ये दोनों muscle lateral pterygoid plate से आती हैं. But the one from the medial surface of lateral pterygoid plate is medial pterygoid, and the one which is from the lateral surface of lateral pterygoid plate is the lateral pterygoid. So obviously, compared to these two muscle, is the lateral pterygoid is inside and medial pterygoid is lateral pterygoid is more outside and medial pterygoid is more inside here. How can this is a temporalis muscle? Now, temporalis muscle is coming from here, but temporalis muscle is inserted on the anterior border and it is inserted some on the medial surface also, guys. There is a coronoid process of the mandible. If I show you this picture here, in fact, I'll show you in the next image, that there is a process over there, is a coronoid process. So temporalis muscle will insert on that process also and to the medial surface of that process as well. So अगर आपको ramus of mandible दिख रहा है, so muscle outside is masseter. Muscle inside, more inside is medial pterygoid than lateral pterygoid, and the muscle that you see close to the anterior border but inside, that is temporalis muscle. that is temporalis muscle. Now that's a coronal section, transverse. If you take an axial section or the coronal section here, how you identify in this section, guys, look at this. Once again, you're looking at the mandible here. Now, first of all, the one muscle which is not confusing at all is temporalis. The muscle coming from temporal fossa, that's a temporalis muscle. Now, if this is a ramus of mandible, that muscle outside is masseter, no question about that. Now, look at how you identify these two muscles. Now, I told you the muscle which is inserted below, jo niche insert ho raha hai, close to the lower part here, that is medial pterygoid, and the one which is inserting to the neck, that is lateral pterygoid. So, in this section, I rather than appreciating which muscle is medial and lateral, I'm looking at which muscle is below and which is above. The muscle which is coming below to the medial surface, that is medial pterygoid, and the muscle which is above, which will be going to the neck of the mandible, that is lateral pterygoid here. So in the transverse section, muscle outside masseter, ऊपर से आ रहा है temporalis. If you're looking at the medial side, ऊपर वाला lateral pterygoid, नीचे वाला medial pterygoid. The one which is below is lateral medial pterygoid. Let's take the individual action of these muscle, guys. Now, first of all, temporalis muscle. If you're looking at the temporalis muscle alone here, look at the fibers of temporalis muscle. The most of the temporalis muscle fiber, the anterior fiber of temporalis muscle will pull the mandible up. So they are mainly for the elevation. So one function of temporalis is elevation, that is closing of mouth. And the unique action of temporalis is a retraction. It will pull the mandible back. So this muscle helps in the retraction also, guys. Elevation and retraction, the two functions of the temporalis muscle. Masseter muscle. The masseter muscle is outside. That muscle is masseter there. When the muscle will contract, obviously this will pull the mandible toward the zygomatic bone. So once again, one action is elevation. That's the main action. But it also helps in protrusion. सीधा muscle तो है नहीं, थोड़ा सा obliquely placed है, so it helps in the protrusion. Helps in protrusion, but the main action is elevation. Again, closing of mouth. Look at that muscle, guys. Medial pterygoid. I wanted to focus on the medial pterygoid. देखो, जो ऊपर है वो lateral pterygoid. Once you remove the ramus of mandible, then you can see the ऊपर वाला muscle is lateral pterygoid. The one which is below and deep, that is medial pterygoid. Now, orientation of medial pterygoid and masseter muscle is more or less the same. So medial pterygoid is also helping in what? That is also helping in elevation and also is a weak protractor. Masseter and medial pterygoid, they both help in protraction, but दोनों का यहाँ पर main काम क्या है? Elevation. And then comes the final muscle, that is lateral pterygoid. There are two bellies of lateral pterygoid. You can see you have a superior and the inferior head here. Now, lateral pterygoid muscle, it's a unique muscle, guys. Out of the question asked, image-based question asked here, majority of the time their question is on lateral pterygoid here. Now, lateral pterygoid muscle is inserting posteriorly. It is coming back and attaching to the capsule and to the neck of mandible, guys. So, lateral pterygoid muscle जब contract करेगा, तो it will take the mandible forward. So, it's a major protractor and the only depressor. The major protractor and the only depressor. These two muscles are also causing the protraction, but the main protraction is by lateral pterygoid, and it is the only depressor. Like the only retractor is temporalis, the only depressor is the lateral pterygoid from the muscle of mastication. हम muscle of mastication बाहर की बात नहीं कर रहे हैं. In the muscle of mastication, the only depressor or the only muscle which will help in the opening of mouth is the lateral pterygoid. The thing in this question is identify the muscle. Identify the muscle in the different section, guys. Coronal, transverse, whatever it is. If you have an idea about that, which muscle is outside the ramus, which is inside the ramus, which is above, which is below, which is medial, which is lateral, you'll be able to identify it, and then they will ask you the question based on its first you identify it and then the question on their action. Now, whatever action we're discussing right now, these are the bilateral actions. When these muscles are working bilaterally, both sides. If the pterygoids of one side will work, let's say if the lateral and medial pterygoid of only one side will work, they will push the mandible to the other side. If my right side pterygoid will contract, not the left one, only right side pterygoids will contract, they will push the mandible toward the left side. So, its unilateral action of pterygoid is to push the mandible to the other side. So, the so-called sideways movement of the jaw here. Right side of the pterygoid will push the mandible to the left side and vice versa. In the triangles of neck, well, there are so many things in the triangles of neck, but when you look at the previous year questions and when you realize that what is important in there, guys, there are a couple of structures that you mainly need to focus on because questions घूम फिर के उन्हीं के ऊपर आते हैं. देखो, now in the triangles of neck, just to give an orientation, that muscle that you're looking at here is the sternocleidomastoid, and this muscle here is a trapezius muscle. Sternocleidomastoid and the trapezius muscle. Now, out of many cutaneous nerve present in this posterior triangle, the one important and the major cutaneous nerve, which is basically running above, the nerve which will go above, that nerve is the great auricular nerve. There's a nerve which will go above, that is called as a great auricular nerve, like this. It is coming from this point called as a nerve point, which is behind the sternocleidomastoid. Many other cutaneous nerves are coming from there, piercing the investing layer of deep cervical fascia, and this nerve will go above, called as a great auricular nerve. Now this great auricular nerve is basically dividing into two branches, which when it goes above, one branch which is going forward toward the face, that is called as the facial branch, anterior branch bolte hain, and we have a posterior branch which is called as the mastoid branch. So we have a facial division and mastoid division of the great auricular nerve. Now facial division obviously will supply toward the facial side, and mastoid division will still supply toward the mastoid process. Great auricular nerve is very commonly asked question here. Now what is so special about great auricular nerve, guys? First of all, now great auricular nerve root value is C2 and C3. Let's start with the root value first, C2 and C3. Now one important relation of great auricular nerve is that it runs with the external jugular vein. The external jugular vein will be running like this here. So it is run with the external jugular vein. That's one important question. It was one of the neat question only. Second thing, great auricular nerve, when it goes above, this guy's facial branch will supply the skin over the angle of mandible and parotid area, and the mastoid branch will supply the skin over the mastoid process also. So the nerve goes above and supplies the skin of the angle of mandible, lobule of the ear, and the mastoid process also. Supplies the lobule of the ear and supplies the skin at the angle of mandible and parotid area also. Lobule of the ear को supply कर रहा है, parotid area को supply कर रहा है, supplying the mastoid process के ऊपर वाले skin को भी supply करता है. That's the sensory area, the skin of this, what do you say, side of the neck and face supplied by the great. Face is supplied by trigeminal nerve. The sensory supplied to the face is by trigeminal nerve, except for this parotid area and this lobule of the ear, and this mastoid process region is by the great auricular nerve. Now this great auricular nerve, the reason it is being asked over and over again, because parotid surgeries के अंदर commonly injured हो जाते हैं, guys. Now in Fraze syndrome, you must have read about this nerve here. Then in Fraze syndrome, when the auriculotemporal nerve regenerate करता है, when the parasympathetic fibers, the parasympathetic branches of the auriculotemporal nerve, they communicates with the great auricular nerve. So your brainstem will give the stimulation to the parotid gland, but along with the parotid gland, what else gets stimulated are the sweat gland in this area, and you will see the sweating in this area. That is because of the faulty fusion of the auriculotemporal nerve with the great auricular nerve in that area. Now, one of the recent INICT question was that in the parotid surgery, what nerve can get injured, guys? Auriculotemporal nerve can get injured, great auricular nerve can get injured here. But the question specifically said that patient felt the sensory loss while shaving. Now shaving करते होगा sensory loss हो रहा है after the parotid surgery. That is not because of auriculotemporal nerve, because auriculotemporal nerve supplies the skin of the auricle and temple. That is because probably during the parotid surgery, the great auricular nerve got injured here. The nerve supplying over the parotid region here. So injury in the parotid surgery, the sensory loss will be seen in the shaving area, that is parotid area. That line will help you. So all these are the questions asked, yes. All these are the questions asked in different examination here. Great auricular nerve, that's why it is so important here. Now another nerve which is very important in this posterior triangle here is, now that is the nerve which is basically the content of this triangle, and that is a spinal accessory nerve. Spinal accessory nerve basically ऊपर से start होके carotid triangle से होता हुआ आता है. Then the spinal accessory nerve passes deep to the sternocleidomastoid, and then it passes into this posterior triangle, and then passes deep to the trapezius muscle and supplies it here. Spinal accessory nerve supplies both sternocleidomastoid and trapezius. Fine, it is supplying both sternocleidomastoid and trapezius. Though guys, first of all, why spinal accessory nerve is so much of concern? Because this nerve is placed quite superficially in this posterior triangle. If you look at the other structures in this triangle, the trunks of brachial plexus, the subclavian vessels, they're quite deeply placed. They're deep to the fascia, prevertebral fascia. So they're quite safe. The one structure which is basically running superficial to the prevertebral fascia is spinal accessory nerve. The floor of this triangle is made up of prevertebral fascia. Nerve उसके ऊपर रखा हुआ है. It is outside the fascia, or you can say superficial to fascia. So that's why spinal accessory nerve is between the prevertebral fascia and the fascia covering the neck, that is the investing layer. It is between the prevertebral fascia and the investing layer, and that's why in any surgical approach to the posterior triangle of neck, while removing the lymph node, while doing the lymph node biopsy, while removing the abscess, the nerve can get injured here. Now the question is, guys, first of all, we said the nerve runs between the investing layer and the prevertebral layer. Deep to the investing layer, superficial to prevertebral layer, दोनों के बीच में चलता है. Spinal accessory nerve injury common है. In the posterior triangle surgeries, the nerve can get injured there. Now, if the spinal accessory nerve get injured in the posterior triangle, the important thing is, जो लोग गलती करते हैं, that spinal accessory nerve is injured in the triangle, guys. In the triangle, that means the muscle which still will be working is sternocleidomastoid. So there will be sparing of the sternocleidomastoid. Sternocleidomastoid बच जाएगा. The trapezius muscle is the one which will be involved here. So trapezius is affected, not the sternocleidomastoid. So that's why the patient will show you the features of only trapezius muscle tech. Now what are the features of trapezius muscle, guys? The patient will have a difficulty in shrugging of shoulder, difficulty in retraction of scapula, and difficulty in overhead abduction, which are all function of the trapezius muscle. Difficulty in shrugging of shoulder, difficulty in the retraction of scapula, difficulty in overhead abduction. The features of the trapezius muscle will be seen. Generally, when they ask this question like this, with which muscle will get injured here, and when the spinal accessory nerve get injured in the posterior triangle, what will be seen? So usually they will give you 3 features of sternocleidomastoid and 1 feature of trapezius. You basically have to eliminate the sternocleidomastoid feature and just need to find out what is the feature of trapezius muscle which will be affected in that case. Okay, a little bit of osteology, guys, before we switch to the neuro part. Now, I'm not going to discuss all these foramen here. ये foramen आप लोग पढ़ते रहते हैं. Like, I'm just going to discuss only 2 foramen there, which are like in couple of years, in the past few years are asked, and they're very important also. Anyways, they're important. Now, one foramen which I wanted to focus on here is that foramen called as a foramen lacerum, guys. Now, that foramen lacerum is very, very important here. Now, foramen lacerum, first of all, it is a foramen which is basically placed between many bones. Look at that, guys. It is not a foramen. It is a space left between the developing bones. Now we have this, you have a sphenoid bone here, sphenoid and the greater wing of sphenoid. There is a petrous part of temporal bone, and you have an occipital bone, the basilar part of occipital bone, or you call it basi-occiput. So first of all, foramen lacerum is present between the sphenoid, petrous part of temporal, that is the petrous part of temporal bone, and that's a basilar part of the occipital bone. So in तीनों के बीच में present है. That is foramen lacerum here. So it's generally bridged with a fibrocartilage inside. So it's not a foramen, it's a space left between the bone here. Now, in the foramen lacerum, there are 2 types of content, guys. Some of the content of foramen lacerum are the one which are traversing, जो cartilage के through होके जा रहे हैं. And those traversing content of the foramen lacerum are some meningeal branches, some meningeal arteries are there, and some emissary veins here. Meningeal branches of ascending pharyngeal artery. आप खाली meningeal artery भी याद रखेंगे चलेगा. Meningeal arteries, some meningeal arteries are entering inside, and some emissary veins are passing through that. So they are the structure which are traversing the entire foramen lacerum, जो cross कर रहे हैं पूरे foramen lacerum को. Now there are some content which are overlapping it, the structure which are present in the foramen lacerum, but they're not traversing it through, and that is internal carotid artery, the sympathetic plexus around the internal carotid artery, the greater petrosal nerve, the deep petrosal nerve, the 2 nerves which will together form the nerve to pterygoid canal, guys. So we have internal carotid artery, sympathetic plexus, deep petrosal nerve, greater petrosal nerve. All these contents are not crossing or traversing the entire foramen lacerum, but they're still the content, क्योंकि वो उसके ऊपर present है. They're present on the foramen lacerum here. The fills of the foramen lacerum, that's how we say it, the fills of the foramen lacerum here. So this question can be asked like this. एक तो question already पूछ ही चुके हैं that it is present between what bone here. So when it comes to the content, there could be question could be very precise here, that what structures are traversing the foramen lacerum and which one just fills up the foramen lacerum here. The second important foramen that we'll talk about is this one, guys, the jugular foramen. This is a foramen which is being asked over and over again. Sometimes they ask us pure osteology questions, sometimes it's the clinical question on that, guys. The jugular foramen, now to understand the jugular foramen, let me just take the jugular foramen separately here. Now, let's say this is a replica of the jugular foramen. I'm putting it outside here. Just trying to replicate that exactly that orientation only. Now, in the jugular foramen, most anteriorly, or you can say most anteromedially and most posterior-laterally, we have the 2 sinuses which will join together below the jugular foramen to give rise to internal jugular vein. So we have an inferior guys, cavernous sinus say inferior pectoral sinus will come from here. That is the site for inferior pectoral sinus will come from here. And look at the shape. The sigmoid sinus will come from here. So obviously the one which is present behind is a sigmoid sinus, and the one which is present is the inferior pectoral sinus. Inferior pectoral sinus and sigmoid sinus, and they both will join with each other below the jugular foramen to give rise to internal jugular vein. One thing. In between them, we have the 3 nerves. Now, it's a jugular foramen. In that sequence is giving passage to the 9th, 10th, and 11th nerve. And again, we have some meningeal arteries also. The meningeal arteries coming from ascending pharyngeal artery, some coming from occipital artery. Some meningeal arteries are also there. Like again, meningeal branches of ascending pharyngeal and occipital artery. And one question is that, like, simply about the foramen, the arrangement of the structures there. Now again, the question here was that which of the nerve passing from jugular foramen is having a separate passage, and the nerve having a separate passage inside the jugular foramen is a 9th nerve. देखो यार 10th and 11th nerve को दोनों को मिलना है ना. Both 10th and 11th nerve, they will join with each other and form the vago accessory complex. The nerve which will have a separate passage is which nerve? 9th nerve. So the nerve which is a content of jugular foramen but having a separate passage is the 9th nerve there. That is a 9th nerve. And if you know the 9th, 10th and 11th nerve are passing from the jugular foramen, and you know what these nerves functions is, so you can make out that if there is a fracture of the base of the skull, including the jugular foramen, then what would be the features? Like if glossopharyngeal nerve is gone, the patient will have the taste sensation loss on the posterior 1/3 of tongue. If the vagus nerve is lost, obviously there will be a bulbar paralysis in that case. Same with the 11th nerve also. So you should know that what nerve is passing through jugular foramen, and any fracture involving the jugular foramen, that what obviously would be the features in there. Okay, now another question which is also asked like more than once here is about the pterion here, guys. The meeting point of 4 bones. First of all, one should know that look at that H-shaped suture that you're looking at here. What 4 bones are meeting in the pterion here? Frontal bone, parietal bone, सबको याद रहता है. The frontal bone is contributing, parietal bone is contributing to it. Now you should know precisely which 2 other bones are contributing to it. So one is the temporal bone and it's a squamous part of temporal bone. Remember this, guys, it's a squamous part of temporal bone contributing to the pterion, and also the greater wing of sphenoid. Well, in the normal lateralis, only the greater wing of sphenoid can be seen here. That's a greater wing of sphenoid which is written. So first of all, these are the 4 bones which are meeting at this junction and they're forming this H-shaped suture called as a pterion. What is related to the pterion, guys? Now that is the site for the pterion. If I just put that over there. Now there are many structures which is related to pterion here. The most important out of those is the anterior division of middle meningeal artery. Anterior division of middle meningeal artery is there. Middle meningeal vessel is there. Sylvian, look at that, guys. Sylvian point. Sylvian point is there. Sylvian sulcus is there. अभी Sylvian sulcus भी अंदर की side होगा तो middle cerebral vessels भी होंगी वहाँ पर. Insula. If you open this Sylvian sulcus, then obviously the hidden lobe is there. Insula. So if you go deeper and deeper and deeper, these are the structures related to the what you say to this pterion here. So obviously the most superficial relation here, the immediately inside the pterion is the middle meningeal artery, the anterior division, guys. It's the anterior division of middle meningeal artery is there. Middle cerebral vessels are there. Sylvian sulcus is there. You open the Sylvian fissure, there is an insula over there, and obviously on the left side, if I'm a right-handed person, on the left side, the Broca's area. The Broca's area is present in the inferior frontal gyrus somewhere here. So inferior front, guys, look at that. That's the area of the Broca's area. That is also is in relation to the pterion only inside if you go here. So they have asked about the middle meningeal artery, but these are the other things that you should know that also lies in the line of the pterion only here. And because anterior division of middle meningeal artery is present there, you all know that the rupture of the middle meningeal artery, anterior division of middle meningeal artery can lead to the extradural hemorrhage also, the EDH. Now finally, just one more thing here. If they give you the picture of the cranial fossa and give you the picture of the cranial fossa with the durameter intact. Now look at this picture, the durameter is intact there, and you still have to identify the nerve, then it becomes a little challenging here because you're not able to see the foramen. How will you identify the major nerves without looking at the foramen? Now let's do that, guys. Now let's just enlarge that portion, the one which I marked in the box over there. Look at that. Now first of all, when you're looking at this, that's the anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Now in the anterior cranial fossa, look at this triangular bony projection over there, जिसके ऊपर durameter लगा हुआ है, that is the anterior clinoid process. The nerve which is present medial to the anterior clinoid process is the nerve going into the optic canal, and that is the optic nerve here. So आप anterior clinoid process अंदर की तरफ देख रहे हैं यहाँ पर, that is the optic nerve, and the same optic nerve and optic chiasm will be forming the roof of the cavernous sinus also. Then the nerve which are present in the lateral wall of cavernous sinus, आपको एक sequence में मिलेंगी. Look at the nerve present in the lateral wall of cavernous sinus. That is the third nerve. Then look at this thin nerve, guys. Thinnest cranial nerve, that is the fourth nerve. And then we have this fifth nerve. Now that is not the sixth nerve, guys, that is a fifth nerve here. Third nerve, fourth and fifth nerve. Think of the nerves present in the lateral wall of cavernous sinus, and that is what you see in that sequence here. Sixth nerve is the one which is most likely to be asked in this picture here. The reason is the sixth nerve is present actually on the clivus. This slope is called as the clivus where the brainstem is present. And look at that nerve over there, guys. This nerve, the sixth nerve, which is having the longest intradural course. It will enter the durameter here only, and then it will go like this and inside the cavernous sinus. That is the sixth nerve there. So the nerve that you see on the clivus over there, that is the sixth nerve. In the posterior cranial fossa, when you look at the posterior cranial fossa, now just make your mindset like this. You will be looking at the 3 foramen. That's the area of the internal acoustic meatus. That's the area of the jugular foramen, and that's the area of the hypoglossal canal here. सबसे ऊपर internal acoustic meatus होगा, then jugular foramen, and then hypoglossal canal, and that's in that sequence you will find out the nerves also. I'm not able to see the foramen, I'm not able to see the brainstem here, but I can still say that nerve over there is the 7th and 8th nerve because the internal acoustic meatus hai. Below that, jugular foramen, 9, 10, 11, guys. Below that, look at those small rootlets coming out. Those rootlets are coming out from the hypoglossal nerve. That's a hypoglossal nerve. The hypoglossal nerve comes out as multiple rootlets only here. That artery is a vertebral artery entering through foramen magnum. That artery is a vertebral artery. So I believe that in this picture, if again this question is ever asked here, the main thing is this nerve here. The sixth nerve, identification of the sixth nerve, guys. Sixth nerve identification, that is a nerve present on the clivus. Okay. लूंगा अभी 1 घंटा और लूंगा आपका मैं. I'll take 1 more hour. कोई नहीं लेगा guys. Nobody will move. Okay, in the neuroanatomy, first let's start with the spinal cord tracts, and the one way to revise the spinal cord tract is directly talking about a syndrome that is a Brown-Sequard syndrome. Now, you're looking at a picture here, guys. You all know about the Brown-Sequard syndrome, the hemisection or the hemi-involvement of the spinal cord here. Now, in the Brown-Sequard syndrome, now look at this picture here and let me justify the features here. Now, I know in the Brown-Sequard syndrome, usually the problem is that what will happen at the level of the lesion, what will happen below the level of lesion, contralateral side पे क्या होगा, ipsilateral side पे क्या होगा. So let's fetch the answer to these questions here. Different shades and colors are given over there. Now let's take them one by one, guys. Now in the Brown-Sequard syndrome, first of all, look at that blue color shown over there. That is telling you that basically all the sensory tract entering at the level of that, if let's say that that's the area of the Brown-Sequard syndrome, whatever level the sensory tract will enter into, no sensation will reach the spinal cord. So ipsilateral loss of every sensation will be there exactly at the level of lesion. ऊपर की बात नहीं कर रहे, नीचे की बात नहीं कर रहे. Whichever the level lesion is, the ipsilateral loss of all the sensation will be there for sure. There will be ipsilateral loss of all sensory modalities at the level of lesion, guys. Exactly at the level of lesion, because the moment the dorsal root ganglia will enter inside, that area is already affected. So there will be ipsilateral loss of all sensory modalities at that particular level. Okay. Okay, chalo guys. The next thing, the main challenge here is understanding the pyramidal tract. Now, I want to just show you one schematic picture here, guys. Let's say if this is a spinal cord here. All of you, please look at the screen, guys. If this is a spinal cord, we know that pyramidal tract will decussate at the lower medulla. Now, once the pyramidal tract will decussate at the lower medulla, after the decussation, let's say these are the upper motor neurons जो decussate करके आए हैं. Once they decussate, the pyramidal tract will come to the spinal cord, different level of the spinal cord. These are the upper motor neurons, and then these are the lower motor neurons which will be coming out of the spinal cord, right? These are the lower motor neurons which are coming out here. Now let's say there is a Brown-Sequard syndrome at this particular level. एक ये segment मान लेते हैं. This is the particular point where the Brown-Sequard syndrome is affecting the spinal cord. Now again, exactly where the Brown-Sequard syndrome is there, जहाँ पर Brown-Sequard syndrome है, can you see the cell body of the lower motor neuron is affected? And because lower motor neuron is affected at the level of lesion, so at the level of lesion there is a lower motor neuron type of lesion, and that's why there will be flaccid paralysis. There will be ipsilateral flaccid paralysis at the level of lesion. Below the level of lesion, lower motor neurons are working fine. Lower motor neurons are perfectly fine. Their cell body is also okay. So lower motor neurons are working, but their upper motor neuron, which is coming from this Brown-Sequard area, is getting affected here. So that's why at the level of lesion, there is a lower motor neuron lesion, so there is a flaccid paralysis. But below the level of lesion, lower motor neurons are working, but upper motor neuron is not working. There is a spastic paralysis. So ipsilateral flaccid paralysis at the level of lesion, and ipsilateral spastic paralysis below the level of lesion. Below the level of lesion. Dorsal column tract के बारे में सोचना ही नहीं guys. Dorsal column tract, whatever dorsal column tract is carrying, conscious proprioception, vibration, fine touch, stereognosis, dorsal column tract, they do not decussate in the spinal cord. My right side dorsal column tract will run on the right side only. So wherever the injury is, if the Brown-Sequard syndrome is at this level here, so the dorsal column tract entering here will be injured, and whatever dorsal column tract जो नीचे से भी आ रहा होगा, that will also get injured here. So it's always ipsilateral. Because of the dorsal column tract lesion, we have an ipsilateral loss of vibration, with the proprioception, ipsilateral loss of vibration, position, there's a conscious proprioception, by stereognosis, fine touch. And then comes the spinothalamic tract. Spinothalamic tract, we all know that spinothalamic tract, they decussate at the spinal cord, guys. Spinothalamic tract, they decussate at the spinal cord, and then they go above here. Now, once the spinothalamic tract decussate at the level of the spinal cord, they take 2 to 3 segments to decussate here. That means the spinothalamic tract अगर right side का injured हुआ है, if right side का spinothalamic tract is injured, I'm sorry, just refresh this thing here. If the spinothalamic tract enters the spinal cord and it decussates here. Now, if the spinothalamic tract is entering at a particular level and decussating here, and the lesion is at this side here, so exactly at the level of lesion, spinothalamic tract, again ipsilateral loss will be there. All the tract ipsilateral loss is there at the level of lesion. But those spinothalamic tract जो नीचे से enter कर रही हैं, imagine these are spinothalamic tract lateral anterior entering here, they're safe till here, then they decussate, will go here, safe here, and then they go safely above. So they're skipping that part here. That's why on the ipsilateral side, there is no loss of pain and temperature below the level of lesion. Below the level of lesion, pain or temperature loss नहीं होगा. Let's come to the other side here. But let's say if I see it in this way here, the spinothalamic tract entering at this point, जो यहाँ से enter करेंगे नीचे से, look at my finger guys, the spinothalamic tract entering from here, now they have to decussate and enter the brown sequoid area वाला region only. So all the spinothalamic tract which are entering here and then they are decussating and they have to go through the brown sequoid region, and that's why there is a loss on which side? Contralateral side. Because of the spinothalamic tract involvement, there will be contralateral loss of pain and temperature, guys. Contralateral loss of pain and temperature below the level of lesion. Contralateral loss of pain and temperature below the level of lesion, right? पहली चीज तो मान के चलो, there will be ipsilateral loss of all sensory modalities at the level of lesion. ये तो सभी में, all of them here. Then the one you have to think about the pyramidal tract, and then you have to think about the spinothalamic tract here. You can compare these different shades and colors with that, the picture which is given here when you will just revise these slides. Okay. Brainstem, guys, when you look at the brainstem from the front here, now this is again a very recent INI-CT question also about the abducent nerve. Now this is, ये question बार बार पूछते रहते हैं. They ask you to identify the nerve, or they will give you the feature, the patient is having a divergent squint or having a facial paralysis or something. Identify the nerve based on that lesion here. Now, first of all, when you're looking at the brainstem here, now this portion of the brainstem, guys, this is the midbrain here. This portion of the midbrain, there is a midbrain here, that is a pons, and that is medulla oblongata. That is medulla oblongata. Now, in the midbrain, this part of the midbrain, guys, that's a ventral aspect of the brainstem. आप सामने से देख रहे हैं brainstem को. Now, that part of the midbrain is called as the crus cerebri, also called as the cerebral peduncle. Now, between the two cerebral peduncle, we have a nerve present over there, and that's a third nerve, guys. Oculomotor nerve is the one that you see present in the interpeduncular fossa, and that is winding on the peduncle here. And the only nerve that you see coming from the dorsal aspect of brainstem, and also winding around the peduncle here, that is the fourth nerve, having the longest intracranial course. So, दो nerve आपको दिखेंगे which are winding around the cerebral peduncle, the third and the fourth nerve. Pons is having so many nuclei inside. Though there are so many nuclei inside the pons, but the only nerve that you see emerging from the ventral aspect of the pons, that is toward the lateral side here, that nerve emerging from the ventral aspect of pons is the fifth nerve, that trigeminal nerve. That's the only nerve. You can see the two part there. The thicker part is sensory, the thinner part is motor, but that's trigeminal nerve. Pontomedullary junction, guys. At the pontomedullary junction, the nerve that you see starting from midline, the sixth nerve, which was a recent question, the abducent nerve, seventh nerve, and more laterally 8th nerve. 6th, 7th and 8th nerve, guys. The three nerves coming from pontomedullary junction, and I can say 6th nerve is more precisely from pontopyramidal junction. That's a pyramidal tract. You can see the pyramid over there, and that is olive. So 6th, 7th and 8th nerve, they are coming from pontomedullary junction. The most medial nerve over there is the 6th nerve. Now, if that elevation over there in the medulla oblongata is olive, lateral to olive, I have three nerves, that is 9th, 10th and 11th in that sequence. 9th, 10th and 11th nerve will be coming out lateral to olive. And the only nerve that emerges between the pyramid and olive, guys, the only nerve that emerges out between the pyramid and olive is the 12th nerve, that is the hypoglossal nerve. The only nerve there is the hypoglossal nerve. Now that's the ventral aspect of brainstem. इससे main चीज यही है, आपको nerve identify करनी. The cranial nerve identification is the main key here. Let's turn the brainstem, guys. The moment you turn the brainstem, you got to remove the cerebellum also. You turn the brainstem and you remove the cerebellum, the fourth ventricle will be exposed there. Now look at that picture here. You're looking at the dorsal aspect of the brainstem. Now it's a real-time section here. When you look at the dorsal aspect of brainstem, first of all, that's a midbrain over there. Look at these four colliculus. That's a superior colliculus and the inferior colliculus, together called as a corpora quadrigemina. That is a corpora quadrigemina. Now below the corpora quadrigemina, below these four colliculus, you can see the nerve coming out there, and that nerve is the fourth nerve. The only nerve we said coming out from the dorsal aspect of brainstem is the fourth nerve. Now here is the floor of the fourth ventricle, guys. In the floor of fourth ventricle, what you see, it's also called as a rhomboid fossa. Look at the shape, it's like a rhombus, rhomboid fossa. And this the boundary of the fourth ventricle is by the peduncles here. Superior cerebellar peduncle ऊपर से आ रहा है, inferior cerebellar peduncle is coming from below, so that is contributing to the boundary of the fourth ventricle. Now what is important in the fourth ventricle is, which is again a repeatedly asked question, is the elevation which is present here, and this elevation here is called as a facial colliculus, guys. The facial colliculus, below facial colliculus we have a vagal triangle, and then below vagal triangle we have a hypoglossal triangle. Now इसमें बहुत अच्छे से नहीं पता चल रहा है because it's a real time picture, but they are all present medial to a sulcus called as a sulcus limitans. There is a sulcus limitans. There is sulcus here. Exactly, the middle cerebral peduncle is not the part here. You people have read really well. So guys, facial colliculus is there. That's a facial colliculus there. Then we have a vagal triangle there, and that's a hypoglossal triangle. Hypoglossal triangle or trigone बोलते हैं because the respective nuclei are present over there. and more laterally, more outside in this area, the vestibular nuclei is present. If we have multiple vestibular nuclei, they are present over there. That's why we call it a vestibular triangle here. Now guys, if the question, now we already know, I'm sure we all know about facial colliculus. The facial colliculus is a facial nerve winding around the abducent nucleus. That means ये bulge जो आपको दिख रहा है, this bulge present over there is formed by the facial nerve winding around which nucleus? 6 nucleus. So if the question says which nerve nuclei are present in the floor of fourth ventricle, nuclei in the floor of fourth ventricle, then you will say it is 6, 8, 10 and 12. 6, 8, 10 and 12. Sixth, obviously facial colliculus यहाँ पे 6th होगा. Vestibular is 8, vagal is 10 and hypoglossal is 12. So cranial nerve nuclei, the question is nuclei present in the floor of fourth ventricle is 6, 8, 10 and 12. Facial colliculus. Now there's a question asked on the injury to facial colliculus. Guys, facial colliculus को injury होगा तो obviously facial nerve will get injured here because it's the nerve which is surrounding the nucleus here. So injury to facial colliculus, the facial nerve, the lower motor neuron lesion of facial nerve will be seen here. There will be injury to the nucleus also, but obviously the nerve is surrounding it here. So if you have to choose one, injury to facial colliculus means there is a lower motor neuron lesion of the facial nerve, and that will lead to the ipsilateral facial paralysis. Lower motor neuron lesion of facial nerve will be there, and there is a ipsilateral facial paralysis. The question, इस question के अंदर वो lateral rectus muscle जरूर देंगे आपको, because lateral rectus muscle is supplied by abducent nerve and abducent nucleus. You don't have to choose the abducent nucleus, you have to go with the facial muscle. Go with any muscle of the face here, rhizoria, zygomatic, whichever muscle of facial expression will get affected here. So injury to facial colliculus, it's more about the ipsilateral facial paralysis. Okay. So that's the ventral and the dorsal aspect of brainstem, guys. Now moving on, now some sections of the brain that are very, very important, because you may get different kind of questions in this here, but again it boils down to identification, whether or not you're able to identify these structures here. If you can identify them on the atlas image, in the cadaveric image, then only you can identify them in the radiological image also. Now this picture, guys, it's a sagittal section here, and the area which is being blinking in the center here, that is the third ventricle here. Now let's look at this thing from the third ventricle point of view. I need to stand for some time. So now what you see, guys, it's the third ventricle here. Now what you see, this is corpus callosum. Let's start from here. That is a corpus callosum, and this septum which is present below the corpus callosum, that is a septum pellucidum. That is septum pellucidum. It's a thin septum. It's a thin pellucid septum which is basically separating the two lateral ventricles. मैं दूसरे section में देखते हैं इसको. Now below the septum pellucidum you can see fornix. Now I want to remember the sequence, guys. Corpus callosum, septum pellucidum, and that is a fornix. That's a fornix, body of fornix is there. And below that we have what? We have a choroid plexus here. So I can say in the roof of the third ventricle we have a body of the fornix and choroid plexus is there. Agree? In the roof of the third ventricle we have a body of fornix and the choroid plexus. Posteriorly, now that's a splenium of corpus callosum. इसको छोड़ते हैं. Now look at here, guys. Can you see the pineal gland over there? Now above the pineal gland there is a white matter commissure there called as a habenular commissure. This is a pineal gland, and this is a posterior commissure. That's a posterior commissure which is present in the inferior lamina of the pineal gland. That is a posterior commissure, guys. That is a posterior commissure. और आप posterior commissure के नीचे आओगे तो this here is an aqueduct of Sylvis which is leading into the fourth ventricle. That's an aqueduct of Sylvis here. Habenular commissure, pineal gland, posterior commissure, and aqueduct of Sylvis. In that sequence, they're all present toward the posterior side, forming the posterior wall of third ventricle. Look, guys, question could be anything in this. They can ask you anything about the connection of the mammillary body, about the projection fiber, commissural fiber. But as I said, it all boils down to the identification. पहले तो identify करना है ना. If you're not able to identify that this is a pineal gland or this is a commissural fiber, it's a posterior commissure, then how will you answer those questions here? So identification becomes very important in these sections of the brain here. Posterior wall of third ventricle, guys. Anterior wall. Now anterior wall of third ventricle, now look at this. That's a genu and that's a rostrum of corpus callosum. Now below the rostrum of corpus callosum, that's another commissure there called as anterior commissure, guys. That's the anterior commissure. And below the anterior commissure, we have this lamina terminalis. So they are both forming the anterior wall of third ventricle. Mainly the two things forming the anterior, mainly there is anterior commissure and lamina terminalis. And then comes the floor. Now if you look at the floor of this third ventricle, interpeduncular fossa में जो चीजें होती है वो सब यहाँ पे दिखेंगी आपको, most of them. Like if you start from in front here, that is optic chiasma. That is a section through optic chiasma. That's first thing here. The next thing that you see is an infundibulum. That is infundibulum, or the stalk of pituitary is there, which is again there in the interpeduncular fossa. Then look at the rounded structure is what? Mammillary body. And then look at those perforations over there. These perforations are by the posterior cerebral artery, branches of posterior cerebral artery. We call it posterior perforating substance. And they're all present, including this tegmentum of the midbrain. They're all present in the floor of the third ventricle. They're all present in the floor of third ventricle. So these are the must-know structure in this section, guys. Always read the sagittal section with respect to third ventricle. Third ventricle boundary padhoge, so you'll obviously remember the structures present around there. Now, one of the questions asked was about the mammillary body in the recent time. Mammillary body basically connects to the anterior thalamic nuclei. I'm not discussing the thalamic nuclei in that, guys. If you want to go through the thalamic nuclear connection, you can watch that on my YouTube channel also. There is a separate video for the thalamic nuclear connection, which I would recommend you that you should watch it agar aapko thalamic nuclear connection clear nahi hai to. Okay, that's one section, guys. Now, same thing, but I wanted to show the another image. Now, let's try to identify on this radiological image here. Again, can you see what is that, guys? Corpus callosum. And that is the fornix. Look at that. That white matter bundle is the fornix here. And in between, we have septum pellucidum. That's the septum pellucidum which will separate that. So this is the fornix. Obviously, below the choroid plexus will be there. And that is where the third ventricle is present. So that is the roof of the third ventricle here. Now, you can see all the things over there, guys. Look at my finger pointing at there. That is the optic chiasma. You can see infundibulum, you can see mammillary body there, you can see posterior perforating substance, that area is posterior perforating substance. Aqueduct of Sylvis bhi dikhai de raha hai. I can see the midbrain, I can see pons, I can see medulla oblongata, the cerebellum here. Now, in the recent time, there was a question asked, and the question was about that some people said the arrow was placed here. That was somewhere behind the midbrain, below the inferior colliculus. See, if this is a midbrain, so this has to be the superior colliculus, this has to be the inferior colliculus. If the arrow is placed below the inferior colliculus or behind the midbrain, so ek hi nerve hai, guys. The only nerve coming out from the dorsal aspect of the brainstem, that is the fourth nerve. But let's say if the arrow is placed inside here, in the floor of fourth ventricle, somewhere here. Now, in the floor of fourth ventricle, we expect to see the facial colliculus. So facial nerve is the answer in that case here. So if the arrow is there below the inferior colliculus, the nerve seen over there is a fourth nerve. If the arrow is placed in the floor of fourth ventricle, the facial colliculus is there where the facial nerve will wind around and then will go front. That's the facial nerve would be the answer to be seen in the floor of the fourth ventricle. Okay. 1.8 thousand people are still maintaining their attendance. That's mean they're taking it seriously. Commendable, guys. We are already 3 hours and 15 minutes into this session and you have not moved. So hats off to you people as well. Chalo, let's keep going. Now, coronal section. If I take a coronal section here, now in the coronal section, let's identify. Again, identification is the key, guys. First of all, look at these are the two lateral ventricles we are looking at, the two lateral ventricle, and that's the third ventricle there. Now, corpus callosum. And the moment you look at the corpus callosum, आप side वाला picture सोचो. Corpus callosum के side, corpus callosum के नीचे क्या होगा? Septum pellucidum. Then will be the fornix. Then will be the choroid plexus. वही सीख. If this is the corpus callosum, there has to be the septum pellucidum. There has to be the fornix. There has to be the choroid plexus, which are forming the roof of the third ventricle also. Same thing. Now that is corpus callosum there. And look at this white matter bundle which is ascending. The biggest projection fiber we have, that is internal capsule. Now guys, look at this white matter bundle is internal capsule. Once the internal capsule reaches the level of corpus callosum, once it reaches the level of corpus callosum, it radiates into the cerebrum as the corona radiata. It radiates as the corona radiata. More outside, can you see, if you go from the outside, inside, if you go from outside from the lateral sulcus or sylvian sulcus, guys, that's the hidden gyrus present inside, and that is the insula, the island of Riehl, or the insula is there. And what you see that between the insula and the internal capsule, this is where the lentiform nucleus is present. The globus pallidum will be there. That is the lentiform nucleus situated there. Whereas medial to the internal capsule, we have a caudate nucleus and thalamus. Now, look at this. Let's see from the lateral ventricle point of view. If this is the lateral ventricle, body of lateral ventricle, roof किससे बन रहा है? Corpus callosum से. Roof is by corpus callosum. Medial wall is by septum pellucidum. That's septum pellucidum forming the medial wall here. और देखो ये सब floor में, guys. Everything. Look at the sloping floor of the body here. This whole thing is a floor here, in which we have this caudate nucleus, the body of caudate nucleus. Head आगे होगा, tail पीछे होगा. That's a body. It's a coronal section, body of caudate nucleus. Thalamus is there. That's a thalamus. और ये दो आपको already मालूम ही है. What are these two, guys? Below the septum pellucidum, what do you expect to see? The fornix and the choroid plexus. The fornix and the choroid plexus here. The fornix and the choroid plexus are also there. So the fornix and the choroid plexus, which are forming the floor of the lateral ventricle, are forming the roof of the third ventricle. So roof बना रहे हैं. Now, also this was one of the question asked. They gave the coronal section और fornix के ऊपर arrow लगाया हुआ था, पूछा हुआ था कि fornix fiber originates where? originates where? Now let me just show you the section from the side, guys. I hope you can identify corpus callosum. अगर ये corpus callosum है तो what is supposed to be next to it? Septum pellucidum. Now the septum pellucidum is cut. Septum pellucidum is removed from here. That's why I can see the cavity of lateral ventricle. That's why I'm able to see the cavity, because septum pellucidum removed किया हुआ है. And below that, look at this, the one which is marked over there. That is the fornix. It's a dissected specimen for the fornix here, specially dissected to show the fornix here. Now fornix का origin is here, guys. Hippocampus. Hippocampus is the origin of the fornix here, and then the fornix fiber will terminate in the mammillary body. Remember that mammillary body present in the interpeduncular fossa? That is the termination of the fornix here. The question asked was, in the coronal section, the fornix was given, and the question was where the marked fiber originates. Origin in hippocampus, termination in mammillary body. It's a part of the limbic system, guys. It's a part of a limbic system. Transverse section, and I'll show you one beautiful overlapping of this transverse section also, guys. When you see the transverse section of the cerebrum here, now देखो यहाँ पर कहीं corpus callosum होना चाहिए, guys. Look at this. If this is a site for corpus callosum here, now no matter how big corpus callosum is, but still corpus callosum will not be able to connect everything in the two cerebrum. सब कुछ तो connect कर नहीं सकता. The fibers of corpus callosum in the anterior part, they will basically move forward, and this moving forward fibers of corpus callosum, they are called as a forceps minor fiber. The one which are going forward, that's a part of corpus callosum only. These fibers are coming from a genu of corpus callosum going forward, called as forceps minor. Similarly, the one which will be coming from the splenium of the corpus callosum, these are called as forceps major. Now these forceps major fiber are sweeping backward, and when these forceps major fiber they sweep backward, they also produce the bulge in the medial wall of posterior horn, जिसको हम बोलते हैं bulb of posterior horn. The bulb of posterior horn is a bulge which is produced by the forceps major fiber. ये भी corpus callosum के fiber ही हैं. These are coming from the splenium of the corpus callosum and running backward, connecting the occipital lobe. Now we do have some fibers of corpus callosum even lateral to the posterior horn of lateral. This is the posterior horn of lateral ventricle only, and these are called as the tapetum fiber, guys. Tapetum fibers are also running on the outside here. So if you look at the posterior horn of lateral ventricle, on the medial side we have forceps major, on the lateral side we have tapetum. So guys, forceps major, tapetum and forceps minor, ये तीनों corpus callosum के part ही हैं. These are fibers of corpus callosum. Forceps minor is going in front, tapetum and forceps major are going backwards and downwards also. What else you see in this picture? Now internal capsule, look at this, guys. That's another view of internal capsule, where you can see the anterior limb of internal capsule, the genu of the internal capsule, and the posterior limb of internal capsule is visible here. So that's the internal capsule. Now lateral to internal capsule and medial to internal capsule relations. जो laterally placed, medially placed, I'm sorry, let's start with the medial one. That is a caudate nucleus, and this time it is the head of the caudate nucleus. Caudate nucleus is like this, guys. When you saw the coronal section, पहले आपने जो coronal section देखा था, उसमें आपको body दिख रहा था. Now you're taking a transverse section. This is towards the head. ये head से दिख रहा है. That's the head of the caudate nucleus there. Head is there. Tail will be somewhere here, guys. The tail of the caudate nucleus will be somewhere here. So it's the head of the caudate nucleus, and that is thalamus. So head and the caudate nucleus and the thalamus, they are present toward the medial side of internal capsule, and lateral to internal capsule we have the lentiform nucleus. The lentiform, if you go a little more lateral to lentiform nucleus, you can see a very thin, a very faint gray matter also there, which is called as a claustrum. Radiologically claustrum दिखता नहीं है. That's a claustrum over there. And furthermore lateral, then we have this insula. Once again, that hidden gyrus over there is called as the insula. Now as I said, this picture could be asked as a radiological image also. So I've tried something, I hope you like that. I've tried to overlap a radiological image with the same image. मुझे दो image exist जैसी मिली, and just try to overlap them. Now look at this, if I'm able to. I hope it's a good attempt. Now look at that, that's a radiological image. You're looking at this MRI of the brain here, and I can see the same, the forceps minor, the forceps major can be seen, tapetum fiber can see, posterior horn दिख रहा है मेरे को. You can see the lentiform nucleus outside, caudate nucleus, thalamus. The same picture which I just showed you, let me try to superimpose on this side, so that will give you a fair idea. Look at that, guys. I think it's fairly matching. It's a good match actually. Although ये दो बिल्कुल अलग-अलग sources की picture है, I just try to overlap them, but they are kind of overlapping very well, and the same labeling. Just give yourself 10 seconds and just quickly go through it. I put some labeling on the MRI and I put some labeling on the cadaveric picture here. Just try to compare the two. Thank you, thank you. All I'm going to do tonight is just going to read your message only. Everything that you're writing, you will write. That's what I'm going to do. That's the plan for the night. That's how I'm going to celebrate my Rose Day. Okay. Cerebellum. Now, let's discuss one more important topic there, guys. Cerebellum. Now, first of all, I've taken this this picture here. I'll show you the histological picture of the cerebellum also. But look at this, guys. Cerebellar cortex. Let's start with the cortex first. The cerebellar cortex is having three layers. We have a molecular layer, which is the outermost layer. That is a molecular layer. Then we have a Purkinje layer. The middle layer is a Purkinje layer, and the inner layer is granular layer. Now, in the three layer of cerebellar cortex, we have total 5 types of cell. Molecular layer is having basket cell and stellate cells. Supporting cells, guys, ज़्यादा परेशान नहीं होना. Stellate cell and basket cell, they are supporting cells present in the molecular layer. Just keep looking at both the side. The boxes will come simultaneously. The second layer over there is a Purkinje layer, and Purkinje layer, obviously the name says Purkinje layer. The Purkinje cells are there. And then we have the granular layer, the G for granular layer, and whatever cells present in the granular layer, उनकी spelling भी G से start होती है. That is granule cells and Golgi cells. So total in the three layers of the cerebellar cortex, we have total 5 types of cell. Basket, stellate, Purkinje, granule, Golgi. Basket, stellate, Purkinje, granule, Golgi. Now, one of the recent question was, they gave a histological image, and the question, not histological image, the simply question was that molecular layer के अंदर कौन से cells होते हैं? The molecular layer is having a basket and stellate cell, the two supporting cells. Out of the 5 types of cells which we have in the cerebellar cortex, most of them are inhibitory. Basket cell is inhibitory, stellate cell is inhibitory, Purkinje is inhibitory, Golgi cell is inhibitory. The only excitatory cell is a granule cell. The only excitatory cell is a granule cell, guys, and that's why cerebellar cortex is the largest collection of inhibitory neurons. Cerebellar cortex is the largest collection of inhibitory neurons. इतने inhibitory neurons कहीं और होते ही नहीं है. That's one question here. What is the largest collection of inhibitory neurons? That is the cerebellar cortex here. Now I'll tell you a little more about these Purkinje cells and all. Now, apart from these cells, you can see some fibers are coming from outside and going into the cerebellum. The afferent fibers. Before we talk about the efferent, what are the afferent fibers? The afferent fiber into the cerebellum are of two types. Some of them are called as a mossy fibers, and some of them are called as a climbing fibers, guys. Now the climbing fiber, look at this. This white matter bundle, जो कि बाहर से आएगा, it will come from outside, from the brainstem, enter the cerebellum, from the white matter, goes into the grey matter, and keep going into the grey matter, keep going into the grey matter, and reaches directly to the Purkinje cells, guys. It directly makes a synapse with the Purkinje cell, with the dendrites of Purkinje cell, and that's why we call them the climbing fibers, because of their climbing capability. They can climb to the topmost layer. On the other hand, mossy fibers. The word mossy, I always say, mossy sounds lazy. Mossy ji की age ज़्यादा है. Mossy ज़्यादा ऊपर जा नहीं सकती. So mossy ji will just go to the granular layer only. The mossy ji will just go to the ground floor only. So mossy will go to the ground floor, and ground floor means granular layer, and they will just stay there only. Now, going till the ground floor of the granular layer is not sufficient, because you have to reach the Purkinje cell to make the efferent. And that's why there where the granule cell come into the picture. The granule cells are excitatory in nature, guys. That's why they're excitatory cell, guys. Rest all are inhibitory. Granule cell are excitatory because it's the responsibility of the granule cell to make a synaptic contact between these mossy fibers and then connect them to the Purkinje cells. So ये तो what difference between the climbing fibers and the mossy fibers, the climbing and the mossy fibers. Now the question is, which one are climbing and which one are mossy? Well, only olivocerebellar and para-olivocerebellar. The tract called as olivocerebellar and para-olivocerebellar, they are climbing fiber, and rest all are mossy. Most are mossy. Most are mossy. Mossy most hai. Most of the fibers are mossy fibers except olivo and para-olivocerebellar. Olivo और para-olivocerebellar tract को छोड़ दो, बाकी any tract which is coming inside the cerebellum, आपने नाम सुना हो या ना सुना हो, whatever tract is that here, they are all mossy fibers here. The dorsal spinocerebellar, cuneo-cerebellar, pontocerebellar, vestibulocerebellar, reticular, whatever it is, they're all mossy fiber except olivo and para-olivocerebellar. Please don't talk about anyone, guys. It's just let's stick to our part. हमारा काम है यहाँ पे just revise करना and just go back home and revise the stuff. Forget about anything else. किसी और के बारे में किसी और platform के बारे में बात नहीं करते. Everyone is doing a great job. So with all due respect to everyone, just please don't say anything to anyone. Okay. Now guys, after the cerebellar cortex, now let me show you the histological image of the cerebellar cortex, which is like being shown over and over again here. That's a very low magnification here. The arbor vitae, that's how the cerebellar cortex slide will look like. आपको 3 color shade दिखाई देंगे उसके अंदर. You can see the white matter inside. You will see the gray matter there. gray matter में granular layer will be seen, and then you will see the molecular layer, the outermost layer, the molecular layer is very lightly stained because we have very less cell inside that. If I show you a little more magnification of that, if I just magnify that part, that's how it's going to look like here. Let's see that. That's a white matter layer in between here, and that's a cortex. If this is a cortex here, that's a granular layer obviously, and that's a molecular layer. The number of cells of molecular layer is less, and you can see the number of cells. That's why we call it a granular layer. It's completely granular in appearance, you can see. And at the junction of the granular layer and the molecular layer, we have Purkinje cells. Now Purkinje cells इसमें बहुत अच्छे से नहीं दिख रहे हैं. So let me give you even more enlarged image of that section here. That's how the Purkinje cell will look like, guys. You can see the Purkinje cells over there. The Purkinje cell dendrites, obviously they are seen spanning into the molecular layer, and axon of the Purkinje cell will be going out of the cortex. In fact, out of the 5 types of cells present inside the cerebellar cortex, the only cell which is forming the efferent from the cortex, and mind it, only cell efferent from the cortex, सिर्फ cortex से बाहर आ रहा है, cerebellum से बाहर नहीं, that is Purkinje cell. Purkinje cells are the only cells forming the efferent from the cortex. And don't misread this information. Purkinje cells are forming the efferent from the cortex, means they're just coming out of the cortex, that is coming out of the gray matter to the white matter only. And what is there in the white matter? The moment Purkinje cell will come into the white matter, we have the deep cerebellar nuclei there, the dentate, the emboliform, vestigial, mainly the dentate nucleus, which is the nucleus of neocerebellum is there. So deep cerebellar nuclei, they will come to the deep cerebellar nuclei, mainly the dentate nucleus. And it's the responsibility of the dentate nucleus to give the feedback to the cerebrum, guys. Dentate nucleus से efferent निकलेंगे, which will come out of the cerebellum, and they are the one which will give the feedback to the cerebrum so that any changes which are to be done will be done to coordinate the movement here. And that's why the efferent from cerebellum will come from the deep cerebellar nuclei. So Purkinje cell का जोर किस पे चलता है? Purkinje cell will basically inhibit. They are inhibitory neuron, the deep cerebellar nuclei. Deep cerebellar nuclei are the one which will form the efferent from the cerebellum. They will form the efferent from the cerebellum. Oh God. Peduncles. Now when you look at the peduncles, guys, the superior cerebellar peduncle, the middle cerebellar peduncle, the inferior cerebellar peduncle, the 3 peduncles over there, the 3 peduncles over there. Now let's first get oriented to this image. Now this is a cerebrum over there, that's a brainstem. That triangle over there is a thalamus. Let's say there's a thalamus there, and you can see obviously the brainstem is connected to the cerebellum by 3 cerebellar peduncle. Now guys, let's keep this discussion purely based on the PG में exam. If I would have been discussing this topic with the first day, तो मैं थोड़ा और डिटेल में जाता है इसका. देखो, out of the 3 cerebellar peduncle, if we just do the 2 peduncles, हमारा काम हो जाएगा. MCQ we can solve. You have to remember 2 peduncles out of the 3. Middle cerebellar peduncle is the one which is basically allowing one tract to come inside, one major tract coming inside, and that is called as a cortico-pontocerebellar tract, guys. Cortico-pontocerebellar. The tract is coming from cortex, then obviously to the pons, and then from pons it is coming into the cerebellum. We call it a cortico-pontocerebellar, and this cortico-pontocerebellar is the copy of corticospinal tract. Whatever corticospinal tract is doing, whatever cerebrum is doing, one copy of the corticospinal tract is also sent to the cerebellum, and that is called as a cortico-pontocerebellar tract. Cortico-pontocerebellar tract, and that is the only major afferent present inside. That's the only major afferent present inside, and that's why cortico-pontocerebellar tract, guys, it tells you that middle cerebellar peduncle is purely afferent. बाहर कुछ जाता नहीं इससे. This peduncle is only allow the tract to come inside. Cerebellum से बाहर कुछ नहीं जाएगा इससे से. So it's the largest peduncle, and it is the purely afferent peduncle. Middle cerebellar peduncle is the largest peduncle and purely afferent. Nothing goes out of it. Superior cerebellar peduncle. Now one of the tract entering inside through the superior cerebellar peduncle is a ventral spinocerebellar tract. I'm least bothered about that. But the main tract I'm really concerned about is this one, the one which is coming from the dentate nucleus. One of the deep cerebellar nuclei, dentate nucleus. Now it's the responsibility of the dentate nucleus to give the feedback toward the cerebrum here. So that is dentato something. Now dentato what, guys? Nothing can reach the cerebrum directly. You have to go to the thalamus first here. So we have a dentato thalamic tract which will go into the ventrolateral nucleus of thalamus, and some are dentato rubrothalamic tract going through the red nucleus also. Dentato rubrothalamic tract, and then obviously they will be projected into the motor cortex as well. So the feedback coming from the cerebellum will come from the dentate nucleus. The tract is called as dentato-thalamic and dentato-rubrothalamic here. So suggestively, if you remember the dentato-thalamic and dentato-rubrothalamic tract and ventral spinocerebellar tract, these couple of tracts from the superior peduncle, one major tract from inferior peduncle, well, I would suggest you, for the MCQ point of view, forget about the inferior peduncle, guys. भूल जाओ. Inferior peduncle is giving passage to so many tracts that you don't have to remember it here. If you know the major tract coming from superior peduncle and middle peduncle, then obviously everything else is from inferior peduncle. जिसका नाम ही ना सुनाओ कभी समझ जाओ inferior peduncle के अंदर है. Most of them, if not all of them, obviously there are some variations in that as well. But this is the kind of risk worth taking. The 3 major tract from superior peduncle, 1 main tract from middle peduncle, and rest everything is from inferior peduncle, and still you will be able to solve your questions. अब मुझे नहीं पढ़ रहे मैसेज. Abdominal wall and perineum, guys. Now, as I said, the demand for the topics will never end. So, abdominal wall में कुछ ज़्यादा कुछ नहीं. I'm just talking about the internal iliac artery branches and some modification of inguinal ligament. Perineum obviously is very important. Definitely get a question from that here. Now, this is what my plan is for the day. So, I think I'll probably take on the maximum half an hour to finish it off. As I said before I finish off the session, I'll tell you this in the beginning only. देखो एक छोटा सा एक और चीज़ which I have planned for you. I have planned one more small session here. Not now. Actually, this will be like 7-8 days before the exam only, and there's a reason for that here. And that session is basically for something which are very volatile here. I will not take that session more than 20 minutes. It's just a 20-minute session. I know उस time पे वो 20 minutes भी बहुत कीमती होंगे. In that 20 minutes, I'll be just talking about some histology slides. Histo is something, even if I discuss the histo with you right now here, you'll forget it here. Because by the time, again, you'll keep on revising so many subjects, by the time your revision will come, आपको दोबारा पढ़नी पड़ेंगे यहाँ पे. I will not take more than 20 minutes. It's a session which is called as the 20 minutes, 20 slides. I'll be showing you 20 slides in 20 minutes, and I'll tell you the one peculiar feature of every slide. The moment you look at that thing, you'll identify, okay, this slide is this here. So that is what we have to do in the NEET exam. It's all about the identification of general histology. So, but that session I will take like a week before the exam only. अभी उसको कोई point नहीं करने का. That's a waste of time. I'll tell you seriously. चलो, get back to the topic in there. Okay. Inguinal ligament, guys. Inguinal ligament, because there are some questions which I have seen in the previous year exam that is about the inguinal ligament. Now, inguinal ligament, which is also called as a Paupart's ligament, it is a modification of external oblique aponeurosis. It is a modification of external oblique aponeurosis. Now, inguinal ligament attaches between the anterior superior iliac spine and pubic tubercle. ASI से pubic tubercle तक जाता है. We know lower fibers of external oblique aponeurosis, they upturns to form this inguinal ligament here. Now, what I want to discuss inguinal ligament is for the 3 modifications of inguinal ligament. Now, one of the modification of inguinal ligament will come from this inguinal ligament and will run along the superior ramus of pubis called as a pectineal ligament. These are modifications, guys. One is called as a pectineal ligament. इसको Cooper's ligament ही बोलते हैं. Then the very, very important modification of inguinal ligament, which is called as a lacunar ligament. Look at that lacunar ligament here, an important ligament because it forms a relation of the femoral ring. In femoral hernia surgery, you may have read about this. And then there is a ligament called as a reflected part of inguinal ligament, जो जाके linea alba पे attach होता है. The one which attaches to the linea alba, that is called as a reflected part of inguinal ligament. That's all I want to tell you here, that there are 3 modifications. Because these are modifications of inguinal ligament, so in a way they are modification of external oblique aponeurosis only. External oblique aponeurosis is having a superficial inguinal ring, 1 modification. Is forming inguinal ligament, 2 modification. And whatever modification of inguinal ligament we have, they are ultimately modification of external oblique aponeurosis only. So pectineal ligament running on the superior ramus of pubis, lacunar ligament, which is also called as a Gimbernat's ligament, which is basically forming a medial relation of femoral ring also, I told you. Pectineal ligament, I told you Cooper's ligament बोलते हैं इसको. Alternative name की जरूरत नहीं है, I'm just saying. And reflected part of inguinal ligament, they are all extensions. Now, internal iliac artery, guys, although ये topic थोड़ा रटने वाला है इसमें, can't help you much in this. Internal iliac artery, but for some reason they keep on asking the question on the internal iliac artery, that which of the following is a branch from anterior division, which of the following is a branch from posterior division. And recently in the INICET exam, again they asked this question here. Now, though honestly I'm not a very big fan of the mnemonics here, but there is one mnemonic which goes for the internal iliac artery, which says, I love going places using my very unnamed vehicle. I hate mnemonics actually. Sometimes mnemonics is more difficult than the branches itself. But let me just still try to go with that, because maybe at least major branches you can remember. When I say I love going places, well, I is iliolumbar artery. I'll explain that how to divide these arteries. Iliolumbar artery. L here is representing the artery called as a lateral sacral artery, and G is for gluteal artery. हालांकि 2 होती हैं gluteal artery, superior and inferior gluteal artery, will come to that. P is for the pudendal artery. U is for the umbilical artery, which will give rise to the vesicular also, umbilical artery. M is for the middle rectal artery. Superior rectal artery is a continuation of inferior mesenteric. This is middle rectal artery. We have a vesicular artery. Again, there are two vesicular arteries, superior vesicular, inferior vesicular. We're just saying vesicular artery here. We have an obturator artery. There is an obturator artery, and there is a uterine artery, guys. And then there is a vaginal artery. Very own. Okay, using my very own. O chhoot gaya mere mnemonic mein, I'm sorry. My very own unnamed vehicles here. O is obturator artery. Well, see, gluteal artery, there are two gluteal arteries, guys. We have a superior gluteal artery, inferior gluteal artery, and similarly, we have the two vesicular, two vesicular artery. We have a superior vesicular, inferior vesicular. Although females do not have inferior vesicular artery. Females में inferior vesicular artery नहीं होता. The job of inferior vesicular artery is done by vaginal artery only. Base of the bladder in female is supplied by the vaginal artery. They do not have inferior vesicular artery. But I've just used different colors over there. Iliolumbar artery, lateral sacral artery, and gluteal, superior gluteal artery, guys. These three are the branches from posterior division. आप इतना भी याद रख लोगे, आपका काम हो जाएगा. If you remember that branch from posterior division, then obviously everything else is from the anterior division only. So SIL branches, SIL, superior gluteal artery, iliolumbar artery, and lateral sacral artery. Just three branches are coming from posterior division, and rest all are coming from anterior division. Three branches from posterior division, and rest all are coming from the anterior division. Sara Tendulkar. Okay, the last topic for the day, and that is the perineum, guys. So I'll just need like last 15-20 minutes of yours. Once again, thank you for staying for so long. I know you all are sitting, आप लोग भी 8 बजे से बैठे हैं, and hats off to you guys. Hats off to you once again, because I've never seen the attendance maintained like this. So still around 7,000 people. Okay. People are still alive. Oh, that is wonderful. Okay, pelvic diaphragm, guys. Come on, last topic. Let's maintain the energy in this here. Pelvic diaphragm, guys. Perineum. Let's start with the pelvic diaphragm. The highest structure which is separating the pelvis and perineum is the pelvic diaphragm. Now, when I say pelvic diaphragm, look at this picture, guys. Now, that's a, let's say that you're looking at the hip bone and the sacrum and coccyx from below. Now, pelvic diaphragm basically is a combination of three muscles coming from three different parts of hip bone. Now, one is called as a pubococcygeus, coming from pubon, that is a pubococcygeus. Then we have a muscle called as a iliococcygeus, and then we have a ischiococcygeus, which is also simply called as a coccygeus. Pubococcygeus, iliococcygeus, and ischiococcygeus. Now, all these three muscles together are called as a pelvic diaphragm, guys. When you look at these three muscles together, are called as pelvic diaphragm. But out of these three muscles, it's the pubo and iliococcygeus muscle which are functionally important muscle, and not the ischiococcygeus. Ischiococcygeus, or simply called as coccygeus muscle, it is more useful in lower animals, the quadrupeds, for the movement of tail. Humans के अंदर इतना काम नहीं है इसका. It's the pubo and the iliococcygeus muscle which are important muscles, and they together are also referred as the levator ani, guys. So out of the three muscles forming the pelvic diaphragm, all three muscles are pelvic diaphragm, but pubo and iliococcygeus muscle, they are called as together called as a levator ani. So levator ani is a part of pelvic diaphragm only. Now, out of these three muscles, the innermost muscle here is what? Pubococcygeus. Now, let us consider this as a section of female perineum. मान लेते हैं female perineum का section है. So, there are three openings in there. You can see the opening of the urethra, vagina, and the rectum. And the muscle closest to all the three openings will obviously form the modification around these openings here. So, like around the urethra, you will see the extension of pubococcygeus. Around the vagina also, you will see that, and around the rectum as well. So these three muscles which are like surrounding these openings here, they're all modifications of pubococcygeus, called as pubourethralis, pubovaginalis, and then puborectalis. Pubo तो नाम में आएगा ही, obviously they are all modifications of pubococcygeus. So we got a pubourethralis, pubovaginalis, and puborectalis. And especially this puborectalis muscle is extremely important, because that is the one which is basically maintaining the anorectal angle, the muscle of continence. The muscle of continence is the name given to the puborectalis muscle, guys, that maintains the anorectal angle, called as a puborectalis. Okay. Oh, the attendance has increased to 1.8. Wonderful. क्या बात है. So guys, after the pelvic diaphragm, guys, when you go below the pelvic diaphragm, now there is another diaphragm present below the pelvic diaphragm, and that is urogenital diaphragm. Now, first of all, you need to consider this from the lithotic position. आप imagine करो, you're looking at me, and if I just lie down in the lithotic position, so this is my pelvic diaphragm here. Now, next to the pelvic diaphragm, there is another diaphragm present, but that diaphragm is present only in the urogenital triangle, only in here, and that's why the diaphragm is called as a urogenital diaphragm. Now, have a look at this picture, guys. Again, the same arrangement here. अब मान के चलो pelvic diaphragm is there is pelvic diaphragm, and below that, when I say below, हम बात कर रहे हैं below, that is inferior, that means more superficial. So more superficial or below the pelvic diaphragm, now there is another diaphragm called as a urogenital diaphragm. Now this urogenital diaphragm is basically made up of two layers. Now there is a superior layer of urogenital diaphragm, and this one is the inferior layer. So there is a layer above also, guys. I didn't show you, I'm not showing you that as of now. There is an inferior layer and there is a superior layer, and this is the inferior layer. जो नीचे से दिख रहा है आपको, the more superficial one is the inferior layer of urogenital diaphragm, which is also called as the perineal membrane. The inferior layer of urogenital diaphragm, which is also called as a perineal membrane. It is called as a perineal membrane. So we got a, if I imagine like this here, so I got a pelvic diaphragm first. Now below pelvic diaphragm there will be a superior layer of urogenital diaphragm, and then we have an inferior layer of urogenital diaphragm, which you're looking at right now in this position, in the lithotic position. There is an inferior layer of urogenital diaphragm called as perineal membrane. इसके भी नीचे क्या होगा? Further below that you will have a bulb. If let's say it's a section of male perineum, so there will be the bulb of the penis surrounding the muscle surrounding it, and the crus of the penis. The muscle which is surrounding the bulb of the penis are called as a bulbospongiosus, and the muscle surrounding the crus is coming from the ischium bone from the side here, that is called as the ischiocavernosus, guys. Bulbospongiosus and ischiocavernosus here. So bulb is covered with a bulbospongiosus, and there is a ischiocavernosus. There also is a muscle which is running transversely in the perineum, and because this muscle can be seen below the perineal membrane, आप इसको देख पा रहे हैं नीचे, it is below the perineal membrane, so it is a superficial transverse perineal muscle. This muscle is a superficial transverse perineal muscle. Now we also have the anal canal in this posterior triangle there, anal canal, and the anal canal is covered with a sphincter, and that is called as an external anal sphincter, guys. That sphincter here is called as an external anal sphincter here. That's the external anal sphincter. And look at this meeting point here, the junctional point here, where all these, majority of these muscles are converging here. That is called as a perineal body. That is called as a perineal body, guys. Perineal body is a fibromuscular node which is basically made up of the 10 muscles. Now what 10 muscles are forming the perineal body? First of all, just let's compare this picture here. First, pelvic diaphragm, देखो यार, all of you, please look at the screen, guys. That's a pelvic diaphragm. Below, नीचे आते हैं. Below pelvic diaphragm, there is urogenital diaphragm. And this one is the inferior layer of urogenital diaphragm, also called as perineal membrane. Bulb and bulbospongiosus, crus and ischiocavernosus, and this one is a superficial transverse perineal muscle. Superficial transverse perineal muscle here, right? External anal sphincter दिख रहा है आपको, that is an external anal sphincter, and that's the site for the perineal body. Perineal body. Now the question is that what muscles are contributing to the perineal body? बेटा PDF आज ही मिलेगा, definitely आज ही मिलेगा. I'll leave the studio only after I give you the PDF. Don't worry. Now, perineal body is made up of 10 muscles. Now, what are the 10 muscles in the perineal body, guys? We have 4 paired muscles and 2 unpaired muscle. Now, what are the 4 paired muscle, and what is a common mistake that people does here? The 4 paired muscle here is, one is a superficial transverse perineal muscle. Now, when there is a superficial transverse perineal muscle, there must be deep also. एक muscle और भी होता है उसके नीचे, उसके ऊपर I should say actually. That's a deep transverse perineal muscle. And even bulbospongiosus, that muscle is also a paired muscle, that is bulbospongiosus here. Now the fourth muscle you got to be very careful about is this one. Ischiocavernosus is not contributing to the perineal body. That's the mistake people does. Ischiocavernosus is not contributing to perineal body here. It's the levator ani, which is the fourth muscle there. So जब भी ये question पूछेंगे, remember that they will try to give the ischiocavernosus in that. Be careful with that. It's the levator ani muscle which is contributing to the perineal body here. So 4 paired muscle. Unpaired muscle, we have an external anal sphincter. One is the external anal sphincter, and we got the longitudinal muscle of anal canal. Any viscera you think of, there are longitudinal muscles also. So similarly, like anywhere else, we have some longitudinal muscle of rectum and anal canal, which are also contributing to this perineal body. So 4 paired muscle and 2 unpaired muscle. And one thing which I'm again warning you for, guys, just be careful with this one here. This muscle is not there in the perineal body. ये perineal body का part नहीं है. Not a part of perineal body. Now, if I take a sagittal section here, guys, we are like moving to the last 2-3 slides only. If I take a sagittal section, आप ऊपर से शुरू करते हैं. सबसे पहले क्या था? Pelvic diaphragm, guys. Now, let's say you have to consider a section like this. So you're taking a sagittal section of the perineum. So first thing is the pelvic diaphragm here. Let's say this is a pelvic diaphragm. Now below pelvic diaphragm we have a superior layer and then we have inferior layer of urogenital diaphragm जो आपस में fuse कर रहे हैं. The superior layer and the inferior layer of urogenital diaphragm. Pelvic diaphragm is there, superior layer of urogenital diaphragm and inferior layer of urogenital diaphragm जिसको हम perineal membrane ही बोलते हैं. That is also called as a perineal membrane. And because this is a mid-sagittal section, so let's say the section is going from the bulb and the shaft of the penis. It's a mid-sagittal section going from the bulb and the shaft of the penis. And here's the urethra, guys. यहाँ पर prostatic urethra होगा. Then we have a membranous urethra, and then we got a spongy urethra running through it. So that's the urethra running in, guys. That's the spongy urethra running in. Now, what about below? यहाँ पर नीचे क्या present है? Now, what is present below here is a fascia, the Colles fascia. But see where the Colles fascia actually came from. Anterior abdominal wall. There is no deep fascia on the anterior abdominal wall. We have the Camper's fascia and Scarpa's fascia, guys. Scarpa's fascia present on the anterior abdominal wall, and that Scarpa's fascia will continue in the scrotum in the form of the dartos muscle, and the same dartos muscle will continue in the perineum as the Colles fascia here. So that's a Scarpa's fascia continuing as dartos muscle, and dartos will continue as the Colles fascia, which is merging with the perineal membrane. And the moment this Colles fascia merges with the perineal membrane, now look at these two spaces, guys. Obviously, जो space ऊपर है, that is deep. This one is superficial. So that pouch over there is a deep perineal pouch, and this pouch below here is a superficial perineal pouch. जो ऊपर है वो deep है, the one which is below is superficial, deep perineal pouch and superficial perineal pouch. Okay, the one. What do you say, the drawback of the superficial perineal pouch is deep perineal pouch is closed. All the boundaries are there for the deep perineal pouch, though there are some like varied concept in the deep pouch here. But superficial perineal pouch is the one which is open in front. There is no anterior wall. Look at, there is no anterior wall of superficial perineal pouch. So it is open in front here. And that's where the question comes from. Extra vestige of urine. Now, if the injury is to this urethra, membranous urethra, the urine will spill in what pouch? In the deep perineal pouch. Look at that. If the membranous urethra is ruptured, the urine will spill in the deep perineal pouch here. But if the injury is to the spongy urethra in the bulb of penis, if the injury is to the spongy urethra in the bulb of penis, the urine will accumulate in the first, can go into the superficial perineal pouch. Because anterior wall is not there, it can go into the scrotum. And because the dartos layer is a continuation of the Scarpa's fascia, so it can go into the anterior abdominal wall also, and it can extend downward into the thigh also to an extent in the thigh till the Holden's line. सिर्फ upper part of thigh में बोल सकते हैं. So extra vestige of urine is seen more in case of the spongy urethra injury in the bulb of penis. The urine can come into the superficial pouch, into the scrotum, abdominal wall में भी जा सकता है, and it can go into the upper part of thigh as well. Upper part of thigh as well. And lastly, one fossa that we'll talk about, that is the ischiorectal fossa, guys, the space which is behind. Whatever we're discussing till now, our focus, if I just one for the orientation sake only, when you saw this picture, I'm sorry, I have to take you back here. Now, we are focusing on this triangle here. That is a urogenital triangle here. Now, let me take you to this triangle here that is called as an anal triangle. So, anal triangle, what we have in between, we have anal canal, and on the side we have ischium. Ischium and anal, ischio-anal fossa or ischiorectal fossa. So the fossa that you will see on the side is the ischiorectal fossa or ischio-anal fossa. Now, ischiorectal fossa, guys, if you look at this picture here, you can see the anal canal over there and the ischium on the side here. So that's why that fat over there is in the ischiorectal fossa. Now, if I just replicate that picture over there, now that's the anal canal. This is the skin of the gluteal region. Now what you see, the lateral wall of the ischiorectal fossa, can you see a muscle over there? That muscle which is forming the lateral wall of ischiorectal fossa, that muscle is called as the obturator internus. So let's say this line here is corresponding to the obturator internus muscle. Medial wall of ischiorectal fossa is by the sphincter. Look at that again, look at that image, guys. Can you see that external anal sphincter there? That's the external anal sphincter. And then look at that pelvic diaphragm. Or you can say levator ani is there. That is a levator ani or pelvic diaphragm, you can say. So that's the external anal sphincter, and this obliquely running is the levator ani. That is a levator ani. Now there are many fascias inside this ischiorectal fossa. This whole thing is a ischiorectal fossa. There are many fascias inside. I just don't have to bother you with every fascia there. Now there's one main fascia which is present inside the obturator internus muscle is called as the obturator fascia. And this obturator fascia mainly contributes in the formation of this canal present on the lateral side called as a pudendal canal, guys. There is a canal, उस picture में तो नहीं दिखेगा. There is a canal which is present on the lateral side of the ischiorectal fossa, which is called as the pudendal canal. Now, pudendal canal is mainly contributed by which fascia only? Obturator fascia is the main fascia which forms the pudendal canal here. The purpose of pudendal canal is basically to take the structure safely in the ischiorectal fossa. The pin structures PIN, those pin structures can travel through this here and they can safely reach the anterior part of the perineum here. So the content of pudendal canal, guys, Alcock's canal or pudendal canal is the pudendal nerve and internal pudendal vessel. N is nerve to obturator internus, वो तो मसल को बाहरी सप्लाई कर देगा. So P and I, pudendal nerve and internal pudendal vessels are the one which are running through this pudendal canal or Alcock's canal here. Now, so if you look at the contents of ictiorectal fossa, overall, what are the contents of ictiorectal fossa? Has to be the fat. Now the contents of ictiorectal fossa is definitely the fat. Okay. Pudendal canal and its content, what is there in the pudendal canal, guys? Pudendal nerve is there, internal pudendal vessel is there, and the next content is the one on which the clinical question is asked. See what content is that, guys. Now once again, look at this picture here. What we discussed earlier was this triangle, the urogenital. Now we are looking at this triangle, guys. Now pudendal canal is present on the lateral side. It's just a very schematic presentation. ये technically ठीक भी नहीं है. Now let's say the pudendal canal is there, although it is actually toward the lateral wall. That's the pudendal canal. I'm just trying to show it is outside. Now this pudendal canal is basically giving passage to the pudendal nerve and internal pudendal vessel so that they can safely go into the perineum in front, into the urogenital triangle in front. Now the thing is, if there is an abscess in the ictiorectal, if there is any abscess in the ictiorectal fossa here, you can easily put the incision in this ictiorectal fossa and can drain the abscess here. And these structures are quite safe because they are very much on the side here. Except the couple of structures which will pierce the pudendal canal and will run transversely. Inferior rectal nerve and inferior rectal vessels are the structures which are running in the ictiorectal fossa transversely, and that's why they are most commonly injured in the drainage of ischiorectal fossa abscess. They are the one which are most commonly injured in the ischiorectal fossa abscess. इसको ischiorectal fossa बोलते हैं बेटा, इसको ischioanal fossa बोलते हैं. It's the same thing only. Don't worry about that. So inferior rectal nerves and vessels, they can be injured in the drainage of ischiorectal fossa abscess. And that's it for this session. Okay, that was a long one, right? But don't worry, I'm going to come to you once again. I'm going to bother you once again, but I'll not bother you for more than 20 minutes. That session which I have planned, it's the so-called 20 minutes, 20 slide session. That session will be kept like just 1 week before the exam. The time will be very precise. You can come and you can come live. You can watch on your will. That video will be there in eGurukul as well as in my. This video also will be there in this channel also, and will be posted in my YouTube channel as well. And as I said, all these soft copies I'll share with you just immediately. I'll just quickly post the soft copy in your group here, DBMCA Premier Group, guys, or in the Telegram you can just easily find my group, that is Anatomy by Dr. Ashwini Kumar. You'll find that group. You can. I'll give a copy of the slide to Dr. Praveen also, to Dr. Jay also, so they can post that in their respective group as well. So you can download it from anywhere you can. So thank you so much, guys, for listening. Thank you so much for being there for 4 hours. By God, it's 4 hours. Still maintaining the attendance of 1.7. Like really awesome, guys. Thank you so much. And I want to end this one by saying one thing here, that in saying that someone who truly loves you, sees what a mess you can be, how moody you can get, and how hard you can be to handle, but still wants you. Well, this is not your girlfriend or boyfriend saying to you. Actually, this is what you are saying to your dream seat here. Basically, this is what you are saying to your PG seat here. No matter how much that the PG preparation is giving you the trouble, how much messy it gets, how much stress it is giving to you, it is getting hard to handle it here. But you know that you want it here. तो करना है तो करना है, guys. No matter how many motivation, from where you get the motivation from, where you you get the energy to get up and get going here. लेकिन फाइनल पॉइंट ये है कि भाई साहब पढ़ना तो पड़ेगा. Doesn't matter. So पढ़ना तो पड़ेगा. Don't give up. Just keep working. This a little hard work that you putting in every day is needed for it. You attended this 4-hour session today is a part of that process only here. So keep following the process that you are into here. Just keep going with that. Don't live in any kind of FOMO. Follow the previous year questions, guys, and I'll also keep posting questions in my group as well, and in the different platforms here, which are the relevant questions for you people. And well, keep grinding. So thank you so much, and I will see you again just before your exam for a very short session on the histology as well. Thank you, guys, and all the very best.